is not a great showing.
Yeah.
All right, usually we have double as many points. So listen clearly. The reason he's asking you guys these questions, whether they're group questions or individual questions, right? It's because you need to know the answers. So, if you don't know the answers, even if we're not asking you the question, do you need to listen to the right answer and get it down?
Yes!
Because he's asking you these questions for a reason. Right?
Yep.
So, same thing again tonight. Right? We're going to go through your pediatrics. We're going to go through all your environmental emergencies and all your trauma. No. Should you, as an EMT, be able to recognize all your specific types of trauma and know their treatment?
Yes!
Would there be any reason for you not to be able to recognize all your specific types of trauma and know their treatment?
No!
Would there be any reason?
No!
I
I might have severe amnesia.
would there be any reason?
No! No!
Silly class. All right, guys, so... Okay. So, guys, was there anything, pretty important lecture last night, all your medical emergencies, all your human body, and your OB, was there anything that you had a question about from last night's lecture? You, sir, in the second row.
I didn't know. You looked at it, I was like, how often will we arrive? So, say someone gets appendicitis. How often will we arrive before their appendix bursts?
Huh?
What? So, because you said that yesterday with appendicitis, they feel a really sharp pain, and then it blows up, and then it can cause peritonitis later on from the rupture. How often will we arrive on scene before it explodes and puts all that stuff into the potential?
What are you looking at?
I have something in my eye.
Okay.
Get a con-tip swab.
Wow.
Tilt.
Actually, no,
because they can't
not
see it off
if
their
it's
eye.
in the eye.
It's gotta be on the inside.
That would be the eye low. That'd be the eyelid, not the globe of the eye. You'll scratch the damn retina that way. All right. So, how many? Yeah, it's just gonna depend. I mean, people are pretty, but that's not the indication. You know that, right? Somebody just complaining of right lower quadrant pain.
No, it's not. Yeah.
What would they also have if they were complaining of? If you thought it was appendicitis, what would they also have?
Well, they would start getting feverish signs.
Right. They'd be flush and feverish. I always say, if you have a male who's flush and feverish and has right lower quadrant pain, it's what?
Appendicitis.
Yeah. Why did I say a male? Because it's much more definitive that way.
Yeah.
Females, it could be something else, even though we're thinking it's appendicitis, right? But it could be something else, right? But males, ain't gonna be nothing else. That's what it's gonna be. Got it? So the answer is they would be complaining of pain that actually went away. That's what would happen, because you get there and they're like, oh yeah, I have really, really bad pain in my right here in my lower right quadrant, right? And then, but it just went away. That's a good thing, right? No, what happened? Yeah, burst open. Yeah. So how often does it happen? I don't know. How dumbass are people? I don't know.
I'm very.
People will endure a lot of shit before they go to the friggin' hospital.
That's true.
Especially over the last couple of years, right? And especially, when you get a little older, you don't want to go. You rub some dirt on it, walk it off. Young people, they don't think anything's. Rub some dirt on it, walk it off. I'm fine.
I'm invincible.
Any other questions? Actual questions about identifying anything, any particular medical emergency that you? Because look, guys, just like I told my morning class, in this class, we told you exactly how to identify. The reason we gave you specifics about what was different, what's unique, is because that's what you're going to be looking for in the question to answer a damn question. That's it. So we don't just teach you about your illnesses and injuries. We don't just give you the signs and symptoms. We actually will literally say, right, see this one, that's what they're going to give you. That's what's going to tell you what it is. Right? That's the stuff you're supposed to be able to get down. And if it's more than one thing, you need to know what?
The difference is.
No. If it's more than one thing that's going to tell you what it is, you need to know what? You need to know all of them. Right? You know all of them. Right? Because, guys, they will use the one they know you don't remember. No, they do it every time. Right? They'll definitely use the one. All right? If they're talking about the Glasgow Coma Scale and a patient's doing this, you know they got what?
3.
They got what?
Decorticate.
But it's also known as what?
Flexion.
Right? If they're doing this, it's what?
Decerbate.
Also known as what?
Extension.
Yeah. Which one do you think they're going to give you if they ask you a question?
Decerbate.
You bet. Because they know. Lowest common denominator. I'm not going to learn that. Like, if they ask you about history EMS. Oh, fuck is right. History EMS. It's part of your intro. What big-ass report, right, actually friggin'... No.
PCR?
Oh, yeah, see?
PCR?
Lowest common denominator. What? Y'all know the slang for it, but they're not going to use that. They're going to use the actual name of the report.
Patient care. Oh, well, he
No,
said that.
fuck, you didn't listen. You didn't even listen. I told you. It was a governmental report that literally spurred on all EMS. The reason we are here today, right, is because of this report, right? And if you think they couldn't ask you about history EMS, you're wrong, right? The report had a name. Lowest common denominator is what you do. Most of you guys remember the slang for it. It's called the what?
White papers.
But nobody remembers what it's called, do you? None of your asses. And that's what I mean. You guys do this shit. No. What do you do? No. What do you do?
What is that?
You turn your back on the... Did you really think they were going to use the white papers? No. Hell, anybody remember when it came out? Really? Just moseying on in anytime you want, huh? Moseying. Lollygagging around the infield. You know what that makes you? Lollygaggers.
Try. Oh, wait.
Does anybody know what that's from? Nobody knows what they're from? Boulder. Yeah, and yes, you have...
Trash.
You might have to take it out pretty soon, too. So, nobody knows what those are called, though. Nobody?
Can get my notes.
Does anybody know when it came out? The white papers, what year? Because the guys, the thing that spurred on all of EMS came out in the same damn year. We just didn't have money for it until later on.
No, definitely 19.
What?
1900 for sure.
Fuck, dude.
We had
seriously?
By then.
So basically, you decided to take that intro shit and just throw it out the goddamn window, and they can't ask you about that. So what's it called? Accidental deaths and disability neglect in the modern society.
Damn.
Yeah, that's tough. Yeah, because it's so long, it's much easier to just be white papers. What year did it come out?
1966.
The Highway Safety Act came out in the same year. It said, we're going to do, this is why you're here today, guys. It was the Highway Safety Act. The problem is they didn't have funding until, anybody know? 73. Yeah, 73. So, I know. Things happen before you were born. So, right, guys, don't forget the shit we already taught you. Don't do that.
What is it called?
How's it going?
Accidental death and neglect.
There couldn't have been that many people today. It's a pain in the ass. Awesome. Michael loved that. All right, guys. So, my question to you, as it is every day, is... Are you ready? Are you ready?
Yes!
Alright, guys. So, enjoy your last lecture day.
Oh.
Hi, Bourbon.
The one, the only,
Bourbon.
Mr. Vincent Conte. And Bourbon. Hi, buddy. Hi.
Do we look like stuffed animals?
Alright, enjoy.
What happened to your getup?
Just think, a week from now, you'll be sucking down lobster.
I'll be on the plane and stuff now.
Oh.
Alcohol and then.
And then lobster.
Memos.
Alcohol lobster.
Will you stop right here?
All right.
We're grouping up now. Teaming up.
They're grouping up.
No, she doesn't want to be.
Shit, hey, she's got trash tonight.
Okay.
And we got a lot of trash. Come on,
You don't have to match us? You thought we were like doing
We got bourbon.
You had that, right? You didn't get that.
Your Bourbon knows all the answers. And he's very tight-lipped.
Who's Hanson?
I did not
Doesn't say a
buy
lot.
one for today, promise.
You need help?
Yes, that's what I did.
Alright, you're not.
He's like, what are you wearing?
I know, he's looking at me like I'm a tutor or anything. Eat those.
A giant,
Giant tutor.
a giant chew toy.
Come on, buddy.
A giant dog. You get a giant chew toy. He's like, I'm gonna stop here and get pet for a second.
Right in front of the lady.
Always.
Yeah, always in front of the lady.
He always
Can't have
likes
him around.
stopping in front of me.
He knows you're allergic.
I think so.
Come on.
That was like a horse move.
Alright guys, so we're going to go ahead and go through our trauma review. Okay, so we're going to start out with a shock review. Okay, then go over all the trauma stuff. Alright, and then go over immunology, environmental, and pediatrics. Alright, so kind of doing the same thing as we did yesterday, right? So still going over the game, right? Now, like I said, tonight we are going to have team-based questions. Okay, so with those team-based questions, right, it is the captain, okay, who is going to provide the answer, who has the power to either go with it or veto and override and give their own answer. Okay, with those team-based questions, the whole team is allowed to deliberate, right, and then again, the captain is going to say, yeah, going with it, or no, I'm going to do this instead. Okay. All right. So as far as shock, of course, we have to know what the definition of shock actually is. So, Chris, what is the definition of shock?
Widespread inadequate tissue fusion.
Okay, that can be caused by what types of problems?
Obstructive problem. Obstructive shock.
Well, it's one type of shock, sure, but what kind of problem is it?
Pipe, fluid, or pump pipe fluid problem.
Right, pump pipe or fluid problems. Okay. Now, if our patient were to have a pipe problem, what kind of shock would that be?
Pipe problem would be distributive shock,
Okay. And what is one type of distributive shock?
anaphylaxis,
Okay. And what would I see on a patient who has anaphylactic shock?
urticaria, hives, it, they'd be hot flush, dry, and bronchospasm.
Okay. So, Ramon, what skin signs would they have with anaphylaxis?
They'd have warm, normal skin signs. Or sorry, coloration is normal, and their skin would be flushed. Flushed, warm, and warm, flushed, and clammy.
warm, flush, and dry.
Right. And with bronchospasm, what lung sound would you hear? And what would we do to treat that patient who's in anaphylactic shock? What does that do to the body?
Vasodilates and bronchial constricts.
Daisy, what does epi do to the body? What does epi do to the body? Right. It constricts the blood vessels, opens up the airway, because in anaphylactic shock, the patient has vasodilation and bronchospasm. Okay? Now, as far as another kind of distributive shock, Axel, what's another kind of distributive shock?
Neurogenic shock.
Okay, what's that caused by?
Spinal damage. The spinal damage got cut off.
Okay. So how can we identify a patient who's in neurogenic shock?
They usually have two-tone signs. So where the spine got cut off, the top of the body would be flush, high and diaphoretic, and the bottom would be, it would start like that and it wouldn't go to cool, flush, no, cool, pale, and diaphoretic.
So what's it going to start as above the injury?
What do you mean?
Above the injury, what skin signs would they have?
Hot, flush, and diaphoretic.
Erica, what skin signs would they have above the injury for neurogenic shock?
Above would be symptomatic, so it would be flush, diaphoretic.
Darj, what skin signs would they have above the injury?
Cool, pale, and diaphoretic.
Why?
Shock. The body is losing.
Why are they going to be pale with diaphoretic above the injury?
Because they're in shock.
Not necessarily, because a patient who's in anaphylactic shock is in shock, but they're not pale with diaphoretic.
I'm not sure.
Because they can still communicate with the brainstem.
Right. Okay, whereas below the injury they would be.
There'll be warm, flush, and dry, and eventually go cold.
Okay, why would they be dry below the injury?
Because the brainstem can't tell the rest of the body below the injury to go into sympathetic, so they're in parasympathetic.
Okay.
So it defaults that.
Okay, but again, what allows them to actually sweat?
What allows it? Brainstem.
So the brain has to tell the body to sweat, right? So because it can't, that's why they're dry. Now, as far as the treatment for neurogenic shock, what do we have to do to treat it?
Isn't it just supportive treatment with oxygen?
Okay.
And then just you put a C-collar and try not to move the spine as much.
And that's it?
Or with high flow too, you just transfer down to the
That's all we do for them. What else?
High flow to blanket, supine position, backboard.
Right. Okay, we've got to put them on a backboard and still cover them with a blanket. Okay, now as far as the nerve that allows them to still activate that parasympathetic response, what nerve?
The vagus.
Okay, which acts as a... Actually, let me rephrase it. What would stimulate the vagus nerve?
The brain.
What stimulates the vagus nerve?
Pressure of the baroreceptors.
Right. Okay, so pressure. So what are things that somebody can do to trigger their vagus nerve?
Either gagging or
Right. Okay. So gagging or bearing down is going to trigger that vagus nerve, right? Therefore, activating this parasympathetic response. And since the only nerve that can actually communicate past the injury, because it comes out of the brain, that's why we see those different skin signs below the injury. Okay. Ramon, or actually, Mr. Fox, what is another distributive shock?
Septic shock.
What is that caused by?
That's caused by widespread infection all over the body.
Okay. So what are we going to see in the case of a patient who's got septic shock?
Well, they're gonna have fever, skin signs, so hot, flush, diaphoretic.
Okay. And how could I tell the patient's in septic shock versus an infection like, I don't know, peritonitis?
So if the patient had peritonitis, they would have a rigid distended abdomen, pain in all 4 quadrants, and they would have the same signs. But but they're still not in a state of shock. So once the infection spreads throughout the body starts trying to compensate for it like it would in a state of shock.
Okay. But how would I know the difference between a patient who's got just regular plain old peritonitis versus a patient who's gone septic because of peritonitis?
Once you see in their vitals, like their heart would go up, their blood pressure would probably shoot up more because it's trying to get rid of all the nasty stuff inside of it. So the blood pressure would go up and the heart rate would go up. And maybe the respiratory would change a little bit as well.
How so?
So because heart rate's going up and blood pressure's going up, or no, that's actually wrong. Blood pressure's going up, so heart rate's going to go down. So the respiratory rate's going to go up to try and get more air inside of it.
Chris? How are we going to tell the difference between a patient who's gotten septic because of peritonitis versus somebody who just has peritonitis?
With peritonitis, they'll just have their just abdomen fever signs. Septic shock is more widespread, so they'll have be hypotensive and have an ALOC.
Right. Okay, so they're going to be hypotensive with, right, an ALOC. Okay, whereas their vital signs, right, for the most part, are still going to go up. Okay, they're going to have tachycardia, right, all the other kind of stuff. Right. Now, as far as the other kind of distributive shock, what's the other kind of distributive shock?
The other kind would be, so we said neurogenic, anaphylaxis. Wait, yeah, we did. We said anaphylaxis. Septic, and then psychogenic.
Okay.
Psychogenic is triggered by onset of a syncope, and that one is only distinguished as a person in shock once they wake up from the syncope. I'm gonna look at these flashcards. And they could occur from possible stroke or brain aneurysm. Involving a problem to their spine because they potentially fell down and injured themselves when they fainted.
So psychogenic shock is caused by syncope?
No, it would be a potential cause to the psychogenic shock, then I would suppose.
So then you're saying the same thing. Syncope will cause psychogenic shock.
Syncope will. I don't understand this one that well to tell you.
So what is psychogenic shock?
Fainting or syncope caused by fear, bad news, or unpleasant sights, rate of blood, and it's going to be a temporary generalized vasodilation.
Okay. So what are some serious causes of psychogenic shock?
Watching a loved one die.
Daisy? What are some serious causes of psychogenic shock?
Hearing like very extreme news, say syndrome. Extreme causes
Yeah.
of psychogenic shock.
Yeah.
An aneurysm
Where?
in the brain.
Causing what kind of stroke?
Ischemic.
Causing what kind of stroke? They have an aneurysm in the brain that ruptures.
Oh, hemorrhagic.
Right. Okay, what else can be a serious cause of psychogenic shock?
Oh.
Anything that dilates the blood vessels in the brain. If you have a head on what you're using, that'd be something.
George?
The question is what can cause psychogenic shock?
What's another serious cause of psychogenic shock?
We already said fear, bad news, or unpleasant sight.
Which are not serious causes.
The patient is suffering from another life-threatening episode. Do you have any
Such as?
say they're having severe shortness of breath, or
Mhm.
even
No.
Irregular heartbeat.
Caused by what rhythm?
Caused by what?
Caused by what rhythm? That's not going to cause death immediately. George? AFib, right? What complication can we see with AFib?
hypotension.
Okay, but as far as brain problem,
The brain cells start dying.
because.
There's no oxygen. There's no blood flow going up there.
But again, what other complication can arise from a patient who's got AFib that's going to affect their brain besides just hypotension and lack of
Stroke.
perfusion? What kind of stroke?
Non-hemorrhagic. Hypovolemic shock. No?
What kind of stroke?
Ischemic stroke.
Right. Okay. Because yeah, exactly. A blood clot that's going to break loose, travel around, and potentially get stuck in the brain. Okay. So with our distributive shocks, we have that mnemonic of SNAP. What mnemonic?
Snap.
SNAP. Septic, neurogenic, anaphylactic, psychogenic. Okay. Now, as far as our pump problems, okay, Nana, what is one of our pump problems as far as shock is concerned?
Obstructive shock.
What are the three primary causes of obstructive shock?
Cardiac tamponade,
Okay. And when it comes to cardiac tamponade, what signs are we going to see to indicate that?
you're going to see extra so hypotension and obstructive JVD and muffled heart tones.
Why do we see those signs?
Because the cardiac tamponade, you're going to get fluid around the heart, and so you're going to hear the muffled heart tones because there's fluid, so you're not going to hear it as clearly. You're going to get JVD because you're going to have, it's a right-sided heart problem, so you're going to get an obstruction. It's going to cause backup to your superior communicator, which is going to cause a JVD. And then you're going to get systolic hypotension. The heart's not filling. The hearts aren't filling as with as much blood as they can, so it's not going to be pushing out a lot of blood. You're still causing hypertension.
Okay. So what's that term that we use for the amount of blood that comes out of the heart per contraction? Okay, and what is cardiac output?
Is stroke volume times heart rate.
That's the formula, but what is cardiac output?
Cardiac output is the amount of blood that's getting pumped in a minute.
Okay, so as far as cardiac tamponade, it's only a right-sided heart problem?
No, it can be a left-sided problem.
Okay, so as far as treatment, how would one treat cardiac tamponade?
High flow to high flow to
Okay,
and you have to increase the cardiac output, but so surgery fix it.
okay, but what can we do about it?
Um, nothing. And just stay on oxygen.
And that's it? Ramon?
High flow to supportive treatment for shock. Supportive treatments for shock. We can't obviously solve the problem, but we could potentially put the patient in shock position.
Okay.
Then we're giving them the blanket, and it has to be a code 3 transport because it's a critical patient. Another thing we could possibly do is use my best guess would be to use some sort of positive pressure ventilation in hopes to well, it's not in the lungs, it's not in the edema. I don't think that would be a good idea. Cardiac tamponade. I would say just CPAP with an armor breather to yeah, that's what I'm gonna stand as. I don't know if that's right or wrong though.
What are we gonna do?
Treat for shock at your hospital. So high flow to blanket, put in shock position, code
Yeah.
3.
That's it. Okay, you should have stopped right there.
And then
Okay.
just a quick question. We can't use CPAP because it's fluid filling the pericardial sac, not the heart itself, right?
Correct.
Okay.
Right, and as far as blood going into the lungs, right, we're having a backup on the right side because the heart can't fill up, therefore causing backup.
Right.
Because there's not a lot of blood going in, there's not much going out, so there's no backup to the lungs.
Right.
Okay, so we end up getting clear lung sounds.
That's it, everybody.
All right. Now, as far as another type of obstructive shock, okay, what's another kind of obstructive shock besides cardiac tamponade? are the possible causes of pulmonary embolism due to blood clots? What's the mnemonic we use? Which stands for? There's a word in the middle of that. Okay.
Recent surgery, long bone fractures.
Okay. What about if it gets caused by an air bubble? What can cause an air bubble to get stuck in the lungs? Gets stuck in the lungs. Right? What can cause an air bubble to get stuck in the lungs?
I know, but I don't know. Is it a catheter shear?
Well, it's not an air bubble. It's
Not an air.
foreign body.
Yeah.
So what can get an air bubble stuck in there?
Some sort of pressure problems. That
Like?
makes sense.
Like?
Like the vents.
Erica?
Jugular vein laceration.
Okay. And?
When you ascend
Yeah.
into that well,
Okay. So what does that diver have to do? Or not do, rather?
don't suck into your balls, not go too fast.
George? Archie, Axel, sorry.
Can you repeat the question?
What does the diver have to do to get an air embolism?
Don't.
Hold their breath when they're ascending.
Okay. And do they take their breath above surface, go down, and then come back, or would take the breath underwater and then ascend?
Underwater and then ascend.
Right. Okay, now as far as a jugular vein laceration, how do we treat it?
You patch it up and then you tape it to like a figure 8.
Well, what do we patch it up with?
An occlusive dressing. Sterile occlusive dressing.
Yeah, they're all sterile.
And you would tape it down 4 sides.
Right. Why on 4 sides?
Why on 4 sides? So no air can go in.
Okay. What other injuries would I use an occlusive dressing on?
Pneumothorax. Pneumothorax.
Would be a second chest wound?
Oh.
This is in jeopardy, sir.
Okay, a second chest wound?
Okay. Taped on how many sides?
On 3 sides.
Why do I want it 3 sides?
You want the gravity side open so it doesn't build up like pressure inside and has it could like breathe.
Well, it's not why I leave the gravity side open. I leave the gravity side open for one other reason. But as far as 3 sides, why do I tape it down to 3 sides instead of 4?
So it doesn't build up pressure.
Okay. Creating what kind of valve?
Valve.
Yeah. What type of valve is that if we tape it down to 3 sides?
You said what valve has 3 sides, right?
No, what kind of valve are we creating by taping it down on 3 sides?
Oh. The lever valve.
Okay. So as far as the gravity side, why do I leave the gravity side open?
So that if it bleeds, it won't like get separated. It will come down.
Okay. What other injury do we use an occlusive dressing on?
Would it be when their insides are out?
What do we call that?
Evisceration.
Okay. And how do we treat it?
You put the big occlusive, the multi-trauma occlusive. You have to like sterile it first. and
Well, no, it's already sterile in the package.
You have to grab the insides and like place it on them.
What kind of dressing do we use first?
It's not called multi-trauma occlusives?
George?
The multi-trauma dressing.
Right. Just a multi-trauma dressing that we soak with what kind of fluid?
Say that one more time.
What kind of fluid do I soak that multi-trauma dressing with?
Saline.
Why saline and not water?
Because saline has salt in it, and you want the patient's body to absorb that. So
What happens if I put regular water on it? Sterile water.
it'll dilute the plasma in the patient's body. If you don't use saline, the patient will have a harder time compensating for what's going on.
What happens if I put water on it?
It swells.
What swells?
The organs.
Because what else is swelling?
Because what else is swelling? The cells.
Right. And cell death leads to,
Tissue death.
which leads to,
Organ death.
which leads to,
Patient death.
right. Okay, and then what? What do I use to cover up that dressing?
The occlusive dressing. You gotta tape it on all four sides
Why?
to keep the organs moist and warm.
Right. Okay, so once we have the evisceration all dressed up, okay, we want to use the occlusive dressing taped on all four sides to lock in that heat and moisture. Okay, as far as the other kind of obstructive shock, George?
The last one is the tension pneumonia.
How can we recognize a tension pneumonia in a patient?
Subcutaneous emphysema, tracheal deviation. The last was the widening pulse pressure.
JVD, subcutaneous emphysema, and tracheal deviation.
Okay, so as far as a tension pneumo, what kind of pneumothorax would arise with the absence of an MOI?
Spontaneous pneumothorax, common in COPD emphysemic patients and tall, white, skinny males.
Okay, so why is it more likely in emphysemic patients?
Because they are peak puffers, their airway have expanded due to their constant intake of CO2, so they want to catch as much air as possible. So when they cough or something like that, those areola can rupture and cause pneumo.
What can rupture?
Their areola can rupture? No.
Areola.
Something totally different, sir.
Their lungs rupture.
No, areola is.
No, wait. Oh, that's just, I know.
He's not even talking.
It's, I don't know why I said areola. I said areola. Shush. I know it. God. I've been saying areola this whole time. Oh my god. I know it. Goes. Branch out. I swear. I want to say something, but I don't want to say it because I know it's going to be wrong. Is it? Oh, that's wrong. Now I can't stop thinking of areola. It's shush. Where's the book? Pink puffer patients have the very end where respiration happens. It's transfer of the air. CO2. Man, I'm gonna get really killed on this test for taking my notes really quickly to human body system to see what the main thing is. I know my lungs, and I can't think of any an areola for some reason.
You don't have any of
At
those.
the end of my bronchi, which is very weird that I'm thinking of their nipples at the end of the tubes inside my lungs.
Sounds like
Okay. The alveoli. So the
Right.
alveoli rupture because they are. Now I gotta get back to our pink puffers. They smoke a lot. So the alveoli expand, and because they expand, they're easily ruptured. And when
Okay.
they rupture, it can cause a pneumonia.
Okay. So what else is going to be special about those COPD emphysemic patients?
Ooh, man, you're doing well. Okay. COPD emphysemic patients. So, COPD emphysemic patient. Okay, I need to see that. I'm just gonna look at the guy. Our textbook case. I'm not gonna look at nothing. Abraham Lincoln with a tripod. Okay. Well, they're more flush.
Okay.
They usually have more. I'm gonna say that because that's not always true. Just with COPD emphysemic patients. Fuck. Pink puffers. I know what happens. Like, I know what's happening on the outside. Are they usually have more labored breathing because they're trying to get as much air in as possible?
Right. So what is their stimulus to breathe?
It's going to be the levels of oxygen in your body.
Specifically, what's going to be their stimulus to breathe when it comes to oxygen levels? I'm sorry?
Is oxygen not the
No, it is a stimulus, but
Oh, like the chemoreceptors?
well, yeah, the chemoreceptors is looking at levels of oxygen. Hmm. But what about oxygen is going to cause them to breathe? I think it's pretty clear. What about their oxygen levels is going to make that patient breathe?
Like if they have higher oxygen levels, you're not going to breathe as much. If they have lower oxygen levels, you're going to breathe more.
Right. Okay. So the lack of oxygen, right, or low oxygen levels, what's going to be their stimulus to breathe with that COPD emphysemic patient? Okay. Now, as far as cardiogenic shock, what is cardiogenic shock?
It's the heart itself is not pumping not pumping efficiently.
Why?
It would be because well, it could be on well, there would be some sort of heart failure, whether it was left or right heart failure, making the heart not do its job as a pump for the body.
Cardiogenic shock is usually caused by the damage to the myocardium.
Which we call
AMI.
right. Okay, specifically what side of the heart?
Left side would cause pulmonary edema, or it can cause pulmonary edema. Yeah, left side of the heart.
Because the left side pushes blood.
This thought.
Okay, so if they have left sided heart problems, we're going to see
If they have left side of heart problems, left side of heart problems, left side of the heart pumps blood to the rest of the body. Perfusion to the rest of the body.
right. But if they have a left sided heart problem, what else are we going to see besides signs of shock?
Pulmonary edema.
Right. What are the 5 medical causes of pulmonary edema besides left sided CHF?
Inhalation of superheated or toxic gas, pneumonia, and near drowning.
Okay. As far as right sided heart problems, what are we going to see to indicate a right sided heart problem?
Either GED or dependent edema,
AKA.
hitting edema.
AKA.
Dependent edema. The third one.
Right. Okay. Now, if our patient were to have a left-sided AMI, what kind of AMI could that possibly cause?
What kind of AMI that possibly cause?
very serious AMI.
Oh,
Yeah, very serious type of AMI that can happen to the left side of the heart. Pretty good compromise. Daisy?
Yeah.
Brent?
Cardiac arrest?
No. Erica?
Myocardial necrosis.
That's an AMI.
Okay, STEMI.
Right.
Oh,
STEMI.
Damn it.
Okay, so, right, STEMIs are generally going to happen to the left side of the heart where we see that ST elevation, right, on the EKG, usually indicating it's a left-sided problem. Okay, now as far as the last kind of shock, Axel, what's the last type of shock?
What did we say already? Cardiotonic.
I'll see you.
Would it be hypovolemic shock?
Is this Jeopardy, sir?
It's hypovolemic shock.
What are the two subcategories of hypovolemic shock?
Hemorrhagic.
Put your phone away.
Hemorrhagic.
Okay, what would cause non-hemorrhagic hypovolemic shock?
Like if you give yourself, and like if groceries.
What would cause non-hemorrhagic hypovolemic shock?
Vomiting or diarrhea.
What else?
Excessive urination.
Sure.
And that's overall loss of fluid in your body because you think you're sweating too much.
Mm-hmm. What else? cause non-hemorrhagic hypovolemic shock?
So nausea, vomiting, excessive urinating. It's just when your fluid is low.
Right, but what else can cause that?
Yeah, diarrhea, nausea, sweating, excessive pain.
That's it?
Yeah.
George?
Excessive thermal burns.
What type of burns?
Full thickness burns.
And?
And partial thickness burns.
Right. Now, as far as excessive sweating, okay, what is that going to lead to if the patient ends up running out of fluid?
Heat stroke.
How would he recognize heat stroke versus heat exhaustion?
If they had heat stroke, if he's sweating, no. If a heat stroke, it'll be dry, hot, and flush because they run out of fluid to cool the body up.
And heat
Or
exhaustion?
Heat exhaustion, they'll be sweating.
Okay. And as far as excessive vomiting and diarrhea, right, who is that going to be the number one cause of dehydration in?
Children.
Right. Okay. So, when it comes to hemorrhagic hypovolemic shock, what causes that?
Excessive blood loss.
Okay. So, what would be considered excessive in patients? What volume?
I'm not. It's in 5
That's the whole body,
Five
bro.
So-
hundred
that we dead. That's
I'm sorry?
500 milliliters.
Right. Okay. Now, as far as patients who have internal bleeding, what are the ways we can recognize internal bleeding?
They're going to be cool, pale, diaphoretic. Their blood pressure is going to be lower. They'll have if it's in the abdomen, it'll be distended rigid abdomen with pain and awful causes. They'll probably have delayed capital flow. If it's in the brain, it can cause anorexia.
Okay.
I don't know what else.
What else?
For a hemorrhagic, hypovolemic hemorrhagic shock, we could. So, we would know. We could be able to distinguish that they're in that shock if they have cool, pale, diaphoretic skin signs. What she said, potential ALOC if not enough blood is being perfused to the head. There would be obvious signs of bleeding.
No, we're talking about internal bleeding.
Oh, internal. Oh, pain on it depends if it's in the abdomen. Then there'd be pain on
You already said that.
There could be hematomas.
What is a hematoma?
It's a bump of blood. It could be anywhere, but I remember learning that only in the brain section. So, I'm gonna say in the brain, on the head where the skull is, above the skull. Different kind of bleed. That would be I would think, epidural bleed. There could be possible signs of, if that's the case, then maybe there would be, like every type of aneurysm, the abdominal, but like you're telling me signs though, signs of the shock. They could have
Just internal bleeding in general.
Internal. Well, okay. Oh, okay. Yeah, I already said that. They become cyanotic over time, and then their vitals would be like even really really bad with hypotension. Yeah, they would have hypotension and I guess eyes not pearl.
Depending on where it is, I mean, ecchymosis, which is a late signs, bruises are late signs of internal bleeding. Hematoma is a bleed beneath the skin, which can cause compartment syndrome, which is like an enlarged hematoma.
Okay. So as far as compartment syndrome, what would we do to treat compartment syndrome?
Compartment syndrome, we want to keep it level with the heart because putting it above or below won't actually do anything. It'll probably make it worse. And then we get them to a hospital so they can actually do something about it. There's no bleeding. There's no bleed to control. But we want to splint it somewhere level with the heart.
And what else could we do?
Put a tourniquet on to control blood flow to the injured area.
What else can we do besides splinting and keep it level? What else can we do? Ice it. Okay. As far as GI bleeds, what can we tell to indicate GI bleeds? What are we going to see?
It's not melena. It's the other one because it's brighter. Hemochrisia.
Okay. So why is it brighter?
Because it hasn't been digested. It's just up the GI tract.
Okay. So if that blood has been digested, what is it going to be?
Then it would be like black, tarry liquid.
And what do we call that?
That's melena.
Okay. What else are we going to see to indicate a GI bleed?
Would it be like through palpitations? Okay. Would it be in our vitals, like their blood pressure would go up? No.
Sorry, what? Erica?
Signs of GI bleeds.
the blood.
Okay, so what do we call that?
Hemoptysis.
Okay. And what else? What else? To indicate an upper GI bleed.
Oh, the hematemesis.
What is that?
Is blood in the vomit.
Okay.
And hemoptysis, which is coughing up blood.
And?
Oh, you said for upper, right?
Mm-hmm.
Isn't it that one where they cough up and it looks like coughing?
So what do we call that?
I have a question while he's looking. It's about the cardiogenic shock.
Mm-hmm.
So cardiogenic shock leads into obstructive?
They're totally different things. So cardiogenic shock is damage to the myocardium, whereas obstructive shock interferes with the heart's function.
So a pulmonary embolism is cardiogenic?
No.
Because I thought it said that you can get a pulmonary embolism from a heart attack.
No, you cannot get pulmonary embolism from a heart attack. You can get pulmonary embolism from a blood clot in the heart that travels around. Okay?
Oh, edema, I'm sorry. Pulmonary edema.
Pulmonary edema is not obstructive shock. Pulmonary edema is a sign of potential cardiogenic shock.
Okay, because I was grouping both of those as obstructive. Okay.
So you don't know it? Darsh?
Coffee ground emesis.
Right, coffee ground emesis, which tells me what?
It's been ingested, the blood's been ingested.
Right. Okay. So again, that patient's ingested some of that blood, swallowed it, and then the body got rid of it because does your body like your own blood?
No.
No. Okay. So the body tries to get rid of it since blood is a high irritant. Okay. Now that we finally have covered all of our different types of shock, now we have our different stages of shock. So what are the different stages of shock?
There's compensated, decompensated, and irreversible shock.
Okay. So how can I tell the difference between somebody who is compensating and somebody who's no longer compensating?
So saying compensated shock, you'll still see the tachycardia, so your heart beating faster, possibly palpitation growing up, and you'll see vasoconstriction because your body's trying to shut water into there. You'll see tachycardic and you'll see this normal tachycardic, but usually though when they start to decompensate, their levels start to drop because their body's going, or their body's exhausted. It fights, and then it either recovers or it gets exhausted. So the body's no longer able to fight, so it starts now slowly shutting down.
Okay. So what vital tells me the difference?
Oh, it's your pulse, because if you feel radial pulse and their heart rate is above 80, and then if you feel the brachial pulse is above 70, and then if it's above 60, you still feel the pulse. But if you can't feel that, then it's below 60.
What vital tells me the difference?
Blood pressure below 90.
Right, because the normal range for blood pressure for an adult is.
90 to 120.
I'm sorry.
90 to 120.
Ramon.
I like Nasi. What the normal ranges of
Blood pressure for an adult.
90 to 140.
Right. Okay. So if our patient's hypotensive, okay, then we know the body's no longer able to
compensate.
Can I tell the difference between decompensating and irreversible shock?
No, sir.
Why not?
We're not the doctors.
Well, they can't tell the difference either.
Well, we don't have. I don't remember that in lecture. I remember it was that was said, and that we weren't able to know. But we can't tell if the organs have already lost their chance to get. We can't tell when the blood becomes extremely acidotic that the organs will not even compensate, even if there's a full flush of the blood that's already inside the body with new healthy blood.
Right. Okay. Because at that point the body's become too acidic, right, to the point where we have widespread organ failure, and organ death leads to patient death. Okay. So as far as telling the difference, right, between our different stages, between compensated and decompensated, it's all about their what?
Blood pressure.
Blood pressure. Okay. But the pulse does have to relate to it, because it's not the heart rate less than 80, it's the blood pressure less than 80 to tell a radial pulse. So if they don't have a radial pulse, we already know they're what? Already know they're decompensating. Okay, but can my patient still have a radial pulse and still be decompensating?
Yes.
Yes. Okay, and we're going to feel what kind of pulse?
Thready,
right? And it's going to get weaker and weaker and weaker to the point where we cannot feel it anymore. Okay, so with that, okay, is our entire shock overview, and it took us almost an hour and a half. All right, to go back over all of that. Okay, so. Right, as far as shock, again, you guys have to be able to identify the differences between all of your different types of shock. Okay, understand your pathophysiology. Why do I see these signs and symptoms for these different types of shock? Okay, and as far as treatments, again, O2 blanket and proper positioning. I have no idea what you said. Okay, and proper positioning to identify what we have to do to take care of those patients. Okay, so just a couple other things just so we can kind of fast forward through the rest of that. Yeah, no, it's just stuck right there. As far as the principle, okay, that determines perfusion.
Okay.
Actually, no, it's what is that principle that determines perfusion? The principle that determines perfusion. Whose principle states that? Daisy? What does fixed perfusion state? Fix. Chris?
Air goes in and out, blood goes around and around, and tissue gets perfused.
Right. Okay. Air goes in and out, blood goes run around, tissue gets perfused. Okay. So if we have anything that interrupts that, right, affecting our perfusion triangle, okay, that's going to lead to our different types of shock, pump, pipe, and fluid problems. All right. As far as our blood vessels, of course, our blood vessels are lined with what kind of muscle?
Smooth muscle. Smooth muscle.
All right, smooth muscle. Okay, where it's going to constrict and dilate as needed, right, to go and compensate based on sympathetic response or its lack of actually getting that sympathetic response stimulus, like in what kind of shock? Neurogenic, right? Because it can no longer communicate with the rest of the brain since that cord's been severed. Okay, without the release of adrenaline, can we kick the sympathetic? No, right? Because that's what we need. Okay, to actually go into that sympathetic response. And of course, the brain has to be able to tell the body to actually communicate with that response. All right. Just in case you guys see questions on it, okay, we have to know about the pneumatic anti-shock garment. Do we use it anymore?
No.
No, right? But again, other places in the country still may use these old school devices. Okay, again, it would squeeze blood from the legs to help maintain perfusion to the core of the body. But once they release it, we have all that dirty, nasty, acidotic blood coming from the legs, coming back up, causing, again, acidosis, organ damage, tissue death, and then patient death.
What's the right way to take one of these off?
So they have to slowly release it while introducing bicarb to neutralize the acids, right? And a lot of doctors were like, screw it, right? And then release all that dirty blood in there. Yeah, and that's why we don't do it anymore. All right, so let's see what else we got here. All right, cool. We'll take our break here. Okay, we'll come back at 5:45, and then we'll start getting into the actual trauma portion.
I thought it was good.
No. It's just a fluid that
So for diving, so when we ascend, it's when we ascend too quickly while we're holding our breath or while we're releasing.
While we're holding our breath.
While we're
Yeah,
holding
what
our
they're
breath.
supposed to do is take their breath and then ascend slowly while they're exhaling.
Oh, okay.
Right, now if they were to ascend rapidly and exhale, we reduce it with how bad it is, but they're still going to do it.
She only missed like one specific session.
Yo.
Is it always gonna?
I think it's gonna be concussion.
Oh my god. If it gets bad, yeah. If it gets bad enough, it'll come though.
Why wouldn't it cause? Would it not
Like
cause
pulmonary
pulmonary edema?
I mean, it's still an even link symptoms. Most likely it causes both at the same time. If it gets bad enough. I think that would make sense.
But when you say the
Oh,
pulmonary
gosh.
edema, it's not
Oh
strong
my
enough for it to go back.
Literally, I'm saying that because it's for sure gonna happen.
Yeah.
So then
So
why
she's
is
saying
it
like
stop
stop
that
that.
It's because the heart can't pump enough. So
Okay, you're not eating it first.
No, it's not full.
Also not going through twice, there's like an air bubble.
Because I
Wait, but if it's not,
think this
it's not pumping all the way back, it's not filling all the way. So then,
Yeah, that's what I was saying. It's not really.
I think it really was that minorly,
It's like
but
cinnamon or
more
like,
times it
like,
makes sense.
I
If the
think
right
we
side
focus
is up.
on like, I know we focus on JVD.
Yes.
I don't understand why we don't really talk about pulmonary.
I think it's because there's just not enough getting
So you have your right atrium that's getting like overfilled, a little bit's going through the tricuspid, and that's gonna go to
No,
your
I'm
lungs.
telling,
and
I have
you
it.
get
I'm just telling you.
rich,
Like,
coming back
So there's just not
in,
enough
but then
fluid.
that also, that left
That's
atrium
not-
still closed,
It's
so.
not filling up, so wouldn't it, if it's trying to go
Oh,
from
yeah,
the
it's not
lung
even
in
filling
here,
it up.
then wouldn't it, like, all that blood should go back?
I think it's maybe there's just not enough fluid.
it's okay. I'm just.
So there's
I'm
no
good.
blood
I'm
going
good.
around, but how does it fill up?
It's just that number.
That's key.
I do agree. I understand your concern.
Did you try it? Did you pay? No, not into it.
The frontal lobe is for behavior, and then the occipital is for seeing. And
Frontal.
emotions.
Okay. What about the parietal and temporal lobes?
The parietal is for your sensory, your sensory movement, or your senses, and wait, let me go to temporal first. Your temporal is for your hearing, and your auditory, your speaking.
Okay.
And parietal is for your sensory movement. Your touch, your sense of touch. And
Okay. All right. Touch and sensation. All right. So that's just one type of our tertiary injuries where we have things like cardiac tamponade. Okay. We have possible pneumothorax. Right. Flail chest segments. Okay. Things like that. Whenever the body, right, and other internal organs hit the actual inside of the body itself. So there we have seatbelt marks. Okay. So those are going to be abrasions where we're going to see more quickly. Whereas if it's bruising, is that an early sign or a late sign?
Late sign.
Late sign. Okay. So again, it may take a while before we start to see bruising develop on here, but the actual redness as that seatbelt tightens up, causing friction burn and injury. All right. That's what we're going to see there. Obviously, we got to worry about internal injuries too. For lateral crashes, okay, this is where we tend to see more fatalities as far as car crashes are concerned, because while the body's not meant for violent movement as a whole, it can tolerate more anterior-posterior movement than lateral side-to-side movement, okay, causing things like lateral whiplash injuries, okay, aortic shearing, things like that. All right. So auto versus pedestrian, who's going to win?
Auto.
Right. Okay. So we have to assess the damage to the vehicle itself to determine what kind of injury patterns we're going to see. All right. Now, as far as pediatric patients, George, what are we going to have to worry about for pediatrics who get hit by cars?
Lower abdomen injury, like below the waist.
We got to worry about for pediatrics.
Upper body injuries, because their body is lower to the ground, so they're more likely to get hit up here than anywhere else.
And what else?
So head and
And what else?
getting back into the car.
Right. Whereas we, as
Go
adults,
over the car.
Right. Okay. Whereas adults, we go up and over. Okay. If we were to get hit, okay, kids tend to go down and under. So, if patients have some type of spinal injury, we obviously want to go and maintain C-spinal mobilization. Now, when it comes to auto versus bicyclists, we have to assess damage of their what?
Helmet.
And whatever damage is to the helmet, we have to assume is also happening to their
Head.
to their skull. Okay. And as far as different types of skull injuries, all right, Nana, what are the different types of skull fractures?
A basilar fracture.
Okay. And what are we going to see to indicate a basilar skull fracture?
See battle signs and raccoon eyes.
Okay.
A depressed skull fracture. You can palpate and feel that it's pushed in. A linear skull fracture, which you won't be able to tell, and an open skull fracture. You can just see it opening and exposing.
Okay. So how would they identify a linear skull fracture?
Like oh, using an X-ray.
Right. And what complication do we have to worry about with most of those skull fractures?
Internal bleeding.
Okay. Such as? Where the brain bleeds.
Epidural, subdural, and intercerebral bleeds.
Okay. So how would you identify an epidural bleed?
An epidural bleed, you would see the symptoms come on fast because the larger arteries are going to be damaged, and then subdural would be slow because it's the veins, and then intercerebral you would be kind of fast because their arteries are very smaller arteries.
Okay. So as far as the epidural bleed, how do we actually describe the speed of that bleed?
The epidural,
Mm-hmm.
super fast.
Right. Okay. Yeah, that's it. All right. So, okay, as far as those head injuries, right, we got to look out for that. Okay, and damage to the helmet may indicate those different types of injuries. So, with motorcycle crashes, different types. Of course, ejections where the riders go over, usually seen with head-on crashes. Angular crashes, okay, we're going to see a lot of crushing injuries to the patient's lower extremities, all right, specifically to their femur. Okay, and what kind of splint could I possibly use if they have a femur injury?
Is it just a finger injury?
Sure.
Isolated shock.
What kind of splint are we going to use?
Isolated shock. Attraction.
Right. What are the two types of traction splints?
There's a single unipolar one, as well as
Which is a
two people have to operate.
not necessarily what makes it different.
One is elevated.
Not necessarily. So if the zig is a unipolar, the hair is a not multipolar.
traction split.
Yeah.
The hair and the Sager.
So
Sager's a unipolar, the hair is a duopolar. It's two.
yeah, we're gonna call it a duo polar.
That's what you just said too. That's right.
That's do it.
No, I only say yeah because we were just talking about that.
Unipolar, two polar.
Oh.
What?
Some
What did you say for the
Unipolar.
Right.
We're not saying the answer.
So where are these team questions?
Yeah,
Hold on, just
we're
wait.
still individuals here.
It's because you guys are taking forever to get through that stuff.
JDI.
So I have 212 slides to go.
The human transport.
Erica? Bipolar.
Oh!
Okay. So when it comes to the rule of traction for a Sager splint, how much traction would I pull for a Sager splint?
10% of the body weight or up to 15 pounds.
What about the hair splint?
Until the patient feels relief from pain or until the legs are articulated.
All right. Okay, so we have to know how much traction we have to pull for patients who have those ice and mid-shaft femur fractures. Okay. Well, it's possible to have that with an angular crash. Usually there tends to be other crushing injuries to the patient's legs. Not always going to see that there. All right. With controlled crash, again, that's where the rider puts the bike down, slides, so we got to worry about abrasions, right, due to those slides that they're going to have. Okay. Now, as far as falls, Brent, what do we have to consider when it comes to falls?
How high they fell.
Okay. So
what they fell on.
what would be considered critical for their height?
Critical would be above, I want to say 20. Is it 15 to 20? 3 times the person's body height.
Or?
Or 20 feet.
Okay.
Cool. How high they fell, what they fell on, inserting on their body. Pediatrics are usually going to fall head first.
Okay.
And then what they fell on the surface, so like concrete, grass, wood chips.
Okay. So why would a pediatric patient fall head first?
Because they are freaks and their head is unproportional to the rest of the body, so it's bigger, so it's heavier, so gravity's going to take over and they're going to head
Okay.
first.
What else do we have to worry about those big old heads for pediatric patients?
In general or with falls?
In general, with trauma.
With trauma. Doesn't have to be Collins analysis. I'm thinking babies, pediatrics, big old heads, type of trauma. Prone to injury, just fractures.
Not really.
Oh. Pass.
Well, sorry. It's not.
So the question was, sorry, I don't know, I was first.
Guard? Or actually, Axel, sorry.
What do you say?
The neck snapping
Why?
because their heads are big as hell compared to their little necks.
Right.
Oh,
Okay.
yeah.
So we got to worry about whiplash injuries. Okay, exactly. Yeah,
that's
blowing
right.
ball in a toothpick. Okay, so we got to worry about those kinds of injuries. Now, as far as falls, right? Again, that big old fat head is going to cause them to pitch downward. Now, when they do fall, right, part of the body that hit first, we need to think about the path of displacement. Okay, so if they land with their knees locked, okay, that's going to be really bad, right? Because either blows out their knees, or dislocates their hips, or just breaks their femurs. Okay, but if they've been with their knees bent, okay, it absorbs, and maybe they'll do the tuck and roll, okay, where they try to slow themselves down. All right. Now, again, with kids falling head first, obviously you got to worry about all the different types of head injuries, okay, including neck injuries, as they go off to the side. All right. So again, height of the fall, 15 to 20 feet, depending on protocol, or 3 times the patient's body height is automatically critical. The type of surface that was struck, okay, and the part of the body hit first, followed by the path of displacement.
Why is it always in both those pictures part of the calcaneus?
Because it's the heel bone, so that's usually the part of the foot that's going to hit first before anything else, unless they go on their tippy toes.
Ooh, that's not.
Or flat-footed.
Isn't that how cats land?
What?
You're not a cat though.
Yeah, you're not a cat whatsoever.
Yeah. Okay. Now, as far as trauma, again, trauma is very what?
Straightforward.
And very binary. It's one or the other. So we have blunt trauma, where the skin is still
Intact.
closed, all right, or intact. Okay, and we have to obviously worry about the possibility of internal bleeding. Okay, especially with abdomens that look like this, where it's distended, and obviously to know if it's rigid, what do we have to do?
Palpate.
Got to palpate. Okay, so we see bruising along the patient's abdomen. It kind of looks like seatbelt marks, so probably caused by a car crash. Okay. Now, as far as penetrating injuries, the skin is now open. Okay. So we need to think about the speed of the penetration. The faster it's going, okay, typically the deeper it's going to go into the body. Okay, with things like gunshot wounds, right, we've got to worry about cavitation, okay, both permanent and temporary cavitation. Okay, now, finally we get to our first team-based question. Okay, so we have to go ahead, and I want you guys to tell me everything we have to do for this particular patient. Okay, so I'll write the injuries right here so you guys can use it for reference. Okay, but a partial avulsion, just going to shorthand here. Okay, so partial avulsion to the scalp.
Do we write it
Jugular
down?
laceration. Yeah, you guys can write it down so you can't steal answers.
Okay.
All right, and we have bubbling wounds to the chest, no exit wounds. Okay, that S with the line means without. Okay, so bubbling wounds to the chest without exit wounds.
Okay.
Okay, so you guys will have 2 minutes. I'm starting now.
We got 2 minutes.
Brains, bleeding.
Okay, so again, I want all treatments for this patient.
Live exit wounds?
No, without exit wounds.
Oh, without.
Where's the bowling one? In the back or no?
The back. So what we see on this guy right here. One minute.
Does it say like chest 5 exit?
Without. That S with a line means without.
Oh.
Okay, 30 more seconds.
Is that an S or is that a 5?
That's without. S with a line means without.
No, keep talking. Keep talking.
All right, 10 more seconds.
No.
Okay, 5, 4, 3, 2, 1.
Oh.
Let's see it. Write it down. Write it down.
Write it down?
Yeah.
Oh.
Oh, wait. We need to write it like big for you to read?
You don't have to write it big. You just hand it to me.
Okay, wait. I need to write the options are for. Hang on, I'm gonna write this on. That's for the.
Well, you can go ahead and expand upon it until we're done. Give you guys an extra 30 seconds.
The second one on the second paper is the same as the top one. The top one on both papers is the same. So I just want to clarify.
Okay. All right. Done.
Yep, I mean, not done coding. This is the same thing, I'm just rewriting out more.
Okay. So just tell me what you have.
It's the same thing.
All right.
It's just,
So, you guys didn't give high flow too. Okay. All treatments. Okay. And you both missed the fact that we have to provide spinal mobilization. Okay. Any penetrating injury, right, to the head, neck, torso, okay, is an indication of spinal mobilization. Okay. So, as far as you guys being at least the closest, okay, you guys will get the points.
You are right. No one gets points.
But again, it doesn't matter whether or not you're going to get close. All right, so again, if we have any type of penetrating injury, right, especially this one right here, the spine's only right there, okay? And if this dude got shot, right, we'd have to worry about cavitation, okay? So that spine might start to get involved. And again, bullets, do they just go straight through people? No, right? We got to worry about zigzagging, doing other kind of stuff, okay? Now, as far as the partial avulsion, yeah, we want to put that flat back in place, okay, bandage it up. Okay, the jugular vein laceration, want to go and put an occlusive dressing tape on 4 sides. Okay, and then with these, since they are bubbling chest wounds, okay, aka sucking chest wounds, right, bubbling because that's what happens when the patient
Breathe.
What? I'm sorry?
breathes in or out.
Yeah.
Which
Out.
one?
In. When the air comes in.
Wait,
It goes
hang on,
out.
question?
Yeah, bubbling chest wound is when they breathe out,
Oh,
okay, because the wound is going to
Bubble.
bubble, right, and then when they inhale, it gets sucked in, just like the video. Okay, so we want to go and take the occlusive dressings, tape it down 3 sides, leaving the gravity side open, obviously because he's sitting up. Wherever that blood is trailing down, that's the side that we're going to leave open. Okay, now as far as patients who have some type of penetrating injury, okay, we stabilize in place unless it interferes with
CPR.
or obstructs their
Airway.
Okay, other than that, again, we just leave it as is, stabilize, and transport. So with our different types of cavitation, again, we got the permanent cavity, which is a tunnel that's left behind, and we have the temporary cavity, okay, which is there just for a split second as the energy is being transferred inside the body, creating a little mini tiny explosion. Okay, and again, anything within this is going to suffer damage, even though it's not directly hit by the bullet itself. Okay, and we have to think about, okay, if a patient got shot, for example, in the right upper quadrant, so it may not have to hit the liver directly, but it's still going to be close enough to where it can cause issues to the liver. As far as our blast injuries, we got our primary, which is caused by the shock wave itself. Secondary, caused by debris flying through the air, causing either penetrating or blunt injuries. Okay, tertiary, where the patient goes flying through the air. And then quaternary is anything else that can be attributed to the blast itself. All right. As far as our coup conjugal injuries, that brain rattling back and forth, all right, typically affecting the frontal and occipital lobe as that brain is sloshing back and forth. But with lateral crashes, we got that lateral, okay, coup conjugal injury affecting the temporal and parietal region side to side. When it comes to neck injuries, of course, we got jugular vein lacerations treated with an occlusive dressing taped on how many sides? 4 sides. Okay, or if they were to have a carotid artery laceration, okay, pressure dressing wrapped around an infigure eight method. Okay, and if our patient has a blunt injury to the trachea causing tracheal rupture, what are we going to feel in that region?
Subcutaneous emphysema.
Right, subcutaneous emphysema. But do we have tracheal deviation?
No.
Do we have JVD?
No.
No, so we can tell it apart from a that's a pneumo.
Tension
pneumo, right? Because we're not going to see the other signs, but the one thing they have in common is the snap, crackle, pop. So, with the flawed chest, 3 or more ribs broken in 2 more places, giving us what kind of movement? Paradoxical. So when the patient breathes in, broken piece goes in, right, while the rest of the chest goes out, and then vice versa. Okay, with bruising, is that an early sign or a late sign?
Late sign.
Late sign. So when we see bruising in different parts of the body, we know that injury has happened quite some time ago, causing the discoloration that, again, we call ecchymosis. Obviously, the more parts of the body that are injured, the worse off the patient's going to be. Okay, when it comes to assessment of trauma, right, we got to try to figure out how much blood the patient has lost. Okay, and for it to be considered shock, it's going to be approximately what volume?
500 milliliters.
500
Right,
milliliters.
500 milliliters. Okay, so we try to estimate that as much as we possibly can. Now, obviously, whatever we see on the outside, could there be bleeding on the inside?
Yes.
Yes, and we have to try to add that into account as well. As far as the different types of bleeds, arterial bleeds are what color?
Bright red.
Bright red, and they spurt, whereas venous bleeds are dark red and they ooze, and capillary bleeds dark red and they
Kind of just
trickle.
Yeah.
Okay, so it just kind of trickles out of the patient. All right. So there we have our different types of shock. So we need to try to identify, right, the suspicion of internal bleeding based on the fact that we don't see obvious bleeding on the outside always. Okay, and we're going to start to see signs of shock. With the abdomen, it's pretty apparent because you're going to have a rigid and distended abdomen with
Pain on
all four quadrants and
Pale
skin
cool
signs.
diaphragm.
All right, pale cool diaphoretic skins indicating some type of solid organ rupture since those are full of blood. Whereas hollow organs are full of nasty stuff giving us peritonitis. We also got to look at the MOI to indicate that because, of course, internal bleeding can happen with trauma just as it can happen with medical. 4 different terms, we've already covered those. Hematoma, bleeding under the skin. Hematemesis, blood in the vomit. If it's bright red blood, then we know it's closer to the exit. Whereas if it's dark red blood and it looks like coffee, we call it
coffee ground
emesis. Gone to the stomach doesn't want it, stomach pukes it back out, right? Therefore giving us that dark and clumpy.
Or you said our body doesn't like our own blood. Would it happen with someone else's blood, or does the body not give a shit?
It'll still happen with blood, but specifically our own, right? Because people are like, oh, well, it's my fluid, I'm just going to get rid
So
of
we
it.
can use someone else's blood and it won't get cough.
No, you
Not
still
that,
get
like,
cough.
I'm expecting to see it. Just curious.
Yeah. No, it's just blood in general. Blood is a high irritant. Yeah, so if blood's not in the blood vessels, it's
what
not.
irritates it about it?
It's acidic. All right, so blood's a little bit more acidic.
So then how come when I
Actually, basic. My apologies.
I was going to say,
Yeah.
that doesn't make sense if I eat lemons and things.
Yeah. All right. But again, it's different. So put lemon in your eye. See how it feels. All right. Don't do it. Okay.
Challenge.
All right.
Yeah,
Come back.
I will go buy lemon.
I know you will. That's why I said don't do it. Okay. So, as far as hemoptysis, okay, that's obviously them coughing up blood, right? Things that we're going to see with certain types of chest injuries, but also other infections like
GI bleed or
infections, TB,
Oh.
right? Tuberculosis.
People we have to check every
So, as far as bandages, okay, so that's what we use to secure. Dressings are what go on the actual wound. Okay, so there is a slight difference in terms. You can use them interchangeably, but again, you have to know what makes them special. All right. As far as soft tissue trauma, besides blood loss, the major complication from a soft tissue injury is infection. It's what? Infection. So you want to make sure you keep it up nice and sterile, right, as we are wrapping around that bandage.
When will we use 4x8 dressing instead of 4x4? It seems like we mainly just use 4x4.
4x4 is just common, but we can use a lot of different types of dressings. So there's 5x9 like abdominal pads. There's multi-trauma dressing, which is a 21x30, if I'm not mistaken. We have 2x2s, 3x3s, and a bunch of different sizes.
Just 4x4.
It's just the common one. Yeah. All right. So as far as occlusive dressings, right, going to go ahead and be airtight, so we can use that for sucking chest wounds, direct vein lacerations, abdominal eviscerations. Okay, anything where we want to keep any air from going in, right, but maybe sometimes allowing stuff to go out in the case of a sucking chest wound. Right, now, if bleeding is not controlled through our traditional methods of direct pressure, elevation, and wrapping, then we move on to a tourniquet. Okay, where was I at?
I actually don't know.
Yeah, I don't remember either. All right, reset. So, as far as alternative tourniquet methods, what can we use to create alternative tourniquets?
We can. Not a belt. And we're not talking about the ones that we carry. So, an alternative, I would think. Could it be the, like, I don't know the exact name, but the tape that's like stretchy, but not entirely stretchy?
No.
Chris?
You know what tape I'm talking about?
I'm sorry?
BB cuff.
Yeah. Okay. What else?
A piece of cloth that's at least 2 inches wide, and then something rigid to twist and cut off the thing.
Okay.
Or cut off blood flow.
Okay. So as far as taking a blood pressure, why are we able to use that as a tourniquet?
when you're taking someone's blood pressure, you're basically cutting off flow and then releasing air, and then getting the systolic pulse with the first sound, and then the last sound would be the diastolic. And so if you pump it all the way, you're just cutting off blood flow.
Okay, and what's one advantage of using a blood pressure cuff as a tourniquet?
You can see if it's deflating at all and letting blood flow.
Right, and how wide does our tourniquet strap have to be?
At least 2 inches.
Okay. So, as far as our blood pressure cuff, again, we can use that. Okay, triangle bandage with a stick. Right, if we don't have our traditional tourniquets. Now, once we do apply a tourniquet, write TK and time. Okay, on a piece of tape, and then slap it on their forehead. Okay, and make sure that tourniquet is visible at all times. Now, as far as a hemostatic agent, what is that? Brent? Hemostatic.
It slows or stops bleeding.
How?
That's a good question. Does it?
That's why I asked it.
Yep. Does it help produce more platelets or introduce more platelets? Cause a blockage?
Erica?
It's a chemical burn, so it cauterizes.
Okay, in LA County, what are we able to use as far as hemostatics are concerned? Can we use powder or infused gauze?
Just the gauze.
Right. Okay, so we can only use the infused gauze, okay, when it comes to hemostatic dressings here in LA County. But just like our other skills and medications, okay, can we just carry it just because?
No.
No, we have to be
Approved
by
by
LEMSA. Okay, so again, our company's got to make application to the LEMSA saying, hey, can we use hemostatic agents? They go, yeah, that's fine, but you got to buy it, supply it, and it sounds expensive, never mind. So I've got everything else. Okay, so we're just going to be using tourniquets instead. Okay, now we can use this if we have to provide wound packing, okay, for certain types of injuries, right? Paper cuts, right? Even moderate lacerations, we don't need the hemostatics. Okay, but if they got a big old gaping wound in their arm or their leg, okay, then we may have to stuff it, preferably with the hemostatic gauze. Okay, so you kind of have to make the determination of we want to use these first over 4x4s, regular bleeding control methods, and go from there.
Since it's a chemical burn, does it affect anything with like treatment or like later treatment or how it?
They have to go in and clean all that stuff out and fix
Is
the
it going to
tissue.
heal fine usually, or is it?
Well, the main thing is we want to just stop the bleeding right away. They'll have to go in and they'll have to clean it out. They may have to cut tissue if it's necrotic or anything like that. Right, just kind of take a little bit better care. That's why again it's only used if we absolutely need to. Okay. As far as splinting, of course, we can use that to immobilize our injuries. Okay, to also help secure different types of bleed. Axel, what are the 4 rules of splinting?
Check CMS before and after.
Cool.
Splint passing the uninjured distal and proximal to the injury. Never tape or. Is that right? I'll go to the other one. Come back down.
Okay.
Never over the injury.
Never what?
Fracture, broken bone.
Never what?
Never splint over it. I mean, never wrap it. Never wrap over it.
Okay, so never wrap over the
Fracture or the broken bone or the injury, unless it's angulated with no.
rules of splinting.
Okay, so the first one is check CMS before and after splint.
Okay.
Second one is almost always splint position found unless the patient has an angulated fracture with no distal CMS. The splint must extend past 2 of the nearest uninjured joints, proximal and distal to the injury, and never tape or strap over injuries or uninjured joints.
What's that third rule?
The splint must extend past the 2 nearest uninjured joints, proximal and distal to the injury.
Okay. All right. Now, if our patient has an angulated fracture, no distal CMS, what do we get to do?
You get to hold it back into place.
What do you mean move back into place?
when you get to pop it like back into place, so you could like what was it?
You ready to place in the anatomical position, the extremity.
Right. Okay. Now, why do we have to splint past the two nearest uninjured joints that are proximal and distal to the injury?
So that you don't create grinding.
Not really.
You want to create like an inline stabilization of the extremity.
Not necessarily in line, because if it's angulated and we got distal CMS, we're going to splint it as is.
You're doing it for proper blood flow.
It has nothing to do with proper blood flow as far as splinting past those injuries, or the joints rather.
What's the exact question?
Why do we have to splint past the two nearest uninjured joints, proximal and distal to the injury?
For traction.
So that you don't make them hyperextended or
George?
To immobilize it, if you remove it.
Okay, so if we have a joint where there shouldn't be a joint, what do we call that?
Huh? You said if you have a joint where it shouldn't be.
Where there should not be a joint.
What are we on now?
Mr. Fox, what do we call it if there's a joint where there shouldn't be a joint?
A joint? So it's a place of movement where there shouldn't be a place of movement?
Mm-hmm.
Oh, that's a type of
Fracture? Oh,
Yeah.
that's what you're saying.
Because if our bone completely snapped in half, then you move the arm in the weird spot, but you can't move it. Look at that. I'm touching on a little thing. Oh, it's transverse fracture.
No.
Or is it complete?
That's not what I'm asking. That's the type of fracture that would cause it.
Yeah.
But what's it called when there's a joint where there should
The
not be a
actual,
joint?
like, medical term for that, like, the actual. You didn't tell me shit when I come on. This is not a question for
That's
me.
why we're doing
Yeah,
this.
exactly. Two stupid reasons to miss questions on exams,
Well,
sir.
I'm gonna figure my no, like,
Better. Huh? I don't know. I'm terrible at reading lips.
Oh,
Not me.
God.
You don't know?
No.
A false joint?
Not really. It is technically a false joint, but that's not the name of the movement that we see with that.
Is this the name of the injury or the name of the movement?
Name of the movement.
Okay.
Yeah. Because you said the name of the injury. It's a transverse fracture.
Gotcha.
So the actual movement itself?
Mhm. Ramon?
Would it be would it be some sort of twisting force?
No. Chris?
somewhere up here. Not supposed to be a joint. False motion.
Right. Okay, so false motion, right, is a movement where there's a joint where there shouldn't be a joint. Okay, so we want to make sure the splint's going past those two nearest uninjured joints to prevent that second elbow, essentially, right, from flopping around all over the place. Okay, now when it comes to treatment of a nosebleed, what do we do to treat a nosebleed? Okay. What if there's CSF drainage? Right. What do we do if there's CSF drainage?
If there's CSF drainage?
Yeah. Mixing with their nosebleed. No, it's not. So what do we do?
Damn, that sucks, bro.
Does that necessarily mean that they have an increased ICP because it's drainage?
Okay. But what do we do?
We would and it's coming out of the nose. Will we try to stop the bleeding, even though there's CSF in your blood? Nope.
Erica?
Are you likely apply a dressing but with no pressure?
Why not?
I should have known he was going to ask that. I mean, that's why.
That's why you get common questions. You know the what, you don't know the why.
CSF, we could, the source would be from ICP. Additional pressure would increase, external pressure could increase ICP, leading to more CSF leakage.
Right. Okay. So if we pinch the nose, right? Okay, and we're blocking the drainage, problem's going to get even worse. What do we call a nosebleed?
Ecchymosis?
Come back to it.
I know this. Epistaxis.
Right. Okay. Epistaxis.
That's the point, right?
No. So, as far as epistaxis, okay, so again, we want to pinch the patient's nose, have them lean forward, okay, and if we do see CSF drainage, just put the 4x4 there just to catch the blood in the CSF drainage. All right, that's it. Again, we don't put any pressure because it's going to make the problem worse. If we have it, apply some ice because it's going to cause vasoconstriction and therefore help reduce the nosebleed. If that's not working, then we take that rolled up 4x4 and again place it up underneath the lip to apply that upward pressure, and then we transport.
Do you think they punch you in the nose to make that nosebleed? Bam!
Like that particular type of nosebleed?
No, like, do you think that's what they did to make her nose bleed?
No, they have makeup.
No,
Yeah.
to do that, you got socked up.
That's what I'm saying.
Okay.
That's
It's not just the.
Wham!
You think
Oh,
they're just
now
hurting
you're
people and then taking pictures of them?
Hell yeah, bro!
Just for the MPA pictures, that's it. So,
Just for
as far as the brain, again, we reviewed that earlier. Okay, layers of the meninges, covered that earlier yesterday as well. Okay, so we got the duramater, that outer layer of skin. If the bleed's happening above the duramater, what do we call it?
Epidural.
What do we call it?
Epidural.
Right, epidural, because epi means
Above.
above. Okay, if it's below the duramater, we call it
Subdural.
subdural. Okay, and if it's inside of the brain,
It's
Cerebral.
cerebral.
So why they call it epinephrine? Why is it that?
Because nephrin refers to the kidneys. Adrenal glands are
Above the kidneys, so it's epinephrine. Wow.
wow, just like
Damn.
the epidermis
It's like Latin
is.
isn't own, but like
They're above your skin. Yeah.
Wow. Oh my gosh, Vince,
That's
this is
nice.
crazy.
I know. It only took 3 weeks.
That's so nice.
So,
I might take a little bit more because this review's not.
okay.
Exactly.
All right. So, as far as our different layers, right? We got the duramater, okay, which is going to be that tough outer layer. We got the duramater, the arachnoid mater down below, underneath, or actually arachnoid mater underneath the duramater, and then the pia mater, okay, right around the brain and the spinal cord itself. So with head injuries, of course, again, trauma is very what?
Straightforward.
So again, very binary as well. We got closed injuries, open injuries. So closed injuries, the head is still
Close.
whereas open injuries, the head is now open. Okay, so with open head injuries, right, again, we're going to have a little bit of CSF drainage coming out of there with this particular guy. Okay, again, we do have an opening right in there, possible brain matter right there, okay, with the scalp and skull. Okay, when it comes to scalp lacerations and facial injuries, okay, is there going to be a lot of visible blood?
No.
It's gonna look really bad, but it's not gonna actually bleed a lot.
Exactly. Okay, it looks a lot worse than it actually is.
Wow.
Okay, so the reason is there's a lot of smaller blood vessels here. So yeah, they will initially leak a lot of blood, but then they constrict and then stop bleeding. Okay, so usually when you see blood around the head and face, it's worse than it looks worse than it actually is. But again, we still want to assume the
Worst.
but hope for the best. Okay. So as far as our primary and secondary, okay, direct, indirect. Again, I just like using direct versus indirect instead of primary versus secondary. But with direct injury, that's obviously direct trauma to the brain itself. Okay, with the secondary or non-direct, okay, it's going to be complications from the actual direct injury itself. So swelling, right, which can lead to edema. So we generally use edema in the sense of fluid, but edema also means swelling. Okay, we got to worry about Cushing's triad, okay, infection, all the other complications that come with the actual trauma to the brain itself. So, brain swelling, of course, is bad. And when it comes to injured tissue, what does injured tissue do?
Swell.
It swells. Okay, so whatever type of tissue is injured, okay, it's going to swell. The brain is no exception. Hence why when you have other types of injuries, it tends to swell. All right, when it comes to Cushing's triad, okay, we have the hypertension with the widening pulse pressure, okay, because that body's trying to compensate for the
High pressure in the brain.
ICP. Okay, so again, let's just say for numbers' sake, right, intracranial pressure measures at 180 millimeters of mercury. In order to get that blood up into the brain, the pressure has to be higher than
180.
Right, okay, just to get it passed in there, right? So the heart's going to pump a little bit harder to increase that systolic pressure. Blood vessels constrict a little bit more, a little bit more resistant, trying to shoot that blood up to the brain as well. But with that increase in pressure, the cardiac control center, using its what receptors?
Baroreceptors.
To check that pressure and tell the heart rate to slow down, okay, giving the patient bradycardia. And because the respiratory control center is all sorts of screwed up, okay, along with acidosis, we get the rapid erratic respirations with either Cheyne-Stokes respirations, right, or biots or ataxic respirations. Okay, so the only treatment we can do for patients with these types of head injuries is just controlled hyperventilation. Okay, consider possible spinal injuries and go to the hospital ASAP. Okay, we want to do the hyperventilations because with Cheyne-Stokes or biot respirations, especially on the lower side of total volume, okay, are they actually sucking in enough air? No, right? So we have to force that air into the lungs to make sure, right, the brain and every other part of the body is still getting perfused with oxygen. So we already hit our skull injuries, again, very common with the linear skull fracture. Can we see that in the field? No. So if we have an MOI that indicates possible head injury and we palpate and they say, ow, we assume they have a
skull fracture.
All right, linear skull fracture. Okay. Depressed skull fractures, do you want to poke it?
No.
Why not? Right. Okay, we'll drive the bone into the brain. Okay. As far as open skull fractures, clearly don't touch it because then you touch their brain.
What about lunch?
No. Okay. As far as raccoon eyes and battle signs, those are signs of a basilar skull fracture. And because they're both bruises, are they early signs or late signs?
Late signs.
Late signs. And with this, we also have to worry about what else happening inside of their head. Right, intracranial pressure. Because if you have a basilar skull fracture, are you going to have some type of brain damage?
Yes.
More than likely. Okay, but again, for class purposes, we treat them exclusive of one another. Bruising is CSF. I'm sorry, basilar skull fracture, right? And then CSF drainage is ICP. So again, there we have our raccoon eyes. Okay, bruising around both eyes. Right, we've got some bruising behind the ears as well, indication of battle signs. All right. So there we have a nasogastric tube. Right, is what it seems.
Okay, probably contraindicated unless they did an X-ray and make sure it's fine. All right, but again, nasogastric tubes are generally contraindicated in head, facial, or spinal trauma because it can go where?
Brain.
Right, and go into the brain.
Should probably X-ray, make sure there's no opening.
Yeah. But again, with basal skull fractures, it's kind of. I mean, I could be wrong. It could not be a nasogastric tube, but I don't really see what else it
Maybe they
could
just
be.
want to oxidize the brain. Maybe that needs a little down.
Nah.
Give it more room.
Nope.
I don't think that's how
So,
that works.
when it comes to concussions, okay, are concussions permanent or temporary?
Temporary.
Right, okay. So, it's going to be temporary brain damage, okay, that will eventually relieve itself, right? But if they have multiple repeated concussions over short periods of time, of course, then we start seeing more serious complications later on, okay? Can we tell the difference between a concussion and a contusion in the field?
Huh?
Can we tell the difference between a concussion and a contusion in the field?
No.
No, okay, because they look very similar, it's just that one will eventually
Stop.
go away.
Gotcha.
Okay, again, assume the
Worst.
hope for the
Best.
best. All right, so with contusions, they may eventually start showing signs of Cushing's triad, but again, that's more of a later sign since you now have pressure and blood building up inside of that head. So with different types of bleeds, epidural again is super fast because these vessels are
Big.
larger compared to the intracerebral, which are smaller, even though they're both arteries. Okay, and with the subdural, it's slow because they are veins, right, that are ruptured and slowly start oozing out blood. Okay, with signs symptoms of head injuries, okay, there's a lot of different signs. If we suspect that it may be caused by a head injury, it's probably
Head injury.
caused by a head injury. Okay, and the first thing we're going to start to see change in patients is their mental status. Okay, so the patient will start to show signs of an ALOC first amongst a lot of other signs and symptoms of head injuries. Shortly thereafter, what else is going to change?
Their eyes.
Eye, pupils.
Because they're windows through the
Brain.
Eyes are windows to the
Yes.
eyes.
Yes, they are. Pupils are
Okay.
windows to the eyes. The inside
Right.
of the eyes.
Technically, you're not wrong. Okay. So, as far as it'd be like a mercy point if anything.
I'll take a mercy point at this point. We're 6 behind.
So, as far as pupils, right, again, they will begin to change. Usually we're going to see unequal pupils, okay? As far as other pupillary changes, fine. What other pupillary changes are we going to see that are abnormal?
So if they have an opioid overdose, they have pinpoint pupils.
Okay.
Strokes can cause half and half. I don't know. It's one smaller, one's pinpoint, one's more dilated.
What do we call that?
This terminology shit is way too hard.
Bro, you guys fucking parties.
What is it?
Bilateral pinpoint dilation and constriction.
Bilateral means same on both
Okay.
sides.
So I can tell you all.
Should make it like Final Jeopardy, where it's actually going to cost you a point if you get it wrong.
Fuck off! No, not with me.
Captain.
I'm shit with terminology. I always have been, always will be. I figure shit out my own way. So when it's like when you just go to my fucking drug thing. Drugs.
So you're not going to find it there.
I know I'm not gonna find it there, but I can figure out a name.
What's the question
Sorry,
before?
So what are other abnormal pupillary reactions? We'll make it a captain's question. How about that?
One dilating and one constricting.
What do we call that?
Oh my lord! I didn't know that.
Is it just opposite pupil reaction? Or oh no, pearl is pupils are round regular, so it's irregular pupil dilate. Round regular, light reactive. Irregular. What?
This is not. That's not fair. That's not fair.
What? What?
They didn't help me.
Just, yeah, what is it, sir?
Unequal pupils.
Right. Unequal.
That's so dumb. That's so dumb. If I said one small,
No,
one
they're
big.
not. Irregular just means not regular. Okay. So unequal pupils, right? What else are we gonna see?
Sluggish reaction to. It's sluggish reactions to
Me too.
things that you would have normal reactions to.
Okay.
They would. You point a light to their eyes, and they would react sluggishly, slowly.
So what would they do
Um,
if they have sluggish reactions?
They would constrict, but like in a very slow way.
Okay. What else?
They could have opposite reactions to that same Pearl's test, which would actually have their pupils dilate when eyes are pointed. I mean, lights are pointed to their eyes.
Right. Okay. What else?
So there's pinpoint, sluggish, opposite reaction, unequal. We said that, and then another Pearl's PE. Could it be? And we're talking about trauma, and
No, we're just talking about abnormal pupillary signs.
oh, abnormal pupillary signs. Okay, so that would be. It's like I knew what I knew the answer, but unequal. Opposite reactions, pinpoint. The last one. They would have a problem. It's not just normal reactions. Would it be if they have like cataracts?
That's
Just completely different.
That's just a thing that happens.
Oh yeah, I could have.
Be cataracts. Yeah, you could skip. That's fine.
Yeah.
No reaction to light?
Right. Why would they have no reaction to light?
Because they're not reactive, they're under the influence.
But a little bit just.
Can we say them all together?
Sure, that's fine.
Oh, we can say it?
Yeah, just say
Okay. Isn't it? So she told me. So you can. So it's
No, you pearls.
Bruh.
Wait.
People.
What?
Wait.
Why?
Oh.
No. Yeah. That's
Wait,
you.
what are we?
Okay. No.
If they're
So
blind or they have fake eye, they're not gonna be light reactive.
Or
they're dead.
yes.
And
Okay.
I thought it was a no shit. Horizontal and vertical tremors.
What's
Known
that?
as eye signs.
Well, what do we call that?
See?
No, we can't call it tremors.
It's
We have a term for it.
horizontal.
I don't know the word.
Oh, that one's in the.
The eye
drugs
twitching up and
section.
down, the eye twitching left to
It's
right.
the- it's
PCP.
What do we call that?
Alcohol.
What do we call that?
Horizontal, vertical, nystagmus.
Right.
What the fuck?
See, I
Right.
knew
Nystagmus.
it.
Why you
What does
asking
horizontal
me
nystagmus
stuff
indicate?
about terminology. Don't ask me.
One of them can be for PCP, the other one can be for alcohol.
Okay, so which one is which?
I know.
Vertical is another thing to alcohol. Horizontal is PCP.
Right.
Damn.
Okay, so again, if those eyes are jittering side to
What
side,
is it called again?
nystagmus.
Nystagmus?
Tweakers are side by
Nystagmus.
side.
Nystagmus.
Nystagmus.
Miss or no
Nis
stag?
with an N as in Nancy.
Can
Horizontal.
we do team questions? I like
Nystagmus.
the team questions a lot better.
Because you can use a team to carry you, I know.
I know, no.
Okay,
I got
so-
everything but the proper
right.
big words.
So,
A really good
part of it. Okay, so going back to that, right? We are going to have abnormal pupillary reactions. Okay, seizures, projectile vomiting, possible CSF drainage, bruising, things like that. Okay, with decorticate and acerbic posturing.
Cookie muscle eyes is a skull fracture. It's a linear skull fracture where you can push the muscle up and make the eyes go out.
It's not necessarily just a linear skull fracture. It's a specific type of fracture.
It's a fracture where it pushes into
It's
the
a
muscle.
facial.
Yeah.
What kind of?
What do you mean? What is
It's your
this?
nose. It's your.
It's when right here gets broken and it pushes into the muscle and it makes your eye go, "Meh," and then you have fucked up eyes.
So
Look at
what
the
do we
cookie
call
muscle.
that type of fracture?
Facial fracture.
No.
Orbital lobe fracture.
We'll get to it later. 'Cause it's
Fracture of the
So,
cheekbone.
as far as decorticate, okay, decerbate, right? Fancy word or less fancy word for decorticate is
Flexion.
flexion, and extension would be
Decerbate.
decerbate. Okay. So we're going to be looking out for that again in the GCS. Going to be worse off. As far as non-traumatic brain injuries, those are different types of strokes. Okay, be it ischemic or hemorrhagic. Okay, obviously hemorrhagic's worse. They complain of the
Worst.
Worst setting of their life.
but it tends to be
Last.
their last. Okay, and we do the best we can to treat those patients with any type of head injury. All right, for spinal injuries, right, we've got the different segments of the spine, so 7 different vertebrae in the cervical spine. Okay, with that one very special nerve that comes out of the cervical spine.
Oh,
right. Where were we at originally? Because we're just like bouncing around.
I was the one that spoke.
Yeah, actually, yeah, it was
It's
Daisy.
Daisy's turn.
Daisy, what's that nerve that comes out of the cervical spine? What does it control?
The diaphragm.
What about the diaphragm?
How structure again. Up and down.
Got that shit wrong yesterday.
Okay. So what other part of our body controls respirations?
The brain stem.
Which control center?
The respiration center.
Through what kind of receptors? In a healthy patient, there are emerging levels of?
94.
That's what I'm asking. What are those chemoreceptors measuring in a healthy patient?
Well, they're gonna increase oxygen breathing so they can get rid of CO2.
So what is their stimulus to breathe? In a healthy patient, what's their stimulus to breathe?
Give your phone a friend.
No.
Give your phone a friend.
Carbon dioxide. So if CO2 levels start to increase, what happens to the breathing rate?
It's gonna go up
Why?
because the body's trying to rid of the excess acid by respiration.
Okay. And if we have a backup system, what do we call that?
Hypoxic drive.
And what kind of patient's going to function on that hypoxic drive?
I want to say the syncope, the pink puffers. I want to say emphysemic, but my real answer is the B one, which I would call
No.
emphysemic.
That was a cough, I promise.
Hey,
Yeah.
he helped out. He helped out.
What?
Yeah!
Are you kidding me?
Yes.
Okay.
What the fuck?
You can afford it. It's fine.
No.
So
Oh,
as far
it's a
as
principle thing.
As far as, right, the phrenic nerve, okay, that's going to be controlling the diaphragm, controlling their tidal volume, right? So, as far as the thoracic spine, okay, that's where the ribs originate. Lumbar spine, most back injuries, sacroiliac, fused part of the posterior part of the pelvis. With different types of spinal injuries, okay, we have compression injuries where the vertebrae are smashing into each other, okay, leading to things like herniated discs and whatnot. Okay, rotation flexion injuries where the spine is spinning, okay, as well as whiplash injuries going back and forth. And hyperextension, where the vertebrae are
hyperextending,
pulling apart.
Yeah.
Okay, right, where we see that typically when people are thrown out of their vehicles. Now, if we have any type of MY that indicates possible spinal injury, like penetrating trauma to the head, neck, back, or torso, okay, then we want to go and prepare for spinal mobilization. Okay, so we just got to look at the MY. It's possible they may have spinal injury. So again, for right now, for class purposes, okay, we want to go and put them on a backboard. So when it comes to mobilization of the head, okay, we go ahead and have our partner do that in what part of our patient assessment?
The partner immobilizing the head, not attaching the C-part. That would be when we after we have done the general impression and as we're doing the process.
Okay, so as far as the process of spinal mobilization, okay, after the primary assessment is complete, what do we have to do?
You begin the secondary with a rapid, and then you check for CMS, and then you put on the C color, and then you also check C in a second. And then you do a rollover, log rollover, and then you check their backside, and then do lung auscultations, and then you put them on, secure them to a backboard. And then you put the cheese blocks on, and then you put you put the straps on from the torso first, and then the cheese blocks, and then CMS. Okay.
So where did the straps go?
First on the chest area, and then the hip area, and then and then the femur area, and then the tip ribs, and then choose blocks 2 times in LA.
Okay. What else is special about the chest strap besides it being first?
The patient needs to inhale before we strap it in, and also it can't get in the way of their right arm. Okay. So when we strap one of their arms down, but one of them goes under their arm.
Okay, so which arm do we generally want to leave out?
Their left arm.
Why?
Because we're on the left side. Well, we're sitting to the left side of the patient's body.
Okay. And as far as rolling the patient, which side do we place the backboard when we're ready to roll?
We place it on their most injured side so that when they roll over, they're rolling over on their least injured side.
Okay. And as far as securing for DOT, how do we secure the head for DOT?
Twice around the head and one under the ends of the chest.
All right. So, as far as securing the head, okay, we're gonna go and take care of that in the secondary assessment. Okay. So, have the partner hold the head after general impression, walk up, okay, run through a primary assessment because we have to find and treat any
life-threatening
threats before we put them on a backboard because it's just a full body splint. Okay, and we never ever splint in the
primary.
We always splint in the secondary. Okay, and then we run through our whole assessment. Okay, get them strapped in, and then transport after we check CMS.
Is it different from the standing takedown?
It's a little bit different than the standing takedown. Yeah, because the standing takedown we just do a partial rapid, right, and then we go and put them down and then finish up.
Gotcha.
Go ahead.
Go ahead.
You go? Okay. Say we yoink a patient. Would you still worry about doing those other assessments? Say I yoink a patient that fucked up, yoink them out. Would I not worry about securing them before, or at least getting them like on a backboard, not maybe strapped down, but on a backboard before I assess them because I'm already having them moving and stuff like that?
Well, why would we have to rapidly extricate?
Because it seems not safe.
Or?
If they're not stable.
Right. Okay, so we've just got to get them out of there. If it's a safety issue, just get them out. Right? If they're not stable, get them out as safely as you can, and then we can go from there. Okay? Next question.
I answered my own question in my head.
Jesus.
I was just thinking about.
Wow.
I was gonna ask you what was the cardboard, the car spinal mobilization.
Okay.
Yeah, I answered it in
Kendrick
my head.
extrication.
Okay.
Do we check CMS and a CAD since we're gonna move them to a backboard?
Yeah. How many times do we check CMS when we're putting somebody on a KED?
Minimum 3.
Right. Minimum of 3 times. Once before, once after the KED, and then once when we secure on the backboard.
Oh yeah, I was a patient most of the time now, so I was like,
Teaching them spin.
no, I don't.
For
Oh,
the
oh,
standing spinal mobilization, the bottles that we're just trying to get before we put them on the board is just back lung sound, right? Is there anything else?
That's it.
Okay.
Yeah, just try to get posterior lung sounds if we can. Yeah.
The L in looks, is that for legs? Okay.
Looks?
My baby looks hot tonight.
Oh.
Yeah.
Right.
Oh, you got me scared. I was like, I forgot.
Okay.
Fucking-
So, as far as supine patients, right, want to go and strap them in, okay, for the KED, again, yeah, my baby looks hot tonight. We'll go and strap that patient in, get him out, okay, on the KED. For the standing takedown, just do what I like to call a modified rapid assessment, right, because we're not checking anything on the core. It's really just the head, the back, and the extremities, and then we'll do everything else once they get centered on that board, okay? As far as face mask removal, okay, if we can get access to the airway, right, without taking the helmet off, then just simply remove the face mask. Okay, but if I can't, then we have to
Remove the helmet.
remove the whole helmet. And once the helmet's off, can I just put their head down on the ground?
No.
No.
Put stuff underneath.
Right, we got to pat it, okay, for whatever the actual distance is. Okay, but in the case of things like this football helmet, take the face mask off, get to the airway, and do what we have to do. We can also take it off during cardiac arrest, but again, try to keep that head still.
So if you check CMS before you splint and it's not there, what do? Still.
Oh, what kind of injury is it, and things like that.
I don't know.
Okay,
I was
so
just-
what
if
if-
you're checking CMS in the hands and
Okay.
they can't move their hand or something, you're like, damn, that sucks, and it's still splint, or
Yeah, what if it's a spinal injury and they just can't move their hands? They don't have CMS beforehand.
Paralyzed.
Yeah.
Okay, so you just don't. Then
Still
CMS
put 'em on
is
a backboard.
Irrelevant. Is there a point of checking CMS afterwards then, because they
Yeah.
can't move their hands?
Documentation.
Interesting.
Yeah.
What if I
Just to prove that we didn't paralyze them.
Exactly. Okay.
Uh,
Now, as far as it being an angulated fracture of distal CMS, what do we do?
Then you can put it back to the media to the body. Wait, to the anatomical position.
Right. Okay. So again, if it's already in,
You take the whole thing and you go towards the body?
if it's already in anatomical position, then do I move it?
No.
No, just leave it. So you just want it as is. That's why I said it varies on the injury. Okay. So as far as tendons and ligaments, okay, so tendons connect muscle to bone, okay, whereas ligaments connect bone to bone. Okay.
You should have asked us that.
So as far as the type of injury, okay, that has to do with this connective tissue, what type of injury has to do with that connective tissue?
Can you repeat the question one more time? I love
Yeah.
this class.
If we have an injury to connective tissue, what do we call it?
You strain.
My turn.
It's
It's an
Oh,
osteostroma.
sorry. It's
Oh, your ass.
You said to connective tissue, right?
Mm-hmm.
Okay, it would be a sprain.
Right.
Yeah.
What's a strain?
A strain is the stretching or tearing a muscle.
Okay. So give me an example.
Like a real life example of us.
Sure. Of both.
Could it be like working out or something?
Okay. So give me an example of both.
Oh,
That's a good one.
no, like doing
What?
weights, and then like you just like stretch muscle. I don't know how to explain.
Okay. So what kind of injury would that be?
That would be a strain.
Whereas the other kind of injury would be a.
A sprain.
So give me an example of that.
Oh, sprain.
Yeah.
Oh, okay.
Don't leave it. Don't leave it.
I can give you an example right now. I will damage my body.
You're gonna make it. You're gonna make it to the point.
Even if you do it.
If I cause a sprain, can I
No.
allow that to be?
No.
Can they lose a point for suggesting that?
You already lost enough.
It's getting Easty in here.
What?
Easty means?
Oh my god. Vince knows what Easty means. You don't?
I'm old. I don't know.
Oh my god. George, do you know what it means? If I say it's getting Easty in here.
What?
What?
No, what does that mean?
Because like the east side of LA is like.
My
So
lord.
you're
That
saying
makes
it's getting,
hell no
it's like
sense.
it's like animosity. It's getting like the tensions going
I
on.
don't know.
Fuck.
What?
I
Is
know,
it
it's
a
Racially motivated.
sprain like a ligament?
So give me an example.
Oh.
That's all I'm asking for is an example of a sprain.
If you use that, people don't really have like, oh shit.
I would use that now. It's getting yeasty in the room. They'll be like,
I
ah!
overextend my hand.
So what would get sprained?
Sorry?
What would get sprained?
My wrist.
Oh, God damn, finally. Okay. So, seriously. Yeah, actually, that's not worth the point. That's okay. All right, so as far as a sprain,
my brother a
okay,
chance.
right, it's gonna be stretching
You
or
got like
tearing
3
the
minutes of a
ligament.
chance.
I know. Okay, for something like a sprained ankle.
I was gonna roll your ankle with a sprained ankle.
I thought you wanted like a whole knee.
No.
That's what I was saying.
That's what I was saying. Give me an example of one. Okay, so sprain, right, is ligament injury, okay, aka joint injuries, whereas strains, right, can be injuries to your muscle. Okay, so again, you can strain your bicep, but you can sprain your ankle. Okay,
Hair?
yeah,
So
I've torn my
sprain is just ligament, not tendon.
it's both. Yeah,
Can you do both in one action?
of course.
Probably, yeah.
Okay, so as far as rices, right, we're going to use our general rest, ice compression, elevation, and splitting, right, to immobilize these injuries. So with fractures, okay, we have a closed deformed fracture here, okay, and is this going to change if there's CMS?
How?
No. What do we do?
Splint it.
Splint it, right? Follow your rules of splinting, and that's it. Okay? So, as far as signs, symptoms of fractures, right? Obviously pain, sometimes false motion, crepitus. Okay, if we have a piece of bone that's protruding out of the body, Darge, what do you call that kind of fracture?
That'd be a compound fracture.
Okay, and if our patient has a compound fracture, what do I take care of first, bleeding or the fracture?
Bleeding.
Okay, and if they have a compound isolated midshaft femur fracture, can I use a traction splint?
Yes.
Right. Okay, as long as the injury is isolated, right, there's no other injury to that leg.
Now we're playing favoritism.
Well, Ramon, stop. Ramon, stop. Ramon. No.
So, as far as splinting, right, we want to go ahead and just follow your basic rules of splinting, right? And as long as you follow those rules, it's just what?
Arts and
Arts and crafts.
Arts and crafts.
Okay. So, just go ahead and make sure we're following those rules, right? Checking CMS before and after we apply a splint. Okay, if I check it in the middle, does it count?
No.
No.
Yeah.
Okay, we have to check it.
You don't have to.
Before and after.
No.
That's what I'm saying.
Well,
Yeah, we check it
before
before, we check it after. Okay, you check it a million times in between, but you don't do either one on either end.
You still
Right?
fail.
Exactly. Okay, so we almost always splint position found unless they have an angulated fracture with no distal
CMS.
Then we get to bring it back to
Anatomical position.
All right, anatomical position. Splint past the two nearest uninjured joints proximal to the injury, and do not taper strap over injuries or uninjured joints. Okay, again, the rules do not splint. Or the rules do not splint. Okay, over the injury because then it defeats the purpose. Okay, so again, do not tape or strap over the injury.
They got an angulated fracture like this, and their arm's just like sticking out like this. We bring it back, and it just kind of swings. Do we just kind of?
Well, we try to hold it and then splint it in that anatomical position. All right, we don't go and then make it two.
I didn't think we would. I just kind of what do we do?
All right.
It's
So,
just like a.
as far as dislocations, okay, we go ahead and splint it just like a regular fracture. Okay, but we modify our rules just a teeny tiny bit to immobilize the uninjured
Joint.
bones,
Bone.
proximal distal to the injured
Yeah.
joint. Okay.
Oh, wait, yeah.
Yeah, because you want to try to anchor that joint so it's not moving around. Okay, as far as reduction of joints, okay, what joint are we able to pop back in place? George? Right. Okay, can we do it here in LA?
No.
No. Okay. So, right, can only pop in elbows, right? Let's see. What else can I ask? As far as shoulder dislocations, how do we treat that?
Sling and swap.
Okay. What about knee dislocations?
Splint.
Okay. What about patella dislocations?
What now?
Patella dislocations.
Stand up. A splint.
Oh, okay. I said splinting rolls. Like, okay. So yeah, we'll go and use a splint. As far as finger dislocations, what do we do?
You wrap it around with gauze, make it straight. With the finger splint.
Okay. So, what are we doing?
Or you stabilizing. No?
Yeah, we are stabilizing it, but
Bro. You got it. He's just making you overthink it. Don't overthink it. What are you doing? You're just.
You're splinting it.
all right, that's it. Okay, so we just go ahead and do splinting, right? As far as any type of finger dislocations. All right, so we just go and leave it as is, right? With shoulder dislocations, just apply a sling and swath. Okay, so with the sling, okay, we're going to be making that with a triangle bandage, and the swath is anything we're going to use to tie around, okay, the patient's arms. As far as the dislocations, it doesn't matter what type it is, okay, we always use a sling and swath. If we have an anterior dislocation, that shoulder gets knocked forward. Okay, if it's a posterior dislocation, it gets knocked
Backwards.
and if it's a lateral, it goes
Out.
outward. Okay, but we splint it as is, whichever way it is.
How come we don't anchor the finger to the a working finger? That's what I was.
We can do that. That's fine.
Yeah.
All right, as long as we stabilize the injury.
Yeah, I was.
Yeah.
Is there like a limit of fingers we can put together? Like if these two are ripping, we can just.
No,
No, it's fine. As long as we have enough to stabilize.
Yeah.
So, as far as our sling and swath, right, we'll go and secure it like so. Okay. Elbow dislocations, right, immobilize the uninjured bones proximal to the injured joint, so we're locking that in place. Again, only can pop in elbow dislocations. Okay. Huh? Okay. So, as far as splinting a forearm fracture, okay, we just go ahead and follow our rules of splinting. Okay, nothing super duper special. Same thing with the Cullis fracture. Okay, we have that silver fork fracture, just leave it as is, splint it. Okay. With forearm fractures, you want to put the patient in a position of function. Okay, so if they lose motion of the hand, at least they can still do something. All right. With pelvic injuries, okay, patients can lose up to 2 liters of blood. Patients may present with hematuria, which is just blood in their urine. Okay, which again, there's a lot of things that can cause hematuria. With the pelvic fractures, we can use the pneumatic shock garments in some places and way back when, stabilize those pelvic injuries, right? Or we can use commercial splints or even a sheet splint, okay, where we go ahead and tie the pelvis together and hold it in place. All right, with hip dislocations, are these common?
No.
No. Are hip fractures common?
Yes.
Yes. Okay, so we have to know the difference between them. With hip dislocations, right, we are going to have bulge on either side. If it's an anterior dislocation, again, that hip gets knocked forward, leg goes out. Posterior dislocation, leg goes back, leg goes in. Okay, both are going to present with shortening, and we just splint to the best of our abilities. Okay, so here we have an example of an anatomical splint. So they have a rigid splint between both legs, tying them together, okay, to go ahead and secure it. Again, splinting is just as long as you follow the rules. Okay, with a compound isolated mid-shaft femur fracture, again, we are able to use a tract and splint. Okay, what we're going to do is end up sucking that bone back into the leg to try to line it back up, and we go from there. Okay. Now, as far as assessment, to know it's an isolated mid-shaft femur fracture, what do we have to do? Palpate. Okay. Right. So just palpate, and if they say ow anywhere else but here, can we use a tract and splint? No, because it's not
Isolated. Mid-shaft femur fracture.
right. Okay, it's not an isolated mid-shaft femur fracture.
Or is it going to be like, are they just not going to say ow anywhere else, or is it just going to be like?
It's going to be major pain here, right? But yeah, if they palpate anywhere, if they say ow anywhere else in the leg upon palpation, it's automatically ruled out.
Yeah, kind of like I said, so it breaks there, and they say ow in that area. If it's like, okay, it hurts a lot right here, if I'm palpating up to it and it goes ow, 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 but it's just a mid-shaft femur fracture, can that happen? Like, this part of my leg hurt.
Is it just like?
I snap my leg, and they go ow, and like coming up to it, they go ow, 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 ow. How do we know it's not multiple breaks rather than just one clean break or something like that, big break?
We'll see shortening, rotation, things like that. Okay, if we suspect that the MOI caused a shattered femur, right, then we'll hold off on that. Right, but if it's, again, they're going to have pain local to the region, and then obviously increases as it goes. But if the apex of the pain is right here in the middle of the femur, probably safe to assume that it's an isolated mid-shaft femur fracture. Okay. So, as far as this splint, is this splint proper?
No.
Why not?
They didn't expose the leg.
Exactly. Thank you for remembering. Okay.
You're welcome.
So, right, they did not expose the patient's leg. Therefore, again, it's not a proper splint. Is this one proper?
Yes.
Yes. Okay.
I wasn't looking.
Okay. So, as far as this leg, yes, this is proper. Okay, he's wearing shorts. The leg's already exposed as far as the knee. We have the pillow there to keep it in the position found. Because again, they're not going to throw all of their weight on the leg. They're probably going to bend a little bit, and we're going to keep that bend in place. Okay, with dislocated knees, again, you can pretty much tell the difference when that knee is no longer where it should be. Okay, just as you can tell the difference with patellas. Okay, where they're not where they should be. Okay, and with these dislocations, we just splint. Right, follow your rules of splinting.
How do you splint patella?
Just put the splint over here. Just put it around the side and that's it. Yeah. All right. With a tib fib fracture, okay, that's where you tend to have compound fractures, okay, where the skin is broken due to the bone protruding through, okay, and we obviously take care of what first, splinting or bleeding? Bleeding, right, and then we go and apply the splint afterwards. All right. With ankle injuries, super duper common. All we do is follow the rules of splinting. Okay, and for certain types of ankle injuries, right, we can use the pillow splint. Thought I had a picture of it in there. Right, so we'll go and use the pillow splint.
For specific type of ankle
is that the same foot in both pictures?
Yes.
Oh.
Okay, because they didn't chop off two different people's legs.
Yeah,
So-
it's the same person or different person, same foot. Like it's they're both
Do you share?
right foot is gone, but it's different people. Same foot, right foot. Is
No.
different people.
Okay, so as far as amputations, okay, we're gonna go and take the amputated body part, wrap it up in a dry, sterile towel. Okay, with soft tissue injuries, if it's dry, we keep it
Dry.
If it's wet, we keep it wet. Okay, but in this case, wrap it up in a dry, sterile dressing, put it in a plastic bag, keep it cool without letting it freeze, without letting it get wet, and then we transport it to the hospital. Obviously, before we do any of that, we take care of the bleeding on the stump first, right, and then we take care of the amputated part.
Except for ears, right? Why do we keep ears?
I don't know. I've never really looked into that.
Is it
Just
because
for
there's so
fun.
much stuff inside?
In the
Like,
ear?
they're so sensitive?
But like,
No,
so
it's the
outside,
external
like,
portion of the ear.
That's what I'm saying. There's so much stuff going on in there, and they're so sensitive that you can keep it dry. Cause like
No, we're talking about like this part here, the actual inner ear.
no, that's
Okay,
what I'm
that
saying.
makes
Cause like
sense.
when you get like frostbite and stuff like that, your nose, your ears, and your fingers get fucked up really quickly. So like it makes sense.
It's because there's lack of blood vessels, right? The ear's not super vascular, right? There's not a lot of blood going here, right? The nose, yeah, it's quite vascular. Obviously, your fingers are vascular. Earlobes, maybe, right? But for this portion up here, there's not a lot of blood, right? So it's going to get frostbitten anyways because there's no blood circulating. So just
Maybe it's the same reason like that. Cause there's a lot of blood vessels that they need to keep it. They can keep it wet without worrying about that type of
could be. I don't know.
process.
Maybe. I mean, it kind of makes sense, but I don't know enough to really look into it to be like, oh yeah, that does or doesn't. Anyways, with compartment syndrome, okay, that's we have that large, massive hematoma, okay, developing under the fascial compartment. The fascia is the covering over the muscle.
Fatty.
Okay, no, it's not fatty.
It's just-
okay, it's just very tough. So it's going to go and start building up pressure inside there, making that tourniquet effect from the inside out. Okay, starting to compromise this CMS. All right, so with compartment syndrome, again, it takes about 6 to 12 hours for that to develop, so it doesn't come on just like that. It does take a fair amount of time for it to start building up. Okay, the patient will have lack of compromised or will have lack of CMS, the injury, as that pressure builds up. So we splint it, keeping it
Level with the heart.
level with the heart. Okay, apply a splint. All right, and then apply ice as well.
What if it's a leather that we just let them supine and try and keep it all?
Yep.
You can't just lift it to the.
No. Okay, want to keep it level with the heart anyways. Yeah.
That's all in line.
All right. So with pelvic injuries, right, lots and lots of blood loss from possible pelvic injury. So we just got to look out for signs of shock, treat for shock. For eye injuries, okay, for DOT and National Registry, they want us to cover up both eyes, whereas LA County only wants us to cover the injured eye. Okay, so whichever eye is injured, we're going to go and wrap up. But again, for DOT and National Registry, they cover up both eyes. Now, if our patient has some type of chemical injury to the eye, yeah,
What's the next statement? Just
what do we do?
okay. That's what I wanted. It changes depending on that. So what do I do if they have a chemical burn inside their eye?
Mhm.
We would flush medial to lateral, trying to get the chemical out of the eye using water. And we can also use like a nasal cannula, so you can place it on here and use water to flush out chemical burn out of medial lateral. And 15-20 minutes after the burning has stopped.
Okay. And what if they have contacts?
But depends. Because certain contacts we can take. Is it dry contacts we can touch and take out? The other ones we have to use the thing and you squish and you suction and you pull it out like that. You get take contacts out because they can trap chemicals underneath there and keep burning the eye.
Okay. And what do I do if there is no chemical in the eye and they have contacts?
Is there an injury to the eye?
Sure.
I would still. What type of injury is it?
General injury.
That's hard to say because if like they really need to see maybe in the injured eye take it out and on the uninjured eye because you want them to still have some like the LA we want them for injured eye because you want them to be able to see anything else around them. So if you take it out of both eyes and they can't see with it, then that might make them more crazy. But I would say no. You take it out for chemicals because chemicals can be trapped underneath it, and that's the worry. If there's just a general, my eye hurts. Like I don't understand. Is this like stuff in their eye? Like did they get like specks on their eye? No, it's just it's hurt. Fuck it. I'm gonna say yeah. Take his shit out. Take it out. No, you don't. Take it out unless it's you don't take it out.
What? You just said both of them.
So all the stages of grief, all right there.
I don't know. The reason why you take out for chemicals is because there's stuff trapped underneath it. If say
You take it out because there's stuff underneath it. If it's say like they got stuff in their eye, then you'd probably take it out because you're worried about maybe getting trapped underneath it. Say they got fucking a bat to their eye, they got smashed across the face. I would say take it out because that could cause stuff to get into their eye and cause trauma.
No, you leave it in unless there's chemicals in the eye.
Right. Now, if they do have something on their eyeball, can we take it out?
Nope.
No.
No. When can I remove an object if it's in their eye?
If it's underneath the eyelid on the skin.
And how would I do that?
You would take a not a Q-tip, but a Q-tip. A cotton swab. And you would flip the eyelid, and then you could use another cotton tip swab to take off object.
You would take the eyelid and then like roll it, kind of, and then with I have it written down, with the cotton tip applicator, swipe out whatever is was stuck inside the eye.
Everything Hinata said, except the second cotton tip applicator has to be moistened.
Right. Okay, so we use a second moistened cotton tip applicator, to go and remove the object out from underneath the eyelid, not on the actual eyeball itself. Okay, so we want to go and just try to pluck it out. Okay, but again, if it's on the eyeball, we can try to flush it out. Sure. If they have an impaled object in their eye, Chris, what do we do?
You can either use a donut, you can either use a donut or like a Dixie cup cut or something, just because you can't remove it, so you need to stabilize it in place, and so you can use either a donut made from gauze or arts and crafts. Cover it up, cover it up the dry, or for DOT, cover it with that is.
Right. Okay, so we'll go ahead and cover up the eyeball right after we stabilize it using whatever we have, donut or cup. Okay, so again, use our cotton tip applicator, dry one to flip, moisten to remove. Right, if there's an impaled object, make a donut. Okay, stabilize it. Right, and then wrap it up. Obviously, both eyes are covered. Therefore, that is again DOT protocol. If it's LA County, we want to leave that uninjured eye clear. For chemical burns, right, we're going to flush for 15-20 minutes till after the burning has stopped. Okay, even if it were a powder chemical, so it would become liquid anyway. So we try to rinse. This is the only exception, right, when it comes to dressing eyes with dry dressings, because when it's wet, we want to keep it wet, and the eye is supposed to be wet. Okay, so we want to use dry dressing just so we don't complicate it and make it even worse. All right, for thermal burns, okay, definitely want to transport them to a burn center, okay, because they may have other issues going on, and obviously the eyes are kind of important for quality of life, okay, but it may not necessarily be considered a critical burn criteria.
I figured out what fracture told us about earlier. Blow-off fracture, right? The Cookie Monster is.
Blow-off fracture?
So when you do the dry dressing, is the eye closed or open?
It depends on how they're going to have it. We don't necessarily put too much pressure if it's open, but if it's closed, we can put a little bit just to cover. And that's about it.
Okay.
Yeah. All right. For lacerations to the eyeball, okay, do we want to put a lot of pressure on it? No, right? Because you may rupture the globe since its integrity is probably already compromised as it is. Okay, if the eyeball is dangling out, do we pop it back in? No. We use what kind of dressing? Moist dressing to very loosely secure it to the head, right, and then transport. Okay. As far as our different types of other eye injuries, we have retinal detachment, where the retina has been detached. Okay, so our patient will start to have some type of visual issues. Since the retina is what processes the light, okay, to be sent through the optic nerve, not the ocular motor nerve, right, which controls movement. The optic nerve just takes that information to the occipital lobe and processes what we see. Okay, with the blowout fracture of the orbits, right, that's where we get the Cookie Monster eyes. Okay, where the eyes are moving in different places. Now, as far as hyphema, that's where we have blood building up in the anterior chamber of the eye, typically seen with traumatic asphyxiation, where we have crushing injuries to the chest. Okay, and we'll see that a little bit later on. All right, as far as unequal pupils, okay, that's where we have one eye that's regular size, one eye that's bigger, okay, where they're not the same size, hence why they are unequal. Okay, for contact lenses, again, we only take out if the patient has a chemical burn, otherwise we leave it. Okay, All right, we'll take our break here. So we'll come back at 8:30 since we don't have a quiz. Okay. Pete's hopefully here. I'll have to go check my phone. But yeah, so we'll be on break till 8:30. Forward, and we can take some ice, right, and go ahead and place it over there. Right, with a posterior nosebleed, more difficult to treat because we really can't get pressure all the way in the back of the sinuses, right? But we still want them to lean forward so they don't swallow that blood. All right, with the facial fractures, there we go. Okay, we try to do the best we can to maintain their airway. Okay, yeah, except the NPA. Okay, because again, in this patient, it'll just go right up, poke them in the eye. Okay, so right, they've got the patient intubated since that is going to be a more secure airway. Okay, if that is going to be an option. Now, as far as broken teeth, Chris, what are we going to do if the patient has any broken teeth?
If they're in their mouth, we're going to sweep them out, and then we're going to put them in either sterile setting or glass of milk.
Okay. What else do we have to be considerate of?
In terms of like time they're out?
Just in general. They got broken teeth.
Choke on broken teeth.
Sorry?
They can choke on them, but that comes with like sweeping out of the airway. Bleeding in the mouth.
Okay.
We'd have to suction.
What are the rules of suction?
Suction on the way out, not the way in. 15 seconds for adults, 10 seconds for peds, and then 5 seconds for kids.
Okay.
And if you suction for 15 seconds for an adult, and then it just fills back up, you have to, ventilate for 2 minutes and then try again.
Okay. And if we don't have the cold milk with sterile saline, what else can we use for the teeth?
Milk.
If we don't have that?
There's saliva.
Right. Okay, so we can go and use the patient's saliva, right, if they have any of those broken teeth, okay, after we've gone and collected. All right. As far as tracheal injury, like we said earlier, they may have that subcutaneous emphysema, but no tracheal deviation, no JVD. Okay, just the subcutaneous emphysema. As far as impaled objects in the neck, okay, if it's in the trachea, what do? Take it out. Otherwise, we
leave it.
Stabilize. Once we leave it, we stabilize. Okay, and then we go from there. All right. Yes. Okay. Due to the fact that she's on what looks to be a metal table, yeah, she's.
I just saw the blue sign.
Oh yeah.
All right. So, as far as patients who have a carotid artery laceration, that's where we take that pressure dressing, place it on the neck, and we anchor right on the opposite armpit using that figure 8 method. With the jugular vein laceration, we take our occlusive dressing, tape it on how many sides?
4 sides.
Right, all 4 sides to prevent any air from going in, creating what complication?
Air embolism.
Right, air embolism. Okay, we don't want that stuff getting in there.
Wait, you said pressure dressing. Is that any different than just like 4x4 with used pressure, or is it like a special?
It's nothing special, yeah. All right, so with chest injuries, of course, we have open chest injuries where the chest is
Open.
i.e. a sucking chest wound. Okay, where we have closed chest injuries where the chest is still closed. Okay, now as far as our different types of closed chest injuries, Ramon, what are the different types of closed chest injuries?
Closed chest injuries, would they be broken ribs?
Okay.
Broken ribs, then that could lead to internal bleeding with those ribs, cutting the organs.
Okay. What else do we have to worry about with those broken ribs?
Well, specific condition would be that if there's 3 or more ribs broken in 2 or more locations on the chest, then there will be a flail chest, which would present as paradoxical movement when the patient is breathing.
Okay.
You could put, there will be potential pneumothorax.
Sure.
With close. Oh yeah. It could potential pneumothorax. That could go into tension. And another thing could be some sort of edema that would travel to would you have to worry about I'm done.
What else?
For closed chest injuries? Do we have a puncture one?
Look at that.
Yeah. Already said that.
Okay.
It's like when you get hit specifically. Perfect.
Internal bleeding comes commonly. Okay. Major trauma. We got our lungs in there, we got the heart in there, you know, you got the lower airway. They've been crushed 4 or more hours, it's pretty dead.
Yeah, sure, okay. Again, what other closed chest injuries are there?
Let me see.
Daisy?
So there's a certain closed chest injuries for kids only, is if like they get some sort of blunt force trauma that at the right time that it could, not at the right time, but like at the right time that the heart is like pumping.
Okay.
So it would basically make the heart stop and they just drop dead.
Go into what rhythm?
Defibrillation. Sorry. It would be VFib.
Okay, what do we call that condition?
Commodio cordis.
Okay, what else are we going to see in the chest with a closed chest injury?
Maybe internal bleeding because the ribs, if they were fractured, they would
Okay,
come
but
from
what
the
else?
organs.
Besides rib and lung injuries?
Rib and lung injuries. Closed. Rib, lungs, bruising, internal bleeding. Besides what? I'm sorry, you said rib and
Rib and lung injuries. What other type of closed chest injury is there?
I mean heart problems.
Such as?
It could squish the heart or something. No. Heart problems. I mean, I'm not sure. I don't know.
Axel?
Did somebody say pneumothorax, right?
Nope. So what else?
Pneumothorax.
Okay.
Pulmonary contusion.
Okay. Already covered that.
Traumatic asphyxia.
Okay. Crushing injury to the chest. So what else?
I don't know. My notes are bad.
Spontaneous pneumothorax.
It's not a chest injury. Erica?
Pericardial tamponade.
Right. And what are we going to see with pericardial tamponade?
Beck's triad.
Which is?
Low blood pressure, JBD, and hypotension.
Well, that's the same thing as low blood pressure.
And weak pulse. No, wait. Yeah, narrowing pulse pressure. JVD, and muffled heart sounds.
Right, finally. Okay, so that patient is getting muffled heart tones. Okay, and what kind of shock does that fall under?
Wait, say that again.
What kind of shock does that fall under?
Cardiogenic shock.
Sarge? Obstructive. Okay, so right, that patient's going to start to develop obstructive shock when they have cardiac tamponade. Okay, so again, open chest injuries, the chest is open. Closed chest injuries, the chest is closed.
Is there a difference between pericardial and okay?
Okay, so as far as a hemothorax, right, that's just a collection of blood in there,
Potential space.
whereas a hemopneumothorax, there's blood and air in there,
Potential
Potential space. Okay, now as far as recognize the difference, okay, with the hemothorax, they have diminished lung sounds that start where? At the bottoms, okay, and then slowly start working their way up since all that fluid starts developing at the bottom, at the base. Okay, whereas a hemopneumothorax, right, we get diminished everywhere because we got the fluid starting at the bottom, but the air putting even pressure everywhere else, squishing in that lung.
That's not any type of edema because the lungs are still intact.
It's the fluid is outside of the lungs.
Outside?
Yeah.
Okay.
So we still get the diminished lung sounds and not the rails. Okay.
Okay.
So with spontaneous pneumo, again, that's a non-traumatic chest injury, okay, where it's not caused by trauma, right? Again, those tall, white, skinny males and COPD emphysemics. So for the chest we've already hit, cardiac tamponade, traumatic asphyxiation. So there we have the traumatic asphyxiation. Okay, so again, all that crushing force applied to the patient's chest started to move blood out to other parts. Now, if we were to open up the eyes, what would we see?
Bulging red.
Wait, what? Asphyxiation? It's blood building up.
What do we call that?
No, it's
Hemophilia?
You go back to the couple slides.
Hemophilia?
It's hemo because that's blood.
No. Hyphema, yes.
Hema.
Okay.
Hema?
I can't read. Hyphema.
Oh, that's why I
Okay.
wasn't getting it.
Right.
Hyphema.
So you need to go to Derek Zoolander School, sir. So as far as for kids who can't read good, do other stuff.
Ants?
Yes. Okay. So we want to go ahead and check for hyphema, indicating that we have rupture of capillaries inside the eyes, causing blood to build in the anterior chamber. All right. So as far as aortic shearing, okay, that's when the aorta and the heart attach. Anything we can do for that?
No.
Nope, because they're
Dead.
Yeah, they're dead. Okay, so we just put on a show by doing CPR and just get them in the hospital. Right, again, that's what we're gonna do there.
CPR on dead people. They're not really dead people.
Well, they're not obviously dead.
Yeah, wait a second. I thought we don't help dead people.
No, we help dead people.
No.
They have to show
We
the
don't
signs
transport
of
dead people.
the signs of being dead.
Take them to the
If
hospital.
I know they have an aortic shearing, I
All right.
I don't know.
What are the obvious signs of death?
Rigor mortis.
Which is?
Hmm?
Which is?
When their body's sleeping.
Okay.
Putrefaction.
Which is?
When they're decaying.
Okay.
It's the one where blood is pooling. Lividity.
Okay. Lividity.
Lividity. I'm checking this.
What was the second one that she said?
Putrefaction. Decomp.
Oh, okay, okay.
Oh, if their body is, I didn't see it, but if their body is like if they're decapitated or something.
Which is an example of.
Decapitation.
Yes, but decapitation is an example of what criteria for obvious death?
Obvious. obvious mortal injury.
What are some other examples of that?
Evisceration of the heart or lungs with no pulse.
What else?
Abdominal organs with no pulse.
Okay. What else?
Like of obvious mortal injury. If their brain was outside their head. Or like their heart was outside their head.
What?
I mean outside their body. Outside their body.
If I was inside the head, again, that too would be an obvious sign of death.
Yeah. Yeah. Obvious. Yeah. If they're cut in half.
People survive that.
No.
No.
That's absolutely
Have you
true.
seen Dewey Cox?
Huh?
Somebody got run over by a train. He's fine. He's just half
It's not fine. Yeah.
If they're
He's half
split,
the man
if
he
they're
used to be.
split in the coronal plane,
You're getting fancy here.
the transverse lane, it's one I can go on. It's a bunch of be dead.
George?
Huh?
What's another form of obvious mortal injury?
Their head and all their limbs are cut off.
Again, we've already covered that. Decapitation.
They're frozen solid.
Okay.
Oh, I know what you're thinking of.
He's looking for something specific.
I know what you're thinking of because you
I
said
said
it.
it all.
No, you didn't.
Oh, I know.
No, you don't.
I know.
No, you don't.
Yes, I really do.
Oh, really?
Yes, I promise.
So you want to say it so we can take a point away?
I think so.
No, so we'll go back to you.
Sorry?
What is it?
My turn.
No, because he skipped him to go to her because she said obvious
him.
death.
Are there burns to Chris?
What do we call that?
Let me see.
Well done.
swear.
Well done, Huey.
I wish our question was
We
split.
said like 7
The
days.
simple finger split.
So I don't know what the 5 are. I've always been confused.
Ignacio's thinking.
I have to think of those.
Ignacio, please. Even I know this terminology. Dad, I know terminology.
No, it's good.
Well, he wasn't obviously dead. So.
But he's a Jedi. He's not a normal person. Probably.
If they're that close to magma, they're gonna not on fire and you're not touching it. Dead.
Still wasn't dead though.
Well, he's super god.
He still died.
Yeah, after a very, very, very long time,
Still
he
died.
got thrown off. I'm like Emperor Palpatine, and I'll live for a million years. And turn up and then fucking shitty grave.
Gotta be like Jar Jar.
Yeah, die. You're a useless character that no one likes. No, he wasn't.
You're like,
This is
Multiple thickness burn around the body.
Right.
Yes!
Okay. So, right, if they are fully
Is it up
incinerated,
there?
where they are burnt to a crisp, okay, again, that is going to be another sign of obvious death. All right. So there we have commotio cordis. Okay, it happens to kids because kids are
Dumb.
freaks. Okay. Yes. Okay, but still freaks nonetheless.
Kids
Okay.
get behind drives down the way.
So, as far as them being freaky, okay, the ribs again are very flexible as well as the sternum. Okay, so when they get some type of blunt injury at the exact wrong time, okay, during the heart's electrical cycle, okay, then it's going to go and cave in, transfer energy to the heart, put them into what rhythm?
V-fib.
V-fib. Okay, and then you want to go ahead and try to defibrillate as soon as we possibly can.
How much force do you need after to apply to a child's chest before it breaks?
I'm not going to tell you, sir, because
Boom!
I actually don't know.
Is it possible to give a child full chest?
It's more difficult.
So get your instinct for extras first.
You have one that has
Throw my child off the building. You're vulnerable, Ben.
All right. So as far as different types of open injuries, right? So we have abrasions, okay, which is going to be a friction burn affecting the epidermis, okay, going after that outer layer of skin. Do we treat these?
No. Yes.
Yeah.
Yeah, but usually we don't because there's usually other issues we got to take care of. Okay, but if we do have to dress it because the skin is dry, we want to keep it dry. So we throw a dry sterile dressing on, try to keep it as clean as we can. Now, as far as lacerations, okay, we use our traditional bleeding control methods: apply direct pressure, elevate and wrap, and if that doesn't work, we apply a tourniquet. Okay, now with certain types of injuries like these two, what else can we do?
Pack the wound.
All right, we can go and pack the wound, okay, to try to maintain that pressure as we go ahead and wrap. Okay, with partial avulsions, again, we try to put that flap back, do some basic bleeding control, go from there. And if it's completely detached, we treat it like an amputation. Okay, so go ahead and stabilize. Right, if they have any of those penetrating injuries. For gunshot wounds, got a few more things. Gunshot wounds, okay, we have our entrance wounds and exit wounds. Okay, entrance wounds tend to be a little bit smaller, exit wounds tend to be a little bit larger, and we have to worry about cavitation and things like that. Okay, is it our job to determine exactly what caliber the patient was shot with? No. Okay, we just want to know, right? Okay, was it handgun, was it rifle, was it shotgun? At least try to determine that so we can determine, okay, do we have to worry about permanent cavitation, how much of a temporary cavity, et cetera, et cetera. With these, crushing open injuries, just do the best you can. Cool, so let me just go ahead and skip over to the rest of these things here. We've already covered it. Now let's see if that's on the screen for now.
I'll eat my pizza while I look at these guys. Delicious.
God, you're so brave.
When it comes to bites, okay, we always assume a bite is infected.
Oh.
Okay, no, not always rabies. Okay, assume it's infected. Okay, possibly with rabies, depending on the animal. All right, such if it were a rodent or some other forms of mammals. Okay, so again, those rabid squirrels that are running around the parks. Okay, if a patient gets bit by one, then we have to suspect.
Raccoons?
All right, they may have rabies. Yes, they're animals. Okay.
I love those.
There's one common animal that people think can get rabies that actually.
I don't think raccoons can. I don't think raccoons can.
No, raccoons can because my dog got attacked by a raccoon. That's why I don't like raccoons. But they did have to go do a rabies test to make sure she didn't have it.
But
so no, raccoons
what
don't have to
about-
worry
It's
about
a
it.
super common one. It's like, oh, they all have rabies.
Why are possums, I think?
I think
are marsupials.
yeah.
Possums are marsupials. They're not rodents.
Might be. Whoa. So, as far as human bites, again, everybody's what? Nasty. Okay, so we have to assume whenever somebody's been bitten by somebody else, we assume they automatically have a what? Infection. Okay, that can lead to other complications. So now, we get to burns. Okay.
Oh, I got this. Let's go.
All right, so when it comes to burns,
I'm listening.
okay, when it comes to burns, we have to try to identify the depth of the burn. Okay, be it a superficial, aka what degree?
First degree.
Be it a partial thickness, aka
Second degree.
or full thickness, aka
Third degree.
Okay, we got to figure out how much the body has been burned and what was the source of the burn. Was it thermal energy? Was it chemical, electricity, et cetera, et cetera? Okay. Now, when it comes to the rule of nines, okay, what is the percentage? Actually, you know what? No, let's go ahead and write it down.
Okay. Oh, my eyes. I was going to my brain catalog.
Everybody or?
No, just 10.
Woo!
Yeah. Okay, for
Give me
this,
that.
we'll go ahead and do lightning round. All right, so let's just
Wait,
go ahead.
Wait. What does that mean?
That means
Whoever gets it first.
yeah.
You bastard.
So we'll partner up.
She's
Yeah,
smarter
right.
and faster.
So we'll be captains. Okay. Now just to make it fair, okay, stand up.
I need to take this up. Wait. I need to. Yeah, he's got it.
Earmuffs.
This
Wait,
is stop
yeah,
my
clothes
arm.
under?
You don't have to know, sir.
Yeah, no, I'm gonna show my bare naked chest to Vince. His girlfriend did leave though, so it's okay.
No.
That's
So,
okay, that's still sexual.
as far as face that way.
Wait. Oh, my pants are dropped. I have shorts on, but they're shorts.
Okay.
Today, you.
So these are all just adults until get to.
Can we get ready to write it this way, or
No.
we like sticking our ass out?
Nope. Just stand
Armpit
facing
chest?
the other way.
Wait.
I can see you, by the way. So just face the other way.
All right.
There you go. All
You
right.
can see me?
I can see you.
Eyes in the back.
Okay. That's why it's the occipital region, sir.
We're going?
No, not yet. I'll tell you when.
Don't believe in me. Believe in him. I have 87, he was 94. I got 69% of this test.
How did you get a 69%, sir, when every question's worth 4 points?
I don't know. I got 69%.
No, it's not.
That's
69?
every question you miss is minus 4%.
Yeah.
I don't know. I just read what's on my paper.
Oh no.
That's how bad I am at doing math.
Oh.
You didn't even do the math. You just
Hey,
accepted
get ready,
it
get ready.
All right. 3, 2, 1.
Oh,
stop.
Point.
All right, so head and neck is worth 9. Enter your chest is 9. Right arm is 9. For a grand total of
27.
27. See, you weren't even right anyway, sir.
Whoa. I would have been right if you gave me a second.
Yeah.
Be smarter, faster.
It
You
wasn't
think
for
I'm
the
capable of
kids
both
on
those at the same time?
dog. All right, anyways.
I genuinely believe you can.
All right, so let's just go ahead and move on down. All right, so Brent and Cheyenne, go and stand up. Okay.
I can touch Brent's button.
Oh, you were here. I thought you could hear me.
All right. All right, 3, 2, 1. Okay.
No, don't look. Don't look. You can keep your mouth.
Cool.
Woo! 23.5, right?
Yep.
Yeah, because torso is 18.
Okay.
Interior torso.
I just had that.
Torso is
What was the?
Yeah.
abdomen is 9,
23.5.
chest is 9, both of them
Okay.
are 18.
All right, Axel, Erica.
Can I go more to the middle?
I got you. No, I got.
Yeah, that's fine.
Oh man.
Try this.
All right.
Oh, we have to turn around.
Yeah, turn around.
He's closer to the board. Is that cheating?
No, you just can't see from that angle. It's there.
Yes. I'm trying to
All right, 3, 2, 1. Let's write it down, sir. Okay. So, pediatrics. All right, Daisy and Dart. Perfect.
Okay.
Dart, you can move in if you need to.
I'm fine with
All right, cool.
Dang, he said he's got better eyes than Axel.
Eyes like
I have a question about the burns
Give me a second.
for adults.
Yeah. Give me a second. All right, 3, 2, 1. You can just hold it up. All right, so for pediatrics, the head and neck, because kids are freaks, the head and neck is 18. All right, anterior chest is
9.
Left arm is 9, right? Because everything in the middle is still the same. Okay, so essentially we get a grand total of 36. Okay. All right, Ignacio and George.
I have a question.
Yeah, sorry.
So for the extremities, the lower extremities per leg, let's say your whole leg got burned, that's 18.
For who?
Adult.
Right.
Is PSP ABD posterior abdomen?
Yo, you just
Sorry?
Is PSP ABD posterior abdomen?
POST.
POST, ABD posterior abdomen.
Yeah. Okay. So, pretty much writing an answer on the board, or a question on the board rather, for rule of 9s. First one to answer correctly gets the point for the team. So, no, stand up, face the other way, because I read it on the board. It makes sense if I write it and you guys calculate. So when I count down from 3, then you go. Okay?
pediatrics, right?
Yeah, yes. So, easy point. So, all right, so.
It's a 2v1.
No, it's a 1v1. Sit down.
Oh, sorry, I'm just.
All right, so let me go and write the question, then you guys can turn around and count down.
Is it soft?
All right, 3, 2, 1.
Wait, why are you?
He's practicing.
Go, I gotta prepare, man.
Okay.
Nope. It's just
So, as far as the posterior chest and posterior abdomen, that's basically the what?
Torso.
That's basically the torso, okay, which for a kid is
18.
18%. The legs in total are worth
13.5.
13.5. Okay, so we get 31.5.
Was it 18?
No, not for the legs.
It's a pediatric.
What's up?
Or if they got really adult legs.
No.
They could be Mr. Fantastic. Stretch out.
All right, Inanna, and yes.
For the adults, what is their butt? Is that the groin?
It'll be part of the legs, basically. So one cheek versus the other.
That's when we'll do proximal.
No, it's just more along posterior, anterior.
You should be.
All right. Alrighty.
Oh, that's kind of. So you were the person in the moment.
Oh, yeah.
All right, 3, 2, 1. Okay.
What'd you rate?
I don't want to say it.
That was wrong. So,
I said 37.
What?
What's 27?
It was 28. Like, can I know the math behind that one?
Yeah, so face and neck for a pediatric is.
Oh, I didn't see the groin up there.
Oh! Wait, face and neck. Oh, it's 9. I put different.
18.
Yeah.
Yeah. You don't read the question, sir. All right. So, as far as rule of nines, okay. Obviously, okay, we got to be able to calculate that. Now, as far as the percentage and severity of the burn, okay. When it comes to the percentage, all right, with severity, actually, we'll just go with critical burn criteria. So, Daisy, what is automatic critical burn criteria?
Critical burn?
Yeah,
Is
automatic
there,
critical
like
burn.
certain places, or is there, you're asking for a percentage?
Automatic critical burn criteria, not percentages.
So it would be the airway. I guess you feel like it's 7. Automatic.
Automatic critical burn criteria.
Okay. So it would be the reproductive area, so like the groin, the hand, like the feet, the head. If it was a circumferential burn, the said.
Full thickness burns to the hands, feet, face, airway, genitalia, or circumferential burns to any part of the body. Which means it goes all the way around. Do you want more for critical burns? Full thickness burns covering more than 10% of the body surface area. Partial thickness burns covering more than 30% of total body surface area. Or any burns associated with a respiratory injury of any thickness.
Okay, so where are the burns at that are full thickness?
Hands, feet, face, airway, genitalia, or circumferential burns to any of the body parts.
Joints as well.
Right. Okay, so hands, feet, face, airway, genitalia, joints, as well as other circumferential burns of body parts. Okay, when it comes to percentages, right, anything over 10%, okay, with a full thickness burn is considered critical. Partial thickness over 30, right, is full thickness, and any type of burn that involves a respiratory injury is automatically critical. Okay, when it comes to pediatrics, what is going to be the age range for modification, I guess?
Anyone under 5 years old.
And on the other side?
Older than 55 for pediatrics.
Why?
Why? They're considered more for kids. Like the burns are considered more serious, and they have more surface area relative to body mass. Yeah.
Okay, but why is it considered more serious?
They cannot compensate like we do for longer periods of time.
Okay. And what about geriatrics?
Similarly, their functions are now slowing down or failing, so they may not be unable to compensate like people in their 20s, 30s, or 40s.
Right. Okay. So again, both patients just don't have compensatory mechanisms that are very strong. Kids are still developing theirs, whereas geriatrics are losing theirs. Okay. Now, when it comes to moderate burn criteria, what is moderate burn criteria?
Full thickness burns between 2 and 10% of PSA, and partial thickness between less than 30, more than 15%.
Okay. I have no idea what that was, but okay.
Let's say 10 or 15. 15 or full, partial, superficial, more than half PSA. And For moderate burns, and if they don't fall within those under 5/55 range. Yeah. Full, partial, and superficial.
So what is about these full thickness burns?
What else about the full? Oh, if they're not covering the hands, feet, joints, genitalia, respiratory, and face.
Right. Okay. So, okay, full thickness burns as long as they don't involve any of the automatic critical areas, somewhere between 2 and 10%. Right. As far as minor burns, Ignacio, what is minor burn criteria?
Oh, minor burns. Full thickness burns involving less than 2% of the total body surface area. Partial thickness burns covering less than 15% of the body surface area. And superficial burns covering less than 50% of the body surface area. And yeah, that's all.
Anything else?
No, sorry.
Nothing about the full thickness burns.
I said that was the first one. Full thickness burn involving less than 2% of the total body surface area.
Axel.
That's excluding the hands, feet, face, airway, genitalia, joints.
Right, because the groin is worth what percentage?
1%.
Exactly. Okay. So, right, if the patient were to have even a full thickness burn to the groin, even though it's only worth 1% of body surface area, it's still an automatic critical area. Okay. It does. Okay, so as far as our superficial burns, right, we're going to have just reddening of the skin. Okay, generally not life-threatening unless it's one of our special patient populations. Okay, being those less than
5
or over
55.
55. Okay, but again, for most of us, not a big deal. Okay, with the partial thickness burns, we start getting development of blisters. Okay, and all those blisters are full of plasma, and that's why it leads to what kind of shock? Right, metabolic hypovolemic shock. Okay, as far as the full thickness burns, right, that's where you have that damage going all the way through, okay, destroying nerve tissue and whatnot. So in the area that's fully burned, is it going to hurt if we press? No. Exactly, okay, because the nerve endings are dead, therefore they will not be sending out any pain signals. Okay. Now when it comes to complications of a burn, actually we'll go with treatments of a burn first. Shannon, what is the treatment for a burn?
What kind of burn?
Let's say it's just a regular thermal burn.
High flow to prevent heat loss from the body, so thermal burn kind of thing. And rapidly assess their severity of the burn. You can stop the burn by cooling and using water, usually. Wet dressing to cool it. And for stuck clothing, you leave it on. And you like turn around it.
Okay. What are some complications of a burn?
Like respiratory complications.
Well, besides that, because then it'd be critical, just general burns, complications.
Infection, hypothermia. Shock.
What kind of shock? What kind?
Non-hemorrhagic. Shock. Non-hemorrhagic. Non-hemorrhagic hypovolemic shock.
Wait, what kind of dressing did you say put on?
So wet to cool, but she said dry dressing earlier. Okay, so wet to cool, right, dry to dress. Okay, we got to worry about hypothermia. Again, ironically enough, burn patients tend to die from hypothermia, right? Because they got these big old gaping wounds. So as long as they're not fully incinerated, right, which again is obvious death, okay, then they're more likely to die from the actual hypothermia infection as well as hypovolemia. Okay, so we're going to go and use the rule of nines or rule of palm if it's covering less than 10% of body. And as far as the rule of palm, it's the hand minus the
Fingers.
Fingers. Therefore, it only leaves the palm. Okay, and of course, is that our palm to the patient's body? No, it's patient's palm to their body, since again, it's all in proportion. So, with the rule of 9, okay, again, we want to break the body down to its different segments. Okay, going through and identifying what body part it is, and just plugging in that number so we can actually calculate the questions correctly. Again, Thursday, scared some of you. All right, as far as Thursday, okay, can you guys come up with a blank piece of paper?
Yes.
Yeah. Yes. Can you write any notes on it?
After.
No.
Before.
Well, not coming in. But yes, once you sit down, then you can write down stuff. Okay, there's probably another thing I would write down if I were you, is write down your rule of 9's chart. Okay, that way if you get those questions, as long as you write it correctly, you at least have a key to be like, oh, I want to go ahead and plug this number into this part, right, and go ahead and just add it in from there. So, as far as breaking it down, again, the head and neck rather can be broken into the face and neck, and that is half, therefore it is 4.5. Anterior torso can be broken into the chest and the abdomen, each one being 9%. Back is pretty much the same thing. Okay, extremities broken down, okay, into their different percentages as well. So, as far as critical burn criteria, any full thickness burns to the hands, feet, face, airway, genitalia, joints, and other circumferential body parts, okay, is going to be a critical burn. Full thickness more than 10%, excluding those areas, because I'm already hit critical. Partial thickness over 30, and then any respiratory injury, okay, following a burn, right, we got to go ahead and treat them as critical. Right, with this, if they inhale superheated gases, what complication are we worried about?
Pulmonary edema.
Pulmonary edema.
Respiratory injury, meaning like they burn and then they just like rupture their trachea, and that's just like a critical burn, or like what do you?
No, it's just they inhale, right, and they inhale superheated gases and they work in the airway.
Superheated and/or toxic. What would sudden lungs do? Because say they don't breathe in the high flow or the superheated CO2 in the air, or they're outside of the building, they start breathing in all the ash and stuff in the air from the burn. What could that cause the patient?
Cause infections.
I'd say it couldn't cause any sort of respiratory issues.
It is going to cause respiratory issues. It could cause infection usually, right? But cilia usually do a good job of stopping that stuff, right? So then they end up coughing that crap up and then just get pneumonia.
Okay.
Yeah. All right. So with moderate burns, right, 2 to 10%, excluding those automatic critical areas. Partial thickness between 15 and 30%, and now we're going to add in superficial, covering more than half of the body. Okay, all moderate unless we have those special patients, less than 5 and over 55. All right, for minor burns, everything less than that. When it comes to pediatric patients, if we see it or suspect it, when it comes to abuse, what do? Report it. Okay, and we have to give verbal notification when? ASAP, and written notification within?
Next 48 hours.
No,
24.
36.
Oh.
Okay, 36 hours.
For burns, why does it matter, like the classification between the critical and moderate burn? Treatment differ?
No, treatment doesn't differ. It just shows how much tissue has been damaged based on the percentage. So obviously, right, if you have 20% of your body covered in full thickness burns, that's a lot worse than 8%, right?
If I say motorcycle accident, it's a, what do you call it? It's a controlled accident. They slide, and they cause almost 100, almost complete full skin graft. They weren't wearing the right protection. They almost completely just cut off the top epidermis. Would that, if say that it was 90% or more of this covered in superficial burns, would that be considered critical because it's so much gone? And it's
That's
such a high risk
different
of infection?
because we're worried more about the actual impact, right, with internal injuries more than the actual abrasions themselves, right? So even though, again, friction burns are a type of burn, it's not really treated the same way.
Even if it's that big, aren't we worried about infection?
No, we definitely are. But again, we're not worried about it being necessarily a burn more so than just soft tissue injury.
Oh, okay.
Yeah. Okay. So, as far as treatment, again, we want to stop burning, okay, by either running water over it or using, again, wet dressings to pretty much dab the area, okay, and then let it cool off. If there's any stuck clothing, do we rip it off?
Yeah.
No, we leave it, okay, cut everything else off. All right, we go ahead and apply O2 if needed, dress in a dry, sterile dressing, all right, treat for shock if it happens to be there, looking out for infection, hypothermia, and hypovolemia, causing metabolic hypovolemic shock. Yeah, from a tiny little burn right here.
Yeah, for such a big firefighter, I don't think that's right, dog.
So, as far as upper airway issues, okay, usually caused by the inhalation of superheated gases. Lower airway issues usually come from chemicals. Okay, and again, if we do get that particulate matter like soot, right, then we start getting worried about infections. Okay. As far as chemical burns, okay, if we have a liquid chemical, we irrigate for how long? Right, until after the burning is stopped. Okay, but in the case of powder chemicals, what do we do? Right, and then flush. Okay, So we just go ahead and try to make sure that we are staying clear of that stuff, right? Rinsing them off for 15, 20 minutes till after burning stop. Again, for our powder chemicals, brush, 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 and then flush.
Is there ever a time when we really shouldn't flush? Like, I know you said that certain chemicals react with water. Are there any certain chemicals where it's like there's like a no-go? You have to use a specific like acid or base?
Not for us. Yeah, because again, we're not chemists to be like, oh, I need to mix this portion.
It's only hazmat, then I have to worry about that?
Yeah. Okay. So we'll go ahead and brush, 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 clear out. As far as electrical injuries, okay, we treat them like gunshot wounds, okay, where they have entrance wounds and
exit.
All right, and is it going to go straight to the body? Could they have multiple exit wounds with electrical burns?
Yes.
Yeah. Okay. We have to worry about it going through the patient's diaphragm, causing respiratory arrest, going through the heart, causing cardiac arrest, and of course treat our patients right as a cardiac arrest patient or respiratory arrest, depending on what issues we have. Okay, so again, multiple exit wounds throughout the patient. There's that fasciotomy that they do in the hospital to relieve that swelling due to injured tissue, because injured tissue swells. Okay, so we may start to see things similar to compartment syndrome, just for class purposes, a little bit different. Okay, but we are going to get that pressure buildup in there.
Why don't they stamp kids like at that point? I see.
Because I can still eat.
Yeah, it's going to be scarred up.
It's never going to work, right? She's never going to be able to really use that leg again. Why not just cut it off and give her another one?
So, as far as our different radiation burns, okay, we have alpha and beta radiation, which again are very weak forms of radiation. Gamma neutron radiation, very, very strong. Okay, or it can penetrate the body, all right, causing a lot of injuries. Again, we got to remember shielding time distance, put as much as we can between us and the source, spend as little time as possible, and get as far away as possible from the actual source itself. Okay? All right.
Done.
No.
Woo! 5 minutes!
You're not coming back tomorrow, or?
I wish I wasn't.
It's actually arranged.
All right. So, pediatrics.
Oh, yeah.
Okay. All right. So, as far as pediatric emergencies, okay, just going to go over this again. We just covered it last week. We've already talked about all the stuff that's going to happen to kids, okay, just make it a little bit different when it comes to the difference between kids and adults. So, as far as our assessment of pediatric patients, okay, are they just little tiny scaled down versions of us? No, they're freaks. Okay, so we just got to keep that in mind, right? Obviously, things are changing very, very quickly with our different stages of development. Infancy is the first year of life. The first month, what do we call them? Neonates. Okay. When it comes to toddlers, 1 to 3, all right, preschoolers, 3 to 6, school age 6 to 12, adolescents 12 or 13, all the way up to 18 years old. Okay, and as the kid gets older, our assessment becomes more and more traditional, okay, like a regular patient assessment. All right. Now, when it comes to different technique that we use to assess pediatrics, what do we use?
Wait a second. Wait a question.
What different tool, let me rephrase it, what different tool would I use to assess a pediatric patient?
Oh, it's a different triangle, right? Weird triangle. It wasn't Italian, actually. The triangle, right? Fuck, no way I didn't write this down. Let me go. Goddamn, that's all the people. Opposite gems.
That's a joke.
Third?
Dark.
Pediatric assessment triangle.
Right. So what does it happen there?
Can you restate that?
It's compromised the appearance, work of breathing, and skin circulation.
Okay. So as far as appearance, what are we really looking for in that category?
If they're aware, if they're awake, if they're upright.
Okay. What about work of breathing?
Noises that they make.
Okay.
And fractions.
Okay. And circulation?
Temperature, color, and moisture.
And when would I do that in my actual patient assessment?
That's in the primary assessment.
Right. Okay. So in the primary assessment, we're going to go ahead and do the assessment triangle. Okay, where we check the appearance right, to see if they are awake, aware, and upright. Okay, if they have retractions, making abnormal noises, and skin circulation is basically your skin signs. All right, looking for color, temperature, and moisture. Okay, so as far as circulation differences, okay, when kids go into shock, do they compensate any different than we do?
They do it better.
They just do it better. That's it. Okay, but their body goes through the exact same mechanisms. Okay, when they start to compensate. Okay, so their blood vessels constrict, airway dilates, heart rate goes up, respirations go up. Okay, as they start kicking their sympathetic response. All right, and they can do that until the bottom drops out, and then they
tank.
Right, they crash, and then they die. Okay, so we got to try to look out for it. So in case of shock, we see it or suspect it, we treat it. Okay, but again, our primary assessment does not change. Don't care about transport. As far as assessment, okay, of different pediatric patients based on age, okay, if they're less than 6, we do a toe to, or if they're over 6, we do a head to toe. Okay, and we can demo use of equipment. Now, as far as vitals, obviously as the kid gets older, vitals start to slow down when it comes to heart rate and respirations, but their blood pressure tends to go up since their bodies are now switching, right, to a different form of perfusion. When it comes to kids, to maintain perfusion, they rely on
cardiac output.
Right, cardiac output. Okay, where they just have to continuously move that blood around the body at all times. Whereas we, as adults, we rely on blood pressure. Okay, we need to keep a decent blood pressure at all times to make sure our tissues get perfused. That's why, okay, we look at things like blood pressure to determine if we are compensating or if we are decompensating. Okay, when it comes to airway differences, kids are freaks. Okay, so they got that big old fat round head with an occiput. Okay, that's going to bring the head down to a flex position. Now, as far as opening up the airway, Ramon, what position do I use to open up the airway for a pediatric patient?
It's a sniffing. It's a hold on. Neutral sniffing position.
Okay, and what could I use to help assist me in putting them in a neutral sniffing position?
A towel in their behind their shoulders.
Okay. Now, as far as use of airway adjuncts, can I use an OPA on a pediatric patient?
Yes.
Okay. What would be different about insertion of an OPA in a pediatric patient?
The measurement. Insertion of the OPA, you would I think the OPA will be measured from the the corner of the jaw. You told me the what is the difference between the insertion?
Insertion of an OPA for a pediatric patient.
You wouldn't. You would just. We still need to measure it. So. No, I don't know. I don't know.
George.
It'll drop right in.
What do you mean?
You wouldn't have to like curve it when you like bring in.
Why not?
Because you're freaks.
He's not wrong.
No, he's not wrong, but it doesn't tell me anything. How does their freakishness make that the reason why we do it?
You think it's more flexible?
Is it because of the shape of the epiglottitis?
They have a small mouth, their tongue, there's no space for filters.
Right. Okay. Big old freakishly oversized tongue. Okay, with a little tiny mouth. But what else do we have to do? What else do we have to use to actually drop it in?
Really reverse that.
Erica.
Something to to depress their tongue to like kind of move out of the way.
So what could I use to depress their tongue?
A tongue depressor.
Okay, so I'm going to use a tongue depressor, right, to go and drop it in. Now, as far as an NPA, okay, what is the contraindication for an NPA?
And they're not for infants.
Right. Okay, so infants. Can't use NPAs on infants. Can I use OPAs on infants?
Yes.
Yes. Okay. Again, kids are too small, right? Infants rather are too small, so we can't use that NPA. As far as the trachea, yes, they do have smaller tracheas. Okay, but again, that has nothing to do with the OPA itself. Right. The epiglottis is much more longer, floppier, shaped like a horseshoe. Okay, and that's why epiglottitis is a bigger issue than them than it really is for us. Yeah, we can get inflammation of our epiglottis, but it's not really that big of a deal. Okay, if that kid has epiglottitis, we're going to see a lot of what? Drooling. Whereas croup kid is going to do what?
Barking seal.
Right. Okay, have that barking seal cough. So as far as respiratory changes, okay, there is that pretty consistent decline that we're going to see in a pediatric patient, starting with respiratory distress, and then, Chris, what happens from there?
Respiratory failure, hypoxia, cardiac arrest.
Okay, so as far as performing compressions on a patient who has a pulse, okay, how is that going to be special for pediatrics?
Has a pulse, but is not breathing. Means we're doing rescue breaths.
Okay, but again, as far as doing compressions, when would I do compressions on a pediatric?
If their heart rate is below 60.
And?
They have shitty tidal volume. Or they're not breathing, so it doesn't matter. Hang on. If their heart rate is below 60, signs of port perfusion.
Yep. Okay. As far as the AED, would I use the AED on that pediatric patient?
Pulse.
Right, because the contraindications are a.
Patients they have a pulse or they're breathing, or they're in standing water.
Right. Okay. So as long as they have that pulse, okay, we still can go ahead and do compressions, but we don't need the AED because they still have a pulse. So as far as retractions, okay, we're going to see drawing in of the intercostal muscles, okay, telling us that kid's using accessory muscles. Okay, with those kids' accessory muscles, are they very well developed? No. So what's going to happen to them eventually? Right, because they're going to stop breathing. Okay, so there we have that decline, failure, hypoxia, bradycardia, cardiac arrest. Okay, when they get tired, that's it, they're done. When it comes to O2 administration, does it really change for a pediatric?
The size of the mask.
Yeah, just the size of the equipment. So really, no, it doesn't. Okay, because flow rates, percentages, everything else is all the same. The only thing that's different, the equipment is because they are smaller. That's it. Okay. As far as cardiac output, again, that's what they're more reliant on. So they got to constantly move that blood around their body at all times. And when they compensate, they do it the exact same way that we do: vasoconstrict, bronchodilate, breathe faster. Right, heart rate's going to go up, and breathing quickly as well. For infants, we check that brachial pulse. All right, and if we're checking vitals on an infant, how long do I check that pulse for?
30.
Right, it's right there on the screen, sir. Okay, so we're gonna go and check for a minute. Okay, go in and check that brachial pulse. Now, as far as blood pressure, right, we don't need to really worry about it in kids that are less than 3 because we have the assessment triangle to use. Okay, to tell us if they're really perfusing okay, and besides, is blood pressure all that relevant for kids? No, not really. Okay. When it comes to capillary refill, if they're less than 6 and delayed cap refill, does that tell us that they're in shock?
Yeah.
Yes, and that's all we need to see to indicate that they might be in shock. Okay. As far as infants, we'll go and check down here at the feet. Right. Older kids, we can go and use their finger. Right, because infants have little itty bitty tiny fingernails, so it's kind of hard to see it. As far as environmental issues, of course, old people and young people don't do so well in extreme environments because they either don't have the mechanism to compensate or their mechanisms are starting to deteriorate. Okay, so as far as what was I going to go? I lost my train of thought here. There we go. As far as compensation for hypothermia, Ignacio, what are the body's mechanisms to compensate for hypothermia?
Wouldn't it be shivering?
Okay.
Rapid. You said indications?
No. Body's ways to compensate.
Compensate.
Brent?
No, I said shivering.
Okay.
Okay. Shivering, vasoconstriction,
Mm-hmm.
increased respirations,
Okay.
and one more, right?
Mm-hmm.
Does that have to do with their pulse? And their heart rate's going to go up?
Okay. As far as compensation for hyperthermia, what does the body do to compensate for hyperthermia?
It'd be convenient, does all opposite, right?
I mean,
Hyperthermia. We're going to start sweating, try to cool the skin, and I think respirations are still going to be high though, increased respirations. Pulse is going to slow down, and we're going to see vasoconstriction instead of we're going to be sweating. I mean, not dilation. Oh my
John?
God.
For hyperthermia,
Mm-hmm.
they're gonna have a muscle cramps.
That's compensation.
For hyperthermia. It's the signs and symptoms.
How does the body compensate for excessive heat?
Sweating
Okay.
and vasodilation.
Why do they vasodilate?
Because the body's trying to get the blood to the surface so it can get cooled off by the sweat.
Ideally, but with vasodilation, what heat transfer method are they trying to do with that?
Radiation.
Okay. All right. As far as pediatrics, okay, younger kids, are they able to sweat?
No.
Why not?
Because their sweat glands aren't developed.
Right. Okay. So with younger kids, right, their sweat glands aren't as developed, so therefore they cannot, right, generate or lose that body heat. Okay. And younger kids, they just don't know how to shiver, therefore they cannot generate body heat. That's why, again, really young kids are bundled up in the winter, right, and pretty much butt naked throughout the summer to simply radiate as much heat as they can.
wait, is shivering a learned behavior, or is it just...
It's not a learn, it's just they haven't developed the actual. That's why when they seize, they don't seize like tonic-clonic, they just kind of sit there and just do this, and that's it. Alright? So, as far as, I was going to put videos of seizing.
Seizing, there you go.
I do it all the time. Right, of infants having seizures, but a little messed up. So, as far as pediatric BLS, all right, as far as pediatric BLS, okay, definition of a pediatric for BLS is from the age of 1 to showing signs of puberty, whereas for the AED, it's from ages 1 to 8. Okay, if we have an unwitness arrest, right, we do 2 minutes of CPR and then go call for help. Okay, otherwise just use the AED when we get there. Okay, when it comes to choking pediatrics, okay, if we have a conscious pediatric who's choking, Mr. Fox, what do we do?
Peds or infant?
Peds.
Peds, you would... Are they conscious or unconscious?
They're conscious and choking.
You need to...
Okay.
Upwards.
And what about for infants?
You do 5 visualize, so 5 fast close. That would then lead to 5 chest compressions, and you visualize the airway to see if you affected the...
Okay.
The thing that's obstructing the airway is now unmoved.
Okay. What if we do see the object? What do we do?
If you see it, you sweep it out of the mouth.
Okay. What if I don't see it?
And you continue until either they're unconscious or you see the object. You don't do any blind sweeps.
So is there anything else we do?
On a ped or on a...
Just in general.
Yeah, you can continue doing it.
If they go unconscious.
Okay, that's what
Yeah.
I asked you.
Yeah.
Are they still conscious or unconscious? If they're unconscious, then at that point, we would do modified CPR, which would be your compressions. Then before you ventilate, you visualize and see if, then again, the object has gotten unobstructed.
Okay. Do I still ventilate if I don't see the object?
Yes.
Why?
Because you're one of two things. The patient still needs air, so you're trying to shove air in there, and two, there is a chance that it can help dislodge the object, depending on what it is. But it's mainly because your patient still needs air, so you're trying to shove just air down in the lungs.
Yeah, no, I wouldn't say dislodge the object, but
But it can just help loosen it up.
You're trying to shut Kurt down.
Not wrong.
no, I know. But what are we trying to do?
I'm gonna shove it down farther so it can get out the airway.
Okay. So, which one of the main stem bronchi is it more likely to go down into if we were to ventilate?
Right.
Why?
Because your right's bigger because it's got more valves in it. It's got 3 branches in it instead of 2, so your heart's also in the way of that part.
So,
It's easier to go down the right valve.
because it's
More open, it's bigger. It's less compressed, it's easier to go into. There's more space for it. What is it just lower, it's more parallel with gravity because of not they're pushing up on it? You really.
You're like really close.
you are really close.
Okay, I'm gonna start going down the list and then we're gonna hit it somewhere down the line. Because the heart is pushing up against the left one, there's more room in the right one for it to be bigger to allow more air in there because there is more valves in there. So, is it above the left one? Is it just higher up so it gets there first? Is it because it's bigger? Is it because you're not gonna say until I definitively give you a confident answer. That's the thing. Fuck, I know it's there. Don't switch off me, please. See, I told you, like, I'm not sleeping on the job. I'm listening.
Well, if you're listening to our lecture on Wednesday, you would know why it's the right, it's not the
Well,
left.
those times I might have been sleeping. No. It's not that the bronchi are bigger. No, you can't take this from me, please.
That's how this game works.
No.
That's how life works.
This isn't a game anymore, this is a blowout. We're just trying to straggle and not look too bad in front of Matt's eyes tomorrow.
There's no
Just
coming
be
back.
We'll be fine.
They're
Smarter, faster.
Yeah, it's the heart's pushing up against the left valve, so it's harder for it to get into the left valve, the left bronchi than it is right.
But why?
Because the right is.
Okay. Right. Stop. I'm going on the right track. You just said.
So with the object.
Huh?
So with the object, but you got to know why it's going down the right track.
It's higher. No. Not narrow. It's higher.
Where are we at?
Fuck.
Go ahead.
Is it straight passageway?
Right. It's a straighter passage. Okay. So because it's a straighter passage, right, it's more likely to go into the patient's right. Okay. Because again, yes, the heart is in the way, so the left does crook, right, but the right is more straight.
I forgot about that.
Okay.
Clearly.
So yeah. So as far as okay.
With a Steve.
As far as modified CPR, okay, we want to go and visualize before we ventilate. Again, trying to push that object down into one of the main stem bronchi, preferably the right, just because it's straighter. So we'll go ahead and do abdominal thrust for kids, okay, 5-5 visualize for infants, right? As far as infant CPR, okay, if we're by ourselves, we use a 2-finger technique to knock out how many compressions? 30 at a rate of?
120.
No, it's a ratio. Okay, the rate is? Right, 100 to 120. Okay, push it down 1/2 inch or 1.5 inches to 3 or 1/3 the depth of the chest. All over the place there. If we have a partner, we knock out our 15-to-2 ratio using what technique for compressions? Right, the two thumb technique. Okay, whereas for pediatrics, okay, go down about 2 inches. Okay, using either one-hand or two-handed compressions based on the size of the kid. Whatever you feel is a small kid, one-handed. Whatever you feel is a large kid, two-handed. Okay, with our ratios still changing if we have partners. Okay, so for the airway, we use neutral sniffing position, taking a towel, roll it up, place it behind their shoulders, right, to bring that chest out into a more neutral sniffing position. With the OPA, again, we drop it straight in with the help of a tongue depressor to depress the tongue. Okay, so we just go and drop it straight in. Right, measurement though is still the same. Anterior portion of the earlobe or tragus to the corner of the mouth, or the angle of the jaw to the middle of the mouth. Okay, and then just drop it straight in. right, again, NPAs we can use on kids, just not infants, measuring the same way, anterior portion of the earlobe or tragus to the side tip or septum of the nose. Okay, and then we just go ahead and drop it in. As far as rescue breathing, right, going to be done at a rate of 1 breath every
6 seconds for 3 seconds.
2 to 3 seconds. Yeah, we're talking
6
about
seconds
kids.
for adults, I clarified.
Okay. Right. Okay. So we'll go ahead and ventilate at that proper rate. Okay. Again, up until they have puberty, then we switch over to adult rates. As far as the AED, ages 1 to 8, can I use adult pads on a pediatric patient?
Yes.
Can I use pediatric pads on adult patients? No. Okay. So we want to go ahead and just zap the kid, right, following the pad placement, generally anterior, posterior. Okay. As we defibrillate.
What happens if you put it the other way?
Then depending on what it is, it may not work effectively. All right, because some AEDs are what's known as monophasic, others are biphasic. Monophasic goes from one pad to the next and then back again, whereas biphasic shocks together at the same time. So in those biphasic pads, it doesn't really matter. All right, but the AED is not going to be like, I'm biphasic or monophasic. It just shocks. Okay, so
I thought it was supposed to talk to us.
it doesn't say that though. All right. So, as far as ALOC, okay, of course we have that AE-IO tips mnemonic. Whatever causes us to be altered can also cause them to be altered, especially if it has anything to go, right, or do with putting stuff in their mouth. Because kids like to put anything and everything they can in there. Since the number 1 route of poisoning is ingestion, right, okay, super duper common in kids. So pneumonia, again, number 1 medical cause of death in kids. Okay, whereas the number 1 cause of death overall in pediatrics, Ramon,
the number 1 respiratory issues.
right? Okay, head trauma, number 1 killer of kids overall.
Let's go.
Right. So, as far as respiratory issues, again, that is number 1 medical killer of kids. When it comes to asthma, okay, super duper common condition in kids. Okay, as far as medication we use to treat that, of course, it's going to be albuterol. All right. If we don't have albuterol and they don't have epi, then we ventilate. Okay, make sure we turn off the pop-off valve, so all the air that we squeeze, right, is going to create positive airway pressure to open up their main stem bronchi. Okay. But if we don't need to ventilate for that, then we leave the pop-off valve open so we can vent out that excess pressure to reduce gastric distension. All right. As far as bronchiolitis, nothing we can do. Just support the signs, symptoms, just transport. Look out for possible sepsis. Croup and epiglottitis, right? Croup's going to have excessive or epiglottitis rather has excessive drooling. Croup has a barking seal cough. For pertussis, okay, they're going to have that bacterial infection. Okay, just be mindful so we don't catch it and treat the symptoms. As far as dehydration, number 1 cause of dehydration in kids is vomiting, diarrhea. Okay, so we want to ask these questions, right, when it comes to our assessment to determine how severe, right, the kid is when it comes to dehydration. Now, as far as the different stages of mild, moderate, and severe dehydration, Daisy, what are the signs of mild dehydration?
Dry lips and gums, and for moderate, sunken eyes.
So that's all we have for mild?
For mild, there's also being thirsty.
Sorry?
Being like thirst.
George?
It's dry lips and gums, decreased saliva, and wet diapers.
Okay. What about for moderate?
It's sunken eyes, sleepiness, irritability, and loose skin when you check the turtle.
Okay. And severe?
There was full climbing, delayed tap refill, and sunken fontanelles.
What are the fontanelles?
The on the head, front and back.
Okay.
Like soft spots.
I'll find that better. Okay. As far as the fontanelles, what else can they tell me about that infant?
Pressure if they have intracranial pressure.
Okay.
If they have meningitis or other diseases.
So what would they do?
So the pass or both.
Okay. So if an infant were to have meningitis, what are we going to see?
Bulging.
Besides that?
Or feverish symptoms. And yellow skin.
So as far as yellow skin, what condition would cause yellow skin?
Well, he's just looking for a specific disease, an island disease.
There's one question.
Quiet, dude, sounds like-
Oh, whoa, Mr. William here. That is a loss. I'm glad to sleep. You never watched Rick and Morty? What? Watch it. Watch Anatomy of Park.
I never really.
If you watch Anatomy of Park, it'll just like you'll see stuff in only good
Well, okay, that's what it's called. Causes it. You said it. If you didn't say yellow skin, we would have been done. Trust me, my reviews used to be a lot worse. I said my reviews used to be a lot worse.
No.
Like the reviews you could give or the ones you got from Matt?
Who hurt you?
No, I'm just saying, like, questions I would ask.
Like they'd be harder.
That shit
You
was
just lose
dumb.
faith in us, or like what happened there?
It's the fact that I've been teaching online for the last 2.5 years, so I kind of lost my mojo a little bit on that.
Aww. It's okay, Vince. The mojo will come.
Just
She's down with us.
Austin Powers?
Oh my
Why
god.
did you do that?
No? No? Alright, so
I know.
what is it?
It's hepatitis B.
Well, just
It's hepatitis causes jaundice in the skin.
just hepatitis in general.
Yeah.
Right?
Hepatitis
You have it
is
with A
bad.
and C. Right? What else can cause jaundice?
Oh, actually, well, in infants,
Just in general.
and certain infections can. Like they've gone septic. Tell them that. I don't know.
Other than hepatitis?
Mm-hmm.
I thought we wanted to talk about hepatitis.
Any other liver or gallbladder?
Oh yeah.
Such as?
I need
It's one that gets worse when you have fatty foods. That would be gallbladder one.
Would it be when you burn? You get
what?
Bad burn?
You turn.
Huh? What? A burn?
Liver issues like cirrhosis?
Yeah, just general liver issues can cause hepatitis. Okay, so right, hepatitis, okay, with its different forms, right, cirrhosis, okay, things like that, right. The liver starts to go ahead and can't filter stuff out, hence why we started getting yellow skin because of all the toxic buildup in the blood. What's that term for toxic buildup in the blood, by the way?
Hemolytis.
No.
Hemotoxic.
No.
Hemotoxicity.
Toxic in blood. Hemo means blood.
I didn't see that.
Yeah, that's.
Acid dot.
Shut the fuck up. Toxic in blood. Why are you like this?
Because Vince knows you're so smart. Okay, fine. You're dumb.
You're right.
Ow.
Imagine we didn't have our notes, dude.
Cardio, that's a specific.
Daisy.
Blood in the where?
Toxic buildup in the blood. What's it called?
Mm. Toxic buildup. No.
Brett.
I'm thinking. I just keep thinking. Pass.
You're good.
Septicemia?
Nope. Axel. Put your phone away, sir.
And you said toxic, right?
Toxic buildup in the blood, yes.
Almost here.
Darch.
Alkalosis? It's not acidosis, is it? That's just that's correct. Okay.
I know the word, I just need to figure out how to say it.
As long as you're close, it's fine.
Uremia?
Right, uremia. Okay.
Oh, come on!
So uremia, right, toxic buildup in the blood.
I was going to, no, that's something else, and it's, I was thinking hematuria.
No. Okay.
Well, urine.
Right. Okay. So, right, uremia, right, is going to be that toxic buildup in blood, which again may indicate liver problems. Okay. So, as far as fontanelles, right, they're going to be open still up until about 2 years of age. That's the front fontanelle still going to be there. They can sink and or bulge out. So, sunken fontanelles, right, indicate late stage of dehydration because they're running out of what fluid specifically inside of their head?
Plasma.
CSF.
Oh.
Okay, which is mostly made up of water, right? And if they're severely dehydrated, so they won't have a lot of water, they obviously won't have a lot of CSF. Okay, so it tends to sink in. Whereas with meningitis, it tends to bulge out because of that increasing ICP. Just like we'd also see that with head injuries. Okay, so when kids sustain head trauma, if they have the fontanelles that are still open, they may bulge out. Okay, so again, they'll have the nuchal rigidity, photophobia, increasing irritability, right, but no crying.
Is there anything else that would cause pressure to some
No. All right. Now, as far as this rash, okay, that particular rash, okay, here we know what causes it because it's meningitis has gone septic. But what other condition can cause this type of rash?
SIDS.
SIDS. Right. Again, we don't necessarily know exactly why it's there. It just is. Okay. So with this, we're going to be looking out for the other signs of infection. As far as acute abdominal issues, okay, especially poisoning, okay, kids get poisoned frequently.
Mm-hmm. Yeah.
It's usually what?
An accident.
Accidental, whereas in us adults, it's usually
Purpose.
intentional. Okay. Appendicitis, again, more common in kids, so they have what kind of tenderness?
Rebound.
Rebound. So when you push down, does it hurt?
No.
It only hurts when you let go. Okay. Again, they'll have that right lower quadrant pain with fever-like signs and symptoms that when the appendix ruptures, then right becomes peritonitis. So as far as medication overdoses, if they've ingested anything, we can possibly give them activated charcoal. Okay, at a dose of 12.5 to 25
grams.
right, of the activated charcoal, shake it up, and then we go ahead and administer it. As far as seizure activity, okay, with febrile seizures, we have our different treatments that we covered yesterday or something like that. As far as older kids, they're going to have that more generalized tonic-clonic activity, whereas younger kids, again, because their muscles are still developing, they can't actually have tonic-clonic activity. So they're going to have that abnormal gaze with the eyes are looking up in one direction. Okay, eyes, extremities are going to be bicycling, so kind of going in circles with a sucking motion as well. Okay, that's why I don't put videos of seizing babies.
Some mental images.
So, as far as treatment of a kid who's having a seizure, we treat him the same as any other active seizing patient. Protect from trauma. Okay, give him blow by O2. Once you're done seizing, left lateral, suction out airway. Give mask once we know they can maintain their airway. Prep for spinal and transport. So, as far as trauma, right? Do the general trauma treatments change with pediatrics? No. Okay, we follow the same basic things with minor modifications because kids are freaks. So, with their big old fat massive head, they tend to have that lawn dart effect where they may start to pitch head first, land on their head. Okay, we got to worry about those whiplash injuries. Big old bowling ball on a toothpick, right, for their neck. Okay, so we got to worry about those injuries, contra injuries, right? Things like shaken baby syndrome, similar with that stuff as well. So, with the abdominal organs, okay, those solid organs are larger and more anterior and bigger in proportion to everything else. So they're bigger, easier targets, right, for abdominal trauma. Okay, so if you have a kid who goes over the handlebars, okay, do we have to be worried about internal bleeding?
Yeah.
Yeah, because what organs are affected?
All organs.
Such as?
Stomach.
No, whole organ.
Right. Right, the liver and the spleen. Okay, liver being right up over here, spleen being right here. So even if they were to kind of twist a little bit and still hit, okay, they can have rupture in their spleen, causing internal bleeding. Okay, with automobile accidents, again, kids are shorter, so they're going to catch the car higher up, okay, causing more significant injuries. And we go up and over, they go down and under.
Oh, with pediatric female patients, they're obviously not going to be, we're not going to be worried about like bleeding from rectal pregnancy, but can they rupture? Is it still going to be vascular?
Mm-hmm. Yeah. All right. But again, because it's contained in the pelvis, they're more likely to get pelvic injuries first than actual trauma there.
Gotcha.
All right. So as far as older kids getting involved in contact sports, then we're going to start seeing again more musculoskeletal injuries associated with that, and we just treat them the same as anything else. Is this a depressed skull fracture? Yes.
Yeah.
Not sunken fontanelles. I'm going to ask the other question. But okay, obviously that is not a fontanelle since the fontanelles are located in the front and in the back. Okay, so we still have to see all the signs of ICP that we're going to see with adults, but because they have those fontanelles, what are they going to do? If they have ICP, they're going to start to bulge. Okay, with that flexible rib cage, that's what puts them at prime condition for commotio cordis, okay, where the sternum is going to flex in, transfer energy to the heart, spring back out. Okay, and if it happens at the exact wrong time, it puts them in a what rhythm? B-fib, right? And they're pretty much going to drop dead where they stand. So extremity injuries, repeat the same, right? Nothing really too special, just use splints that are sized for that kid. For burns, we have to consider the possibility of child abuse. And if we see it or suspect it, we report it. So there's a rule of 9. As far as drowning, okay, kids are at high risk of near drowning and drowning itself. So we just want to go and treat them as best we can. Okay, maintain C-spine precaution and be careful about hypothermia, especially if they're found in cold water. And they're not dead until they are warm dead. As far as mobilization, just do the best you can. Okay, if they have a car seat that's intact, and the kid is still stable, just like what other spinal device? KED. Okay, we just stuff them into that car seat, right, and just use that to immobilize. But if the car seat is damaged or the kid's unstable, extricate, put them on the board.
Would you be able to use a KED to stabilize a pelvic fracture?
Technically, you can. Right, it's just difficult because we have to find them in certain positions. But yeah, because the leg straps are going to hold and everything, we have the wrap coming around the side. That could be used to stabilize some pelvic injuries. Right? It's probably better. It depends on how we find them. If they're seated, then we use the KED.
Gotcha.
Right? So, as far as pain management, just do the best we can for those kids. Okay, whatever causes shock in us can cause shock in them. Okay, and our treatments are still the same: O2, blanket, and proper positioning. Do they compensate any different?
No.
It's longer, right? But their body will do the exact same things. Okay. So, because their body is just more adapt to tachycardia and tachypnea compared to us, so they just naturally keep on pumping that blood. All right. So as far as triage, where was I at? Okay, sure. All right. So as far as yellow tag triage for a pediatric patient, what is it?
They got this increased respiration cycle. So is it is it if their heart rate is below 15 or above 45? Yeah.
Erica?
Their respiration rate is between 15 and 45. They have peripheral pulse, and they are responsive to.
Okay. As far as red tag criteria, what's considered red tag for pediatric?
Any one. They just their respiration seems to be less than 15 or greater than 45. They do not have spontaneous breathing upon having their airway repositioned if they weren't breathing when we first got there. And then respiratory failure and if they're not responsive to painful stimuli or they react to it weirdly, and then no peripheral pulse.
Okay. What about black tag?
They're about to die, or they're already in cardiac arrest, or they haven't regained a spontaneous breathing upon having their airway repositioned.
Kind of falls under the same things said, but yeah. All right. So as far as start triage for an adult, Axel, what is going to be yellow tag criteria for an adult patient?
They're able to follow commands. They have a pulse, a radial pulse.
Okay.
What?
Yellow tag criteria for an adult.
If their respirations are under 30 breaths per minute.
Okay.
Their cap refill is above 2 or above seconds.
Darge?
If their
Oh,
respiration are under
yeah.
if you have perfusion with radial pulse, and they can follow simple commands.
Okay. As far as the cap refill, what does the cap refill have to be considered yellow?
Like how fast is it? For it to be yellow, it'd be 2 seconds or less.
All right. Okay, so less than 2 seconds. As far as red tag criteria, what would be considered red tag for an adult?
Respirations under or over 30 per minute.
What was it?
Respirations over 30.
Okay.
If you don't have a cap refill within 2 seconds.
Or
Um,
or
32 can do. If it's above 30, if it's above 2 seconds, and if they can't, false commands are there. If not able times 3, then they're protected.
Okay. But what about their perfusion?
It has to be more than 2 seconds. Or no radio pulse.
Right. Because if they don't have a rate of pulse, their blood pressure is less than, which means they're in decompensating
shock.
Right. Okay, so they'd be in decompensating shock at that point, whereas black tag patients,
dead, or they're about to die.
yeah, that's fine. All right, so
That's it. They're about
as
to
far
die.
as our jump start, okay, so green tag again for both peds and adults. Okay, they are the what kind of patients?
Walking wounded.
Right, walking wounded. So they can get up and they can walk, and they can of course follow commands. And then we do a secondary triage where we see if they're still green, yellow, red, or whatever else. They wouldn't be black tag at that point unless they drop dead. As far as yellow tag, okay, breathing somewhere between 15 to 45 breaths per minute, not pulse because that'd be very bad. Okay, if they have a palpable for peripheral pulse, okay, or at their very least responsive to painful stimuli. Okay, red tag again, it's got to be one of the criteria. So a breathing rate that's too fast or too slow. Okay, either they're apneic and they respond to opening the airway or rescue breathing. Okay, they have respiratory failure, right? If they are breathing but don't have a palpable peripheral pulse, or they are having some type of inappropriate painful response. And then black tag patients are again those who are dead or expected to die.
About that.
Oh, why is it for kids we don't use cap refill, but they're peripheral pulse?
Because they don't care about blood pressure, it's about cardiac output.
Well, again, for kids though, they are more reliant upon cardiac output. So their cap refill actually means more. I don't know why they don't use it for jump start. I really bother looking at that.
Done. Bye, man.
No.
No. Damn. Poor guy. Do we still have environmental access too?
Mm-hmm.
Fuck my life.
So, as far as immunology, okay, so again, this is going to be our different bites and stings, okay, as well as anaphylaxis. So, when it comes to anaphylaxis, George, what is it?
It's exactly as an exaggerated immune system response.
Okay, so how is the patient going to present with anaphylaxis?
Urticaria, broncho, spasms, and vasodilation.
Okay, well that's what's happening to them, but how do they actually present? What am I going to see to indicate those things?
Urticaria and pale, cool, and diabetic.
They would be dry, warm, and flushed skin signs with rashes that would be described as hives that would be in this class described as eucardia. Eucardia or is it eukarya?
Urticaria.
Why is it
They would have delayed cap refill.
Well, it doesn't really tell me anything.
And because they're flushed, they would have bradycardia and
bronchoconstriction, vasodilation.
So what are we going to hear with bronchoconstriction?
Wheezing.
Okay. And skin signs would be?
Warm fish dry.
And?
Urticaria.
Urticaria. Okay. And? Possibly. What do we call that if they have a swollen tongue?
Something edema. Lingual edema.
It's actually
That's
not
a
what
good
it's
guess.
called. Yeah, no, that is a good guess.
I buy it.
I would too, but that's not the actual term. It makes total sense. What do we call it? Daisy. What do we call it? They got swollen tongue.
Big ass one or just a small one?
Is there a difference?
Because you can see babies like, I think have a little bit of a angioedema.
Right, angioedema. Okay.
Angioedema.
So, what kind of shock does that fall under?
Angioedema or just
Anaphylaxis in general.
Oh, it's distributor shock.
Because it's a
Uh,
kind of problem.
pipe problem.
All right, it's a pipe problem. Okay. Now, if our patient were to get stung by a bee and the stinger is still in the patient, what do we do?
We can use our fancy little nifty EMT certification card and just pull it and kind of drag it across the skin, push it out, make sure you get the stinger out.
Can you elaborate?
Probably.
Wait, is angioedema the loss of the respiratory?
You want to go, if the finger's looking in the name with this, and go against it so you can push it out without doing any of it, pushing it further.
Right. Okay, so you want to scrape in the direction of travel to go and take it out using something flat and firm like your credit card. No, EMT cert.
Yeah.
Okay. Be optimistic, sir. Okay, I don't want to see you again. So, we'll go ahead and scrape it out. Okay, and flat and firm. No, I'm gonna wait. I'm done. So, as far as taking that out, okay, you want to go and do that again. Don't use tweezers because then we squeeze more venom into the patient and make the problem a little bit worse. Okay. Now, as far as our different types of toxin, what are the two types of toxin?
Neurotoxins and cytotoxins.
Okay. What are the animals that carry cytotoxin?
The brown recluse, snakes,
What kind of snakes?
coral, copper, cottonmouth, and the rattlesnakes.
Brett, what kind of snakes?
Pit vipers.
Okay. So, as far as signs and symptoms of cytotoxin, if the patient were bit by a brown recluse, what would happen to the patient?
Do you want stages, or can I just say like it's going to be like a necrosis of cells?
Sure.
I like necrosis of cells.
Okay, so what are you going to do to treat that?
We just covered it with a dry dressing and wrap it up. And that's it.
Okay, and if they were bit by a pit viper, what do we do?
We're gonna, if we can, try to capture the snake and bring it along so somebody can identify it.
I am 100% doing that.
Okay.
That is going to be the one thing I'm going to get stuck in me out.
Step one.
Step one.
If you're the patient, guys.
Get that bitch.
Snake bite.
The raw snake. Kill it. Snap
If you can't get it to put for a picture. Bring it over along.
Get it right next to the patient. It's like
So we
5
got bit by a
marks.
snake. We can see the marks. We don't want to like touch it or squeeze it. So we're gonna mark where they got bit. Hopefully get the snake. Do we want to keep the area cool? Not ice.
No, so what do you do for a patient got bit by a pit viper?
Or a pit viper, right?
Mhm.
Okay, so if you can calm the patient down.
Really? Calm down, sir. It's gonna be fine.
You guys are, you just were bit by a poisonous snake.
Basic.
You cleanse the
I'm a
area.
basic medic, I promise.
You split to minimize movement. You keep the where venom below the level of the heart,
Why?
so the venom doesn't travel too.
Okay.
Like Keep on moving.
Eh,
Okay, and
doesn't work, but yeah.
you do not add ice
Why not?
because then it's gonna
You want?
because it vasoconstricts and it makes the I don't know, like, I don't know idea. But another thing is you have to watch out for vomiting. That's the last of it that I have.
Can I answer why? It's because your veins or your vessels will constrict. Because it's cold. So
You already said that.
oh, what did you miss? Wait, what did you say?
Vasoconstriction.
Yeah.
What if captain's allowed to just take over?
Yeah, it doesn't matter.
Well, the point's gone anyway. So yeah, you circle it to show if it swells anymore. You can use those, not the real tourniquets, but the blue bands to help not completely cut off blood, but stop blood from going back up. Keep it below the heart, and try and minimize as much movement as possible.
Okay. So, if the patient were infected with a neurotoxin, Axel, what are we going to see?
Inflammation. They're gonna be cramping. It's gonna be a painful bite. Cause paralysis of the nervous system.
Okay.
So
So, what's our biggest concern with that?
they won't be able to fight the infection off.
Okay.
It'll be widespread, like, muscle contraction. So
What's our biggest concern with that?
the heart and the lungs, brain.
George? Right. Because when we breathe, we use our what?
Lungs.
Muscles.
Oh.
Okay? These are muscles, right? Heart's not going to stop, brain's not a muscle. Okay? So they can start having respiratory issues. As far as the animals that have neurotoxins, Darge, what are the animals that have neurotoxins?
Whole snake.
Everything is not a pit viper.
The pit viper?
I'm sorry?
The pit viper?
No.
Oh.
No! Yeah.
Everything
Wait.
that's not a pit viper or brown recluse.
Such as?
Oh, let's say jellyfish. You could have mamba. You could have a black widow.
Black mamba.
That's a poisonous snake. That doesn't.
Not in North
It's not a
America.
pit viper. It's not a pit viper, and it gives. No
I mean, I guess if you're working a zoo.
Yeah, San Diego Zoo could have an outbreak. You don't know. Child could fall in the San Diego Zoo pit.
We don't need another.
Yeah, venomous snakes that aren't pit vipers and usually spiders that don't include the brown recluse, so black widows. You could see things like jellyfish or stingray. So how far do I have to get? Is there a specific one you're looking for? You bastard. Black widows, jellyfish, stingrays. Oh, scorpions.
Right. Okay.
Yeah, we
So,
have scorpions too, I guess.
okay. So, as far as the other, I guess they're insects that don't have toxins. What?
Wasps with yellow jackets. Right?
That's not really what I was going for. Yeah, I mean,
They don't because they don't. They're not like bees. They don't
So
leave a
they're
poison
arachnids,
stinger. They just
not
stab, stab,
insects.
stab, stab, stab.
Yeah. No, it wasn't going
Ants.
for
You can
those.
cause bullet ants. Bullet ants can cause pus.
Yeah, but I wasn't going for those.
Who said?
You let me finish.
No.
Right?
No.
They spread infections.
Oh, I know that one.
What?
Ticks and fleas that can cause the fever.
Kind of fevers.
Oh, fuck, it's like the whack-ass hillbilly fever. Mountain
What?
fever? No.
What is it? George.
Ticks?
Okay. So what do they?
Oh, Lyme disease and Rocky Mountain spotted fever.
Yeah,
Right.
see the whack-ass hillbilly fever.
Still gotta know what they are actually called. Okay.
Nice.
So.
Hipster smoking weed.
So, as far as Lyme disease, okay, what is the quote-unquote classic sign for Lyme disease?
The bullseye pattern rash.
Okay, and in what, I don't know how to phrase it, percentage of the patients who develop Lyme disease?
Say that again?
What percentage with patients that develop Lyme disease are going to see that rash?
What?
Do we need slides?
10%.
I'm just going to ask questions.
Oh, cool.
25.
Oh,
No.
well, wait a second. We have to get through
30%.
More than one less than
we
100.
have to get through our environmental as well. So
Yeah.
I'm
not wrong.
My turn.
Uh-huh.
But did I go by
It
the?
says 30%, yes.
Oh, okay.
He said it was close. So.
1%.
Don't let you try to price this right here.
$1, that's it.
Yeah, I said 25.
35 or 50%.
Which one?
1 plus.
Mine was wrong.
Yeah.
5%.
It's close, but not quite.
Oh.
We won't. So it's gotta be in between.
37%.
Now I'm getting colder.
Oh, and what did you say?
37.
37?
Between 30 and 35.
Okay.
Go. There's an infinite number of numbers between that number.
There's no whole numbers.
Well, they're whole numbers, yeah. Here.
So they I'm gonna hedge my bets and say, you know it. 33.
Close.
I got it.
Is it 33?
Nope. What percentage of people get Lyme disease? And it's between 34 and 30.
Between 30 and 34?
But it's not one of those two.
Okay.
Excluding those.
You got 3 numbers.
You got like 3 numbers.
Yeah.
31.
No, faster!
Right.
Let's go!
Okay. About a third, right, of the patients actually present with that Lyme disease.
Oh, yeah, that makes sense.
Oh, yeah.
Oh.
That was on the slide, though.
It was on the slide.
Yeah.
Let's
I just
say
think
it
that's
was.
important.
I'm going to show you right now. This one.
I'm just gonna say, wow, you look like I could shoot you. Okay, you got Lyme disease.
There it is.
that it?
Yeah.
Bullseye.
Dang. Okay, right, so about 1/3 of those patients, okay, so again, they're going to have that bullseye rash, and we just treat the tick bite just by trying to remove it, okay, grabbing as close as we can, and firmly flushing out
You're
the
telling me
bullseye.
the target dog has had Lyme disease this whole time?
Unfortunately.
So why?
Poor boy.
Why does it make bullseye?
I don't know.
Why isn't it just 4 out? You're my teacher. You're supposed to know why.
I'm not a zoologist.
Well, it's not a zoologist. It's the human body thing. Why is the human body?
Entomologist, not a
That's
zoologist.
true, that is true.
I know.
Wow.
I'm not that either. Alright.
Man, you become a zoologist? How hard is... Oh my
There's
gosh.
no college
You know what I
degree.
found out, by the way? Heads up for everyone. I didn't remember the exact word. But in terms of people that mix the chemicals for pills, it's like a $500 cert, 2-day course.
Pharmacists?
No. The people that mix the pills, like you put the stuff inside of the
Yeah,
capsules.
they're pharmacists.
You could work
No,
at that.
as in the factory. You get paid $25 an hour, and it's a $500 cert course for 2 days. I'd be making more than I would as an EMT.
And what are you still doing here?
I don't know. I heard that made me sad. But I want to save lives.
So, as far as environmental issues, okay, so again, we got our hypothermia, hyperthermia, okay, with the different stages of those different issues, okay, we got to go over altitude issues and diving emergencies, okay. So, as far as environmental issues, okay, again, we got those special patients that don't do so well, okay, those young patients, old patients, sick people, hurt people, okay, they don't do so well in those extreme environments, all right. So, as far as factors we got to worry about, okay, obviously the air temperature, so how hot or cold it is right outside, okay, is going to determine how well or poor this patient's going to do. We also got to worry about humidity as well as wind velocity. Okay, humidity usually for heat problems, wind chill factor for colder problems. Okay, obviously it doesn't have to be super duper hot or cold, okay, to cause those issues, just other modifiers like humidity and or wind, and other variables like age. Okay, with the different heat transfer methods, heat transfer through touch is called conduction, whereas heat loss through circulating air is convection. Okay, then we have evaporation, right, happenings with sweating. All right, radiation and respiration is where we start breathing quickly. Okay, and evaporation as we begin to sweat. Our radiation is coming off the environment. All right, so first things for environmental issues, get them out of the environment. Get them out of the environment. For either heat or cold, just get them out of there as best we can. Okay, and then we do whatever we have to do from there. So as far as hypothermia, okay, it begins at 95 degrees, right, from mild hypothermia, but it becomes severe at 90 degrees. Okay, and as far as looking at the patient, can we tell the difference between mild and severe hypothermia just by looking at them?
No.
Yes.
Yes.
Okay, the severe hypothermic patients are not going to shiver. Okay, whereas our other patients, again, will still shiver. Okay. So as far as everything else, when they start getting severe hypothermia, vitals start going down. But remember, they're not dead until they are warm dead. Okay, so we want to try to warm back up until we can say, all right, that's it, they're done, and then we go and classify them as dead. Or again, if they're frozen solid, then obviously we know that they're dead. As far as vitals, okay, since vitals are slower, okay, we want to go ahead and check heart rate and respirations for how long?
60 seconds.
All right, for a full minute. Check skin signs right here by the abdomen. Okay, and of course they're going to be much more altered as time goes on. If we can, try to reheat the patient, but we have to do it very, very slowly, okay, to try to reduce the risk of that re-warming shock that patients can go into. Okay, so if we can, just get some heat packs, neck, armpit, groin, just like active cooling, but active warming. We don't want to massage extremities in case they have frostbite, okay, because then those ice crystals start rupturing cells even more, causing more tissue damage, okay, which then can lead to other complications like infection and then eventually amputation. As far as our different types of freezing injuries, okay, if they have a superficial freeze, that is frost nip, where if they have the wet freeze, that's trench foot, and a dry freeze will be frostbite, where it goes all the way through that different part. Okay, as far as locations in which they're going to receive these injuries first, usually on the distal parts of the body. So fingers, ears, noses, and any other part that's exposed, okay, that doesn't really have a lot of blood vessels going to it. So we'll try to go ahead and dress these up with dry sterile dressings. Okay, as far as being able to warm them, okay, what was I at?
You're right, Cheyenne, but or you're Ignacio because you did air.
Yeah,
I said something though, right?
That's true, you did. Daisy, what are we going to be able to do to try to thaw this patient out?
Blanket.
To try to thaw out that particular body part. So if they have frostbite on their fingertips.
Is that already gone?
Axel?
Immerse in hot water, temperatures 102 to 104. Dress with dry sterile dressing.
But what else do we have to keep in mind and do while it's in that water?
Can you repeat the question?
When it's in the water, what do we have to do and what do we have to keep in mind?
You have to stir it.
Okay.
And then replace the water when it gets cold.
What else?
In regards to still being in the water?
Mm-hmm.
Keep the water clean.
We already covered placing the extremity in water in 102 and 104, right?
Mm-hmm. And we want to stir it, but what else? Start. Why not? Yeah, exactly. Okay, if it's touching the container, right, it's not going to thaw out because it's not in contact with that water that's somewhere between 102 and 104. Okay, so once we don't do that though, if we have a chance of refreezing, again, we said we'll just dress it up with dry sterile dressings and then go from there. Okay, but we do want to try to thaw it out, right, and then get them out of there. Now, as far as heat exposure, okay, with environmental issues, not fevers, okay, with environmental issues, right, that cause the core temp to get up to 101 degrees, we have different stages, right, of those heat-related issues. So, Ignacio, what are the 3 different heat-related stages?
Would it be heat cramps?
Okay.
And then heat stroke? No, but heat exhaustion and then heat stroke?
Okay, so what are heat cramps?
Heat cramps. It's cramping in the muscles caused by loss of water and electrolytes.
So how do we fix it?
We rest the cramping muscle, replace the fluids by mouth, and if the cramp persists, we'll take them to the hospital.
Okay. As far as heat exhaustion, how can you tell the difference between heat exhaustion and heat stroke?
They can have normal vital signs, or it can be tachycardia.
For which one?
Oh, for heat exhaustion.
Okay.
With decreased blood pressure, they would be cool, with clammy skin.
So why are they climbing with heat exhaustion?
Because they're sweating.
Okay. What about heat stroke?
And in heat stroke, it would be hot, dry, and flushed.
Why?
I don't know, because they're so hot that they can't sweat.
George?
Use the body's been on the floor to try to cool itself down.
Okay. As far as treatment for heat stroke, what do we do to treat it?
Passive cooling or active cooling. Active.
What about LA County?
It's passive, so you just say no.
Okay.
What?
What's our LA County treatment for heat stroke?
Passive.
That's for.
It's active cooling for both.
Right. Why?
Passive for fever,
Yeah. For a heat stroke, you can do active cooling.
Why? Why would I do active cooling here in LA?
What? No county, bro.
County.
Because they say you can use active cooling for a heat stroke.
Oh, why?
Because you need to lower their temperature.
Otherwise?
Otherwise,
Come on, let me see it. Hi.
they're
Please.
well, because the body pressure is going to decrease.
They die.
Wait.
They die. If you don't cool them off, they die.
Ow.
Of overheating.
So what's going to get cooked?
Their inside. Their blood. They die. They overcook. They cook inside. They bake.
What organ specifically?
What organ?
Mm-hmm.
Organ.
Brain.
Yes. Okay. So, right, if they're severely hyperthermic, okay, their brain, right, starts to suffer damage because it gets too hot. Okay.
Would you say
With
again? Hyperthermia. Okay.
Yeah, heat stroke.
Hypo.
Okay, so they get too hot, right? So the brain ends up getting damaged to the point where, again, it leads to permanent brain death, and then patients die. Okay, so that's why we do active cooling. With febrile seizures, okay, with kids, is a seizure itself concerning? No, it's what caused the seizure, right? What caused their temperature to get that high? That's the main concern. Okay, so with heat stroke patients, right, we definitely got to worry about that. Now, as far as patients who suffer from heat exhaustion, what do I do?
That's when they're still sweating. They're not shock yet.
Okay.
You rest them out of direct sunlight or out of the heat source, and you try and replenish as much. Well, you try and replenish their electrolytes and water through mouth, and you try and help them passively cool them off. You don't have to do direct cooling because they're not in shock. So you just try and let them passively cool. Rehydrate them with electrolytes and water and keep them out of the thing that made them hot, so keep them out of sunlight. Or
that's it.
Yeah.
From a shock position, give them folks who, if they need it, you can give them water slowly, or non-burden and drinks so you can soothe, and then passive cooling.
Right. Okay.
Want to shock if they're not in shock? They're not always in shock.
No, you just want to shunt blood back to the core.
But it's boiling blood.
It's still blood.
It's heat exhaustion.
Yeah,
It's not heat stroke.
Don't you
Okay.
get the babies when you're hot?
Not always.
Well, yeah, when you start getting towards heat stroke.
Yeah.
Right, because again, we
But
start
that's
having-
high. Heat
Yeah, we're talking about heat
exhaustion
exhaustion.
is
You felt like shit in the heat, right?
not always.
No, I do.
But you have felt like shit in the heat. Yeah, okay.
You drink water. You sit out the sun. You chill
And you
for a
lay
second.
down a little bit, right?
I sit down. I always sit. I've never had the point where I lay down. I always sit down, drink some Gatorade, some water, get back up, keep going. Don't be good.
But lay down, right, will help you recover faster.
Don't
Okay.
be rich.
You
So-
lay down. Does that really help actually?
Yes. Okay.
I thought it's bad.
Standing is hard for your body.
Yes.
No, sitting. You sit fine.
No, but laying down, right, because the body's going to try to compensate for heat by vaso, which does what to your blood pressure.
Makes it shoot down.
Okay, so if you were to lay down, is that going to increase perfusion to the brain?
Whatever. Yeah. Stupid
Science. Yeah, exactly.
Damn.
Okay.
Damn anatomy.
So, right, as far as our environmental issues, right, we got to make sure we get them out of the heat, okay, to try to cool them off as quickly as we can, depending on the issue. Let's see here.
Oh, look at the old lady EMT. I saw her. She had her glasses on. She was doing real good.
So, as far as drowning, if they drown, they
Dead.
died. Okay, if they nearly drown, they survive for at least 24 hours.
Then they dead.
Right, then they die, or they survive.
They dead.
Okay. As far as drugs and alcohol, got to worry about that in adults and adolescents. Okay, with kids, since they don't know how to swim. Okay, they also at risk of drowning. Okay. With diving emergencies, of course, we have to worry about what kind of injury.
Spinal.
Head injuries.
Spinal injuries.
That's I just said it.
Okay. I know, but
He's looking at me because he knows I'm gonna hit my head.
no, because you didn't know that that's what the no diving sign was.
No, I thought they were suggestatory. Okay.
No, they're not. Okay. So.
And I still take them as such.
As far as diving issues, right, we are going to have to worry about spinal mobilization. As far as mobilization in the water, okay, if we can, we float that backboard under the patient, bring it up, secure them, then take them to the surface, or the shore rather. Again, that's assuming we have the training to go in and do it.
No, we can't use my ATM for you guys.
No.
No, my question was, I thought everyone floated. That's what they were teaching in swim pool. You can float. So how are kids drowning if they can just lie there and float to the surface?
Sometimes people sink. Yeah. Especially if they were to inhale, right? And if their gut glass doesn't spasm, it actually gets in. Yes.
On the bottom.
What level of training does a beach lifeguard have? Like, I have no idea. Like
Can't wait. Can
if
I
you
just show
were
up?
called to a beach lifeguard, would you take over CPR or would you let them do CPR?
As far as CPR, we would do it, right? But since they're specialized in like water rescue stuff like that, they'll handle that aspect of it. They bring it to us, and then we take over primary care.
Do I need washboard as becoming a beach lifeguard, or does that just help?
I don't know.
What if I've
had some
if I
chunkier lifeguards
choose-
as students.
Wait a second.
But yeah, essentially, we take over surface treatment. They take care of anything in the water.
So wait, in the water. So as soon as it gets on the beach, I can show them the sign and say, "Mine now."
Pretty much. Yeah. All right, because like I do get students that are lifeguards. I'm kind of surprised I didn't get any this class. Right. Oh, okay. There you go.
Well, you don't count then.
My beach lifeguard
Yeah.
is like a crazy.
Yeah, my junior, have you not
Yeah,
junior
I've seen
lifeguards?
Baywatch.
Yeah, my sister did.
So,
I saw her, I said, fuck that shit, you whack.
But yeah, no, they usually take care of that kind of stuff, and they usually just have like basic CPR, not BLS. Right? They'll have like healthcare provider, or not healthcare provider, heart saver.
Clear! Oh, they died.
That's it.
Never mind.
So, as far as diving issues, okay, with an air embolism, the patient takes a breath underwater and then
Ascends too quickly.
ascends too quickly without
Breathing out.
exhaling. Okay, whereas the patient, when they get the bends, okay, they're swimming around for a while, okay, and then they rapidly ascend without exhaling. Okay, the difference is where the air bubble gets stuck, right? If it gets stuck in the heart, lung, brain, that is the embolism. If it gets stuck in the abdomen or the joints, that's
Bends.
the bends.
Okay.
Just for this class.
Yeah, I know. Why did?
nitrogen, isn't it?
Yeah, why did
Bends
the
use
slide? The slide said air, and all divers I talked to, they said it's a nitrogen policy. Why did it say
You get nitrogen bubbles in your blood.
Yeah, you get nitrogen levels in your blood.
So why is the slide? So when you showed it the last
Because
time,
that's not
Mostly, most of air is made of
nitrogen. But I'm saying like,
That's it. That's it.
okay, whatever.
Okay.
They don't think we're smart enough.
So, just simplify it. Okay, again, that is a 10th grade level textbook that you guys have. So, yes.
I did in basic bio. They said nitrogen, oxygen.
There should be more pictures.
There should be.
Agreed.
And some pop-ups. Scratch and sniff
You know
pictures.
what? I will make one. You know what?
Yeah.
I will make one.
Exactly. Polonium, Helena.
You when I become when I become Richard and Vince, run that by me again. We'll make our own pop-up scratch and sniff EMT textbook,
Yes.
and I will put it under your name so you get the benefits of it.
So, as far as the difference, okay, time is what we also use to identify the difference. Okay, so with the gas embolism, it happens
Quickly.
right away, whereas the bend happens
Long time.
later on. Okay, as far as management of these patients, we got to get them to a hyperbaric chamber to recompress the patient, and then slowly
Decompress.
decompress the patient. Okay, to get rid of all their air
Yeah,
bubbles.
'cause you just shove them down. Get down there.
Hey, I'm gonna go back down in the ocean and do it the right way.
Why not?
They're probably having a stroke, especially. With
That's okay. Just shove the rebreather on their face and slowly drown them.
Theoretically, you can control all those air
I just want to go home. You're cleaned up.
I want to go home too.
Situation was great.
I have to deal with a bunch of idiots over at Hawthorne for the last 2 days before you guys. So.
What if I tie rocks on them and throw them in the water with a non-rebreather?
It's called murder. Non-rebreather is a crazy seal. So, as far as the super duper high altitude issues, again, we're not going to see a lot of that because it's, again, super duper high altitude. Okay, so high altitude pulmonary edema, cerebral edema, again, happens at 15,000 feet and above. Okay, with that rapid ascension. As far as lightning strikes, whatever happened to them can happen to us. Okay, so again, try not to be the tallest thing around, near the tallest thing around, or near metal. Okay, so try to lay flat, right, and get as far away as you possibly can. Try to get some overhead cover as well. Different ratings of lightning strikes, so mild, moderate, severe. Okay, whereas moderate, again, for some reason, asystole is just okay. And then cardiopulmonary arrest.
They're not like dead.
Yeah, even though it's the one that's not convertible.
Smite it.
So, as far as cardiopulmonary arrest, again, that's going to be severe. We're same deal. As far as treatment, okay, we just try to do the best we can to support treatments. Okay, supportive, treat any type of superficial burns. Yeah, there's dry dressings. Okay, as far as reverse triage, okay, if our patient's undergoing regular triage, okay, and they're black tags, do we do anything about that?
No.
Just black tag and move on. Okay, in the case of lightning strikes, okay, we give them one chance, right, with the AED to try to convert, and if they don't convert, then what?
Dead.
Black tag.
Bye-bye.
Okay, and that's it. All right,
Wait,
so
we having a mass casualty incident of lightning?
when? Yeah, it happens quite a bit.
Really?
Mhm.
Have you had it?
So what are these people like?
Yeah, you
Holding
can
hands.
Bam!
Soccer, for whatever reason, soccer tends to attract lightning.
It's really conductive, so if one person struck, that can like
Soccer
That
field.
sounds so cool. Like, I
Hits the
would,
ground
I
and
would
then
allow
half
myself
the
to be
team
struck by
is-
lightning. Have you seen?
Oh, you would allow.
Have you not seen the people?
That's
Where they have like a zip
I
line?
know a
You
lot
can
of
look
people
at
die from
videos.
lightning strikes, but I just
There's
I
a
think
lot
I
of them.
survived. Like I'm just
Wow.
I think the smite from
Because of the
above would
friction.
grace me
What's up?
with.
Because of
No,
the
it's-
friction that this creates.
I don't know.
I think I did like a really cool
It's
story.
not any other sport. For some reason, it just tends to be soccer. It hits the field, and then half the field just drops.
Wow.
Yeah, I think it's happened maybe like 1 or 2 rugby games, but like 7 or 8
I
soccer
got
games.
struck by lightning 7 times.
That sounds so fucking
Yeah,
dope. Like, I would love that.
terrible.
I'm lightning man at that point.
All right, so.
Why are there dead cows?
Aw.
Is it electric fence? You know, electric fences actually aren't that powerful. I've touched a bunch in my life just to see how it feels.
Yeah, but you're in the
So,
house, so you know.
so if you touch it with one hand, it just causes vibrations. If you touch it with two, it sends like a you feel a line through your arm.
It just explains everything.
Yeah.
Literally.
Oh my god. I've gone on hikes with this paddle, and you touch it, it's like, oh, that kind of feels great. And you go, ooh.
Wow, electricity.
All right, guys. So
You want to make sure bring a light
for
you can see things.
There's not such a thing as does not happen.
So
What would be typical murder if I didn't have a license of an EMT that is no longer besides an EMT?
anyway, so
Even manslaughter?
as far as tomorrow, okay. Again, if you guys got to retake anything from today, obviously coming tomorrow. What time? 10. Okay. So you can go retake those quizzes again. Don't try to come in thinking you're going to take all of your quizzes tomorrow. Okay, before class, try to get them done as soon as you can. As far as tomorrow, okay, we are reviewing your skills. Okay, so make sure you guys are taking the remainder of that time, okay, to practice, because this is your last hurrah, okay, for skills before you guys test out. All right.
Question. So, schools are actually wondering, on Thursday, that's our written exam, correct? So, since the morning class is not there, can we come in really early to practice our skills before?
Really? Nope.
Why?
Because Matt doesn't let you guys do that.
But this is our only time to practice skills. We can't practice it at home. We can only practice it here with
You've
the
had
proper
4 weeks to do it.
We have as well, but we want to get really prepped and make sure. That's some sneaky stuff.
And no, you can't stay after either.
Damn it! You got God.
Okay.
I didn't know my brain worked like that.
Because I knew everyone
It's not that
does
hard.
that.
Well,
So
my question is,
Another one?
I do. Is there anything you could recommend that we do at home practice that we could practice, like what we did?
Run an assessment on your dog, cat,
Right.
child.
or each
My child would not let me home for that long.
As far
The chair?
as
Right down, blow
again,
it.
Thursday, okay, when you guys are done with your exam, you guys are going home. Okay, so however long it takes you, okay, you guys are done, you go home, and then you guys come back on.
How many notes learned?
Just an hour. That's it.
How long?
You guys have 2.5 hours.
Question: how long or how soon will we know our score for that final?
On Friday.
Fuck, like before the skills or after the skills? During the skills. Fuck, 'cause I was gonna say if I failed that shit, I was. You can take it. Oh yeah, for $75.
And you could, but you,
doing a lecture.
Can you retake skills?
Yeah.
Yes.
Oh yeah, it does cost less than redoing a lecture.
How much is
Yeah.
it to redo a skill?
0.
It's free.
When can you redo a skill?
Like you're gonna
On Friday.
So after you do it, you can like after you do them all 12, they go fuck this one, redo them.
Almost as you go. So it's going to be broken into 4 different scenarios, and we'll talk about this more tomorrow.
Also, it is multiple. It's three skills per scenario. It's
No,
small
it's
skills.
not.
There's 12 skills.
So what? So, as far as skills, yeah, if you guys fail a skill, you can retest on the skill up to 3 skills. Okay? So it's usually easier if I just do it on the board since you guys see it.
Yeah.
So, as far as skill fail number 1, okay, you fail it, you can retest. Okay? And if you pass your retest, you're golden to move on to your next skill, and let's say you fail skill number 2. Okay? You can retest, and you're fine. Okay? You can fail skill number 3, you can retest, and you're fine.
You fail
Okay?
skill number 4, you're done.
You fail 4, you're done. Or if you fail a retest, then you're done. Okay? So if this were the case, you don't get to this point. Okay? So
You can't use the other.
no. Okay? So you can only get a retest on up to 3 skills, and if you fail that retest, even if it's only 1 and you fail that retest, that's it, you're done.
Tomorrow, are we going to be going over scenarios, or are we just going to be just
You'll
skills?
see. Okay? So, yeah, that is what your practical final is going to look like as far as criteria is concerned. Okay? Hence why we have been going after you guys and telling you to practice your skills, because all it takes is stupid little mistakes, okay, to make you fail a skill. Another stupid little mistake on that same skill will cost you 4 weeks and all of your money. Okay? So you need to make sure that, again, you guys are using tomorrow, okay, to your advantage, because, again, it is your last hurrah to get through your skills.
Where did you go the trash? I was yelling about this before class. Where can we...
It goes in the dumpster.
Where's the dumpster?
Around the corner. And somebody was late anyways. I forgot who it was. Yes, it was you. Okay. So, yeah, you guys, it's pretty much you walk down the sidewalk, you make a right, you go all the way. It's going to be a little building right over So any other questions about tomorrow?
Will you kiss me?
No.
If I pass.
Yeah, that was fun.
All right, bye, Vince.